वो तो यहाँ पे भी देख सकते हैं चाहे तो। दिखा सकते हैं, ऐसा कुछ नहीं है। नहीं, वो हमारे लिए होगा, वहां के लिए नहीं। वहां पे नहीं होगा, वो हमारे लिए होगा यहाँ पे। तो वही बेटर रहेगा। सेशन खत्म होते ही जैसे ही उन्होंने अपना पीपीटी खत्म किया, उसके बाद हमें पता है क्वेश्चन आंसर्स होंगे, तो इतनी देर में अगले 2-3 1 मिनट में विद इन 30 सेकंड्स में आपको प्रिंट आउट।
1 आवर में पहले 3 टॉक्स होंगे, एक के बाद एक टॉक के बाद क्वेश्चन होंगे
जी।
तो चैट बॉक्स के क्वेश्चन इस पर्टिकुलर सेशन में पॉसिबल है क्योंकि दोनों इन पर्सन मॉडरेटर।
डोंट वरी।
बाकी का ऑनलाइन बात करें 45 मिनट्स के जितने क्वेश्चन आएंगे ये प्रिंट आउट डाल दूं।
मॉडरेटर विल स्पीक ना कि वो क्वेश्चंस क्या क्या है उस हिसाब से। हाँ, मॉडरेटर विल स्पीक।
Put your questions in the chat box. I am just thinking that people sitting here, they have no access to Zoom. How will they read the question?
मैं प्रिंट आउट दूंगा विद इन 30 सेकंड्स और मिनट।
दे दोगे?
हाँ,
जब लास्ट सेशन खत्म होने वाला होगा ना,
हाँ उसी हिसाब से मैं कर दूंगा। एग्जैक्टली, समझ गया समझ गया। हेलो हेलो, टेस्ट टेस्ट 1 2 3।
Rahul? Good afternoon, friends. Welcome for this grand nephrology, that is kidney conference on 5th and 6th of Maharashtra. On behalf of Indian Medical Association headquarters, I welcome all the delegates who have personally come here in our auditorium. At the same time, nearly 400 plus delegates have joined across India for this very important and a prestigious conference which we have arranged. I also welcome all the faculties, those who are present, who have flown in today for the special conference. At the same time, some faculties, moderators, and other seniors will join across India. This is a very important conference on the occasion of World Kidney Day, which is on the Thursdays of March second week. We are observing this, and I really want to congratulate two young educationists and very important faculties also. I must say that Dr. Kshitij Bali, who is a urologist, and Dr. Garima Agarwal, who is a nephrologist. She has come specially from Bangalore to arrange this program. Dr. Kshitij is our joint secretary and urologist practicing in Delhi. And these two have borne the entire brunt of the scientific side of this conference. At the same time, for all the arrangements, very meticulously and very, very pinpointedly, I would say that she has taken. So just in the morning, I have told Dr. Kshitij that your exam starts now. And our examiner is Dr. Vinay Agrawal, sir, our past national president. And he has been looking into this conference right from the day one. And he has been guiding us under the helm of our affair, Dr. Ketan Desai, sir, our chief patron of the Indian Medical Association. I am very happy that the entire conference will be recorded. It will be put onto our website subsequently. Those delegates who have already registered, who have logged in, they will be logging in also. But I promise that the same entire talks will be available on the website subsequently, so that whenever they need it, they can just go there, visit there. And this entire program, there is a software. In the software, our stalls are there, talks will be there. So everything will be recorded and kept live for another 15 days into the platform, so that all the doctors, the link for that particular subsequent program will be sent to you later on. Right now, it is a live link. Subsequently, it will be a conference link, which you can visit it. And I'm sure the benefit all the family physicians will take for this conference. And really congratulate Kshitij and Dr. Garima for taking over. And now I will request both Dr. Kshitij and Dr. Garima to take over from me for the first session and start the program. Thank you so much, Kshitij and Garima. Please go ahead. Please.
Hello, all of you who are here in person and all of you joining us online. Welcome to IMA Kidneycon 2022. I am just going to give a few instructions before we begin our first session. All the speakers are requested to stick to the assigned time. All of you who are in the audience, if you have a question, please let us know or come towards the dais and we will take your questions from here. Every session in the conference is designed in such a way that the session has a few talks. We will finish all the talks of a session and then take all the question and answers. Till such time, the people joining us in person, please come only at the end of the talks for your questions. And all of you who are joining us online, please write your questions in the chat box and we will relay it to the moderators, who will then be asking the questions from the chairpersons and the speakers. So without further ado, I would like to call Dr. Kshitij to start the first session.
Good afternoon, everybody. Thank you, Lele sir. Thank you, Dr. Garima. So we start the session. The first session is Basics of Kidney Disease. I would like to welcome the moderators, Dr. Manisha Dasi and Dr. Lavi Gaur.
Good afternoon, everyone. It's a pleasure hosting the first session of IMA Kidneycon 2022. The first session is about basics in kidney disease. Before I talk about the lectures we are going to have, let me introduce myself and my dear colleague and friend. I'm Dr. Manisha Dasi and she's Dr. Lavi Gaur. We are consultants, nephrology and transplant physicians at Max Super Speciality Hospital, Vaishali, Ghaziabad. So before I introduce the speakers, let's first of all introduce the chairpersons. Dr. Lavi, could you introduce the chairpersons, please?
Very good afternoon, everyone. First, I would like to humbly invite Dr. Girish Tyagi, sir. He needs no introduction. He is the Registrar and Secretary of Delhi Medical Council. He has been awarded many awards, like the Lifetime Achievement Award by the Delhi Medical Association, Doctor of the Year Award by the IMA, Global Outreach Healthcare Award in 2020. He has also been the past president of Delhi Medical Association, Indian Medical Association, and UCMS alumni. So please. Next, I would request Dr. Rajiv Ranjan to come on the dais, please. He needs no introduction. He's a famous physician from Patna. At present, he's also the Honorary Secretary of IMA, Academy of Medical Specialties. He's a co-chairman of Scientific Committee of All India IMA Nation Conference at Patna. He has also been awarded several awards like the Best Secretary Award at All India Conference of IMA Academy of Medical Specialties at Tirupati and President's Appreciation Award at All India IMA Annual Conference at Patna in December 2021. Now I would hand over to Dr. Manisha Dasi to invite the next chairperson.
We also have Dr. Mohan Rajapurkar, sir, who is going to join us online. He is a leading nephrologist, a teacher for almost all of the nephrologists of my age or even senior to me. He's a consultant nephrologist at Mulji Bhai Patel Urological Hospital, member board of governors of the same hospital. He has received many awards and presentations and research publications. It's such a pleasure to invite you, sir, to join online. I don't know if you remember or not, but you were my examiner for my DNB exit exam and I was fretting like hell. But it was an honor to be there, to have been tested by you, and it's an honor today to invite you, sir. I would also request, sir, to introduce the first speaker for the first lecture of the session. Dr. Rajapurkar, sir.
Thank you, Dr. Manisha. I do remember you quite well. And if you don't remember, I did visit your Max Hospital also. So thank you for this kind introduction. And also thank you for asking me to participate in this session. The first speaker in this basics session is Professor Dr. Swarnalatha. She's additional professor and chief of a unit of the Department of Nephrology at the Nizam's Institute of Medical Sciences in Hyderabad. She is the head of the Jeevan Dan, which is a disease donor transplantation program of the government of Telangana. Several best paper awards nationally and internationally, more than 70 publications in national and international journals. She has been an editor to postgraduate nephrology book and other books, and is a reviewer for several journals. I've known her for some time. I'm sure she will do justice to the topic she has been given on how kidney diseases presentations are missed by many doctors. So I request Dr. Swarnalatha to make a presentation. Thank you.
Yeah, good afternoon, everyone. It's my pleasure to be a part of this program. And I would like to thank the organizers, IMA, for having such a wonderful program on the occasion of World Kidney Day with the theme of bridging the knowledge gap. And I would like to thank Rajapurkar sir also for introducing me. It's my pleasure to have you as my chairman. So thank you, sir. Coming to my topic, I've shared my slides. Is it visible?
Yes, ma'am, they are visible.
They're visible, yeah.
Okay. So my topic is the eyes don't see what the mind doesn't know. Commonly mispresentation of the kidney diseases. Yeah, are my slides moving?
Now, yes.
Yeah, okay. So all of us have heard this childhood story of a blind people and an elephant. So these blind people try to hold the trunk, the lug and the tail of an elephant and describe it, in their own terms. But unfortunately, none of them could describe the whole of the elephant. This shows that we actually see through our mind, not the eyes. But having said that, there is a famous quote by the Lawrence who says, what the eye doesn't see, the mind doesn't know, doesn't exist. So it's very important for us to know the knowledge in our mind and also see through our eyes. Particularly nephrology, with respect to nephrology, it holds very good because nephrology is a unique cross-section discipline of medicine with its natural extension. Usually, all the super specialty, it narrows down, but it broadens, but have a limited presentations. That's why it is the mother of all battles, at least in the eyes of nephrologist. And it's very important for all of us to know the common presentation, which is often missed, not only by the physicians, but also by the nephrologist. So here we have an approach towards the same concept with few of the clinical examples. Before going to clinical cases, I would like to discuss what are the common symptoms which are patients present to a department of nephrology. Basically, there are obvious symptoms like urinary abnormality, either oliguria, disturbance in the urinary stream, hematuria, and the other most common symptom being the swelling of the feet and the face. Though we have only few presentations, we have a spectrum of clinical syndromes which represent these symptoms. This can be acute nephrotic syndrome, which is the most common, the clinical syndromic presentation, wherein patients present with the swelling of feet and face in all age groups. Next common being the nephritic, where the patient have the oliguria, hematuria, swelling of feet and face, and hypertension. The other common nephrology syndromic presentation is rapidly progressive glomerulonephritis. Here again, patients present with oliguria, swelling of feet and face, which progresses rapidly to develop breathlessness and anuria. Then we have acute kidney injury, wherein there is a sudden fall in the urine output within few hours to days. Usually, they'll have a preceding illness like a febrile illness or a drug intake or some other, the preceding event would lead into acute kidney injury. Or when patients within the hospital, they have that daily fall in the urine output with increase in the swelling of feet and face, which can easily picked up in the hospital environment. And then we have chronic kidney diseases. These are the patients who initially present with various conditions like nephrotic syndrome, nephritic syndrome, or the AKI or rapid progressive glomerulonephritis, or they have risk factors like hypertension, diabetes. They go on to progress to the CKD. And then we have acute and chronic, wherein these CKD patients, they have an acute precipitating factor like infections, drugs, or some other causes. We do have a isolated hypertension as one of the presentation. It is most common presentation, often missed, labeling it as an essential hypertension. And we also have the asymptomatic urinary abnormalities like microscopic hematuria, subnephrotic proteinuria, which usually is missed, and we need to specifically look at these conditions when we come across with a certain clinical situations. Now coming to the common presentation, let us move on to what are the commonly missed presentation kidney diseases. As I've said, most common clinical symptoms being the swelling and the oliguria. But we have a group of tubular disorders. Usually they don't present with all these symptoms and they are often missed. They have very subtle urinary symptoms like polyuria, or they do present with the other symptoms like weakness, generalized weakness, vague symptoms, or they can present as other system disorders like a weakness of all four limbs. We'll be discussing cases in this category. We also have another category of patients, particularly in youngsters or children, where they suddenly all of a sudden present with a kidney disease. But if you look at, they do have some clinical clues which could have been picked up much earlier. The other category is the interstitial nephritis. Even these patients don't present with the specific symptoms; they present with the vague symptoms, and ultimately land up to nephrologist at a stage of end-stage renal disease. And of course, hypertension, as I said, is one of the misdiagnoses. We often label it as essential hypertension, and we don't look at a kidney being the cause of the hypertension. And we have a group of systemic diseases wherein, like hypertension, diabetes, which are the risk factors for CKD, and slowly they do progress to a kidney disease. So now, before going to the cases, again, I would like to just highlight that, there are simple tests like urinary examination, which is not oftenly, looked at, or even if it is done, we don't try to interpret it and often miss the simple cases present with the kidney manifestations. The other simple test, which is not often being used in the clinical day-to-day practice, is ABG, wherein we can pick up most of the tubular disorders. And of course, the ultrasound abdomen, though we see the sizes, we don't look at the echo texture. And then the other, the abnormalities of kidney, the hydronephrosis, obstruction, or the nephrocalcinosis. So looking at the three basic, the test where we can pick up most of the kidney diseases. I can say more than 90% of the kidney diseases. Now we'll move on to case studies, like one after the other, involving the categories which I have mentioned earlier. The first case is a child with missed hematuria. So actually he presented at the age of 13 years with GI symptoms like nausea, vomiting, loss of appetite. He went on to see most of the physicians and ended up in gastroenterologist, where he was thoroughly evaluated, including the upper and lower GI endoscopies. And during the evaluation, he was found to have a creatinine 10. It's when he was referred to a nephrologist. And with us, he was diagnosed to have end-stage renal disease with a bilateral small-sized kidney and immediate initiation of dialysis. But if you looked at the history, when we probed to the history, he gave a history of hematuria during childhood, and he also had a history of deafness. And when we took the family history, his father also had a kidney disease. So hematuria is a very common symptoms which often missed, and it is defined as 5 to 10 RBCs, 5 RBCs per high power field, and it's very high prevalence of as high as 21%. And we have seen that these patients presenting as isolated microscopic hematuria do go on to develop ESRT at a later stage in life, and it's very important. And in fact, most of the countries, they do a screening during admission to the schools, particularly few diseases like IgA nephropathy, which is very common, and it presents as a microscopic hematuria. Particularly in countries like Japan, they do a screening test and pick up most of the glomerular diseases, for example, IgA nephropathy, by simple doing a screen test for the hematuria. So regarding this case, he had a history of hematuria, and he had all other features which are suggestive of Alport, that is deafness and a family history. So it is like, they usually present as ESRD at a second decade of life to a nephrologist, and then they are initiated on dialysis. But these patients can be diagnosed at an early age. They have a typical presentation of sensory deafness. They have a visual manifestations like lens dislocation. But this is basically a defect in the type 4 collagen and is due to a X-linked disease. These are all inherited diseases. Usually, if you take a family history, we can diagnose even at the time of a birth, because they have this family history and they have this red diaper syndrome, wherein at an age of particularly neonate, they can have a hematuria, and the mother is smart enough, she can pick up this red diaper syndrome. So this is an X-linked disorder wherein father is affected. He will 100% of the females becomes carrier, and none of the males are affected. If a woman is a carrier, then you can see none of the males are, 50% of the males are affected, and 50% of the females, they get carrier. So this is a second case wherein is a child who presented to us with a growth retardation. Recently, we have seen this patient in our OPD. He presented to us at the age of 14 years, and main concern was a growth retardation. So she has been actually taking this child to several physicians and pediatricians. There she was only told that it is because of the malnutrition, and he was put on various supplementation. And then she was also assured that because it's an average height, when both the parents had related to the height of their parents, and it is like normal to have that height. But however, he landed up in our OPD, And when we took a history, he had definitely history of voiding symptoms from the childhood, particularly the nocturnal enuresis. Nocturnal enuresis is one of the common, presentation in childhood, which is often taken as a normal physiological phenomena, and often it is ignored. And he also had a recurrent history of UTIs. And when we have evaluated this child, he had a bilateral dilated tortuous ureters, and creatinine was 10, and MCUG revealed bilateral vesicular urate reflex. He's been initiated on CAPD, and he's awaiting the renal transplantation. Here again is a patient of VUR. It can be a primary or it can be secondary, wherein because of the bladder, usually what happens is the urine from the bladder, it is ejected out, but here it goes backwards into the ureter because of the defect in the vesicular wall. This can be primary because of the defect in the wall. It can be secondary because of the bladder dysfunction, like a neurogenic bladder. So again, the presentation is usually picked up in early age, but somehow it is missed, and usually they present to a nephrologist at a second decade with the end-stage renal disease. Here is the third case of a child with rickets. This is again one of the common manifestation in children. India being low middle income countries with 80% of the population being malnourished, it is very common in a pediatric form in OPDs to see a child with the rickets. So, but however, so you should always look at a patient with a rickets for the kidney disease, underlying kidney disease. So here again is an 8 years old child who was brought with a waddling gait to a pediatrician. It was picked up to have vitamin D deficiency rickets, and he was put on the vitamin supplementation. Further probing led to the history that he had a recurrent history of polyuria and failure to thrive during the infancy. And we did a simple urine examination on ABG, which revealed a metabolic acidosis. And then the urine showed, the glucosuria, and then the aminoaciduria suggestive of Fanconi's syndrome, that is proximal, presenting as proximal renal tubular acidosis and failure to thrive at an early age. And then the eye examination revealed cystine crystals in the cornea. So this is very simple diagnosis. We can just look at the ABG, the urine examination, and then the slit lamp examination of the eye, which can be done in any of the OPD clinic to pick up the diagnosis. So this was a case of nephropathic cystinosis with a hypophosphatemic rickets. So with a simple urine examination, we could have picked up this case. And here is the patients presenting with a knock knees, and the eye examination revealed the crystal deposits in the cornea. So cystinosis, it is a genetic defect in the CTNS gene. So it, depending upon the severity of the mutation, it present at a neonatal age group, infantile age group, to juvenile to adult onset. In the neonate, they usually present as a failure to thrive in the infancy, and then go on to develop ESRT at the first decade of the life. With a milder variants, they can present with only renal tubular acidosis, and then the crystal deposits in the eye. In adult variant, they hardly present, hardly have any of the urinary abnormalities. Predominantly they have ocular abnormalities only. So basically the defect is in the cystinosin, the protein, which is actually helps the cystine moving out of the lysosomes. In the lysosomes, in the disease, it gets accumulated because of the absence, and then gets into what we call as the systemic effects of the cystinosis deposit disease. So here the presentation is failure to thrive in the children, but adults we can also see presenting as the type 2 renal tubular acidosis. So in children, we have to look for all the primary causes like idiopathic sporadic familial cystinosis, tyrosinemia, hereditary fructose intolerance, galactosemia, the glycogen storage disorders, and Wilson's disease. And adults, we should look for the malignancies like multiple myeloma and the drugs, the heavy metal poisoning, and amyloidosis.
Madam, we're coming to the end of our time, so please wind up. We're coming to the end of the
Just
time.
wanted to only emphasize few more such examples. That another is again a middle-aged female who presented with quadriparesis. She was also evaluated. She was been moving to all the physicians, and then landed up in with the neurologist, diagnosing as a hypokalemic periodic paralysis. But she presented to us with a renal stone. Subsequently, we have evaluated and was found to have renal tubular acidosis. So again, this is a type 4 the renal tubular acidosis, secondary to a Sjogren syndrome, presenting at a quadriparesis. So with ABG and ultrasound, we can actually pick up these cases. And this is basically defect in the distal collecting tubule with defect in the sodium potassium ATPase and H plus ATPase ATS channels. So this is how they present. And this is again another clinical patients which are often missed is the young hypertensive patients. These are all labeled as an essential hypertension, and if you don't look at the renal cause, and the renal cause should be considered when there is an presentation with the recurrent episodes of accelerated hypertension, pulmonary edema. So she presented to us like that, and we have evaluated, and we found to have a fibromuscular dysplasia. This is a corkscrew appearance in the renal angiogram. So another group of patients which often missed is during pregnancy-related kidney diseases. So this 30 years old lady who presented to us with a fluid overload with a creatinine of 8. And then when we took a history, she had a history of first pregnancy loss, and then second pregnancy, she had a hypertension. She was never bothered to check her BP again. And she took it as a pregnancy-related changes, physiological changes. But subsequently, she presented with a CKD. And then we should always have a mind about the underlying chronic kidney disease, chronic pyelonephritis, left axis nephropathy, or the glomerular disease like FSGS, MPG and IgA nephropathy, membranous nephropathy, when you are dealing with the patients, pregnancy patients with hypertension. It is also important for the nephrologist to have a collaboration with the primary care physicians, but not only to diagnose a patient which is often missed, but also to screen patients who have a risk factor for kidney disease or who are at risk of kidney disease. American College of Physicians have come up with the guidelines as well. They have suggested that patients with hypertension, diabetes and cardiovascular disease should be screened for the kidney diseases. And not only such patients with high-risk individuals and population-based comorbidities and environmental exposures and genetic factors should also be considered for the screening of kidney diseases. Thank you.
Thank you, Dr. Swarnalata. I'll hand it over back to the chairpersons in the IMA hall to take it further.
Thank you, Dr. Chandralata, for talking comprehensively on the eyes don't see what the mind doesn't know. Now, the next topic is a very important topic. It is all in the urine, practical tips on understanding urine reports. And to talk on this very important topic is Dr. Arvind C. He worked as a nephrologist at Singapore General Hospital from 1997 to 2002. In 2002-03, he joined Sagar Hospital and Bangalore Hospital at Bangalore. He is the past president of Nephrology Association of Karnataka, and he has won National Hellman Social Media Award for the year 2018. Now over to Dr. Arvind for talking on this very important topic. And my request to Dr. Arvind to just stick to the timing, sir. Thank you, Doctor.
So you are muted, so you have to unmute yourself.
Sorry. So I was just saying that it's an honor to speak here at the IMA. Thanks to the IMA as well as to Dr. Garima Agarwal for actually inviting me to speak. So we'll move on to the urine analysis as such. And we do three things when we look at the urine. We do a direct observation to look at the color, order, and consistency of the urine. We look at a dipstick analysis to look at certain things in the dipstick. This may include stuff like protein, glucose, ketones, nitrites, and leukocyte esterase. We do a microscopic analysis. It's quite important to look at the sediment, to examine for red blood cells, WBCs, epithelial cells, casts, and so on and so forth. Not able to move my slide. Okay. How is urine collected? The collection should usually be a midstream clean catch in a clean and dry container. Clean the external genitalia first. In indwelling catheters, make sure you collect directly from the catheter tubing and don't go to the drainage bag. If you do collect urine, make sure you examine it within 2 hours of retrieval of the urine. If that's not feasible, refrigerate it at 2 to 8 degrees and then rewarm it to assess. This is quite important. So I'm going to look at certain urine tests of patients of my own, and we are looking at this urine examination. When you look at urine, you look at 2 or 3 things. One is the glucose and protein, And secondly, the microscopic examination for leukocytes and RBCs. This is what our focus is on, but each and every print on that printed urine report is quite important. You look at the color, you look at other things as well. Here is the urine of one of my patients who came in with leg swelling and facial swelling, had RBCs which were numerous in the urine, but remember the color was pale yellow. So this patient actually was actually a diabetic, but actually had microscopic hematuria. Microscopic hematuria is defined as hematuria that is not visible to the naked eye, but is visible under the microscope at greater than 3 RBCs per high power field. So this is a microscopic diagnosis. The patient had some degree of proteinuria. Being a diabetic, when you see some proteinuria as well as RBCs, you're a bit worried and you would want to do a biopsy. We biopsied this patient and found that the patient had IgA nephropathy. So important for us to know that in diabetics who come to us with some degree of urine changes here, the RBCs were numerous, you would want to actually look further, quantify the urine protein, and then go ahead and do a biopsy if you want to. When you have macroscopic hematuria, this can be of two types. One, cola-colored urine that you're seeing here. This can happen in post-infective glomerulonephritis, other nephritides as well. You can get this sort of a red color in the urine, hematuria that is really, red in color. But all that is red is not blood. So that is quite important for us to know. When you are worried that the red color urine does not translate to red blood cells, the simple test that you would do is look under the microscope. And if you don't see red blood cells, then you're obviously inclined to say that this is not hematuria. What else is it? So if you take a centrifuge of the urine, if you see sediment which is red, that is hematuria. If you go to a supernatant that is red, that is the top column of the sediment, then you go to a dipstick heme test. When you do a dipstick test, you find that there are other causes, including myoglobin and hemoglobin, beta-urea, porphyria, and so on. If you look at the plasma color of this, not sure you're able to see my pointer. Let me just get the pointer options here. Yes. So if you see the plasma color here, and then you see whether the plasma is clear, you go to myoglobinuria, and if it's red, you go to hemoglobinuria. Different varieties of urine color. Usually yellowish is normal urine. A clear, transparent, light yellow is well hydrated. Dark yellow is probably dehydrated. You're looking at red colored urine, which is definitely something that you would want to consult a GP. There are various other shades of urine that can happen, including orange, green, blue, and so on. These are the categories that we look at. I'm not going to go into the detail of what is what. You can have my slide deck to look at these differential diagnoses for the different colors of urine. And this is not just in charts. We actually see it. This is a urine of a patient, of a tuberculosis patient who's on rifampicin. So you see the orange color. This is a patient of mine, a photo of which I took 2 days ago. This is called the purple urine bag syndrome because of certain changes in the indole content of the urine that changes the color. Green urine can also be seen in pseudomonas and so on and so forth. Now, if you're worried about the urine, and you're looking at blood cells in the urine, you need to decide whether the blood cells are coming from the kidney or they're coming from the lower urinary tract. And you can actually make a diagnosis of that by doing a simple microscopy test called the urine phase contrast. The urine phase contrast will then tell you whether there are acanthocytes, which are basically misshapen RBCs that you see here. And these misshapen RBCs is because they traverse around the tubules, different osmotic forces play on it, and the urine is misshapen. The blood cells in the urine or the RBCs in the urine are misshapen, and you call them dysmorphic RBCs. If you have dysmorphic RBCs, you're pretty sure that this patient has a glomerulonephritis or a kidney disease that may require a biopsy. You follow it up by looking at the urine and you pick up a urine RBC cast, you're pretty sure then that this patient has a problem like a glomerulonephritis. This could be an IgA nephropathy, post-infective, vasculitis, and so on and so forth. Suppose you look at the urine and you find these monomorphic, eumorphic forms of RBCs that are there scattered throughout this picture, except for these two cells, which are actually WBCs and slightly larger than the RBCs. If you see these monomorphic forms, then you're sure that the urine is coming from lower down, the lower urinary tract. And therefore, that is anywhere from the pelvis, ureter, as well as the urinary bladder. So if you're looking at the lower urinary tract, you can look at prostatic problems like prostatic cancer, bladder malignancy, radiation, cystitis, stones, and so on and so forth, that can give rise to eumorphic hematuria. Let's go through one more report here. You have this young gentleman of 20 years old who came in with leg edema and facial puffiness again, and you have a urine albumin that is 4+. When you see a urine albumin that is 4+, you're worried that something is happening. Obviously, you're also seeing some pus cells and RBCs in the urine. Now, pus cells and RBCs in the urine are important in glomerulonephritis as well, and should not lead you into a wrong path where you are now considering urine infections. My suggestion to most people who look at urine reports are eyeball the patient first. If the patient has come in with leg edema, facial puffiness, and you have this report, look for a glomerulonephritis, a nephrotic syndrome. If the patient, on the other hand, has come in with something like fever, chills, rigors, and you're going to look at the urine report then very differently. In this patient, we quantified what is called the urine protein creatinine ratio. That is a timed urine sample which shows a urine protein level of more than 7 grams, which basically then means that this patient has nephrotic syndrome, and he was treated for that. When you consider nephrotic syndrome, you look at various categories. You look at the commonest points. You look at minimal change disease, focal segmental glomerulosclerosis, which is what this patient actually had, membranous nephropathy. In diabetics, you would definitely look at diabetic kidney disease as a possibility. If you're looking at proteinuria, you need to quantify the proteinuria, and the quantification of the proteinuria is usually as microalbuminuria, where it is 3 to 300 milligrams per 24 hours, or overt proteinuria or macroalbuminuria, which is greater than 300 milligrams, right up to a gram, 5 grams, 10 grams, and so on. The new terminology on proteinuria includes moderately increased albuminuria for microalbuminuria and severely increased albuminuria for overt proteinuria. Proteinuria itself can be transient, therefore you need to be careful when you assess urine reports. Every urine albumin infusion or vasopressor infusion. But the usual proteinuria we are looking at is glomerular proteinuria. You can get overt proteinuria basically because of myeloma, and overflow proteinuria can happen in these cases. Myeloma, hemolysis, and rhabdomyolysis, you can get overflow proteinuria. Be careful here because some of the dipsticks may not actually capture this proteinuria. You will have to do a urine examination followed by urine protein electrophoresis or serum protein electrophoresis to catch this. How would you measure proteinuria? You would want to do a 24-hour urine protein collection. That is the gold standard. You would want to do spot urine samples of a urine albumin creatinine ratio or a urine protein creatinine ratio. The protein here is a mix of the albumin plus tubular protein. Urine albumin is a better judge because you're looking at glomerular disease. You would want to perhaps measure urine albumin. Here's another patient who came to me with fever and chills. We measured, we looked at the urine report. Obviously, urine albumin is 1+, but again, that is not the focus here. The focus is fever with chills. And here you see pus cells were numerous. So you're now in a situation where you're looking at a urine infection. Don't get misled by the albumin in the urine. You can get small degrees of albumin being positive in patients who have urinary tract infections. In a patient with urinary tract infection, you would look at the turbidity of the urine. The turbidity can range from clear to very cloudy. Cloudy urine can be a cause, one of the reasons for urine infections. But apart from urine infection, you can also get crystals or chyluria that can present with cloudy urine. You can get contamination by genital secretions that can also give rise to turbid urine. So turbid urine does not always mean urine infections. Therefore, you would look at white blood cells in the urine. The clinical microscopist usually looks for neutrophils and eosinophils. Eosinophils have receded now in importance. Neutrophils are intermediate in size compared to RBCs. Renal tubular epithelial cells may also be present. So this is something that you'll have to look at. When you look at urinary neutrophils, you can get pyuria that could be related to urinary infection. You can get sterile pyuria as well. Here is a patient who came with this urine infection. You can see a cast. You can see an outline of the cast here, and all these WBCs with their multi-lobed nuclei that you can see here trapped within the cast. And this is characteristic. WBC cast is characteristic of urine infection. Pyuria can be seen in the urine, and that is a hallmark of urinary tract infections, defined as more than 10 or more white cells per cubic millimeter, or 3 or more white cells per high power field. You can get a urine dipstick test that is also positive for leukocyte esterase in these patients. If you do have urine WBC predominance or numerous pus cells, or pus cells in the urine more than 5 or 10, like the definition said there, you can then do a urine culture. If the urine culture is positive, you're pretty sure about treating the patient with an antibiotic based on the culture report. If the urine culture is negative, you would want to look at sterile pyuria as one of the causes. Genitourinary TB tops the list, but you can get fungal infections, viral infections, sexually transmitted diseases. You can get foreign bodies and stents. You can get urinary fistulae, polycystic kidney disease, transplant rejection, as well as intrinsic renal diseases such as interstitial nephritis and analgesic nephropathy that can cause sterile pyuria. Here is another urine report that I'm not too fond of. Everything is normal in this urine report. You can go through the microscopic examination.
Dr. Arvind, please try to finish it up, sir.
Almost there. Bacteria of 21, don't look at the bacteria in the urine. Epithelial cells, very important for renal tubular epithelial cells. They are much larger than the other cells and can be seen in transitional cell carcinoma, where transitional epithelial cells appear in clumps. Renal tubular cells can be seen in ATN and other tubular diseases. Urine dipsticks is a good method of screening for blood as well as protein in the urine, but you need to be careful that you may miss out some of the myeloma type of proteins when you do urine dipsticks examination. Crystals, I'm not going to go into great detail. Calcium oxalate, triple phosphate, coffin lid, as well as cysteine crystals that appear hexagonal. All in all, urine is a very important examination. And this quotation by Sean Elliott, who is a professional basketball player, I'd like people to know that you can ward off kidney disease, maybe prevent a transplant or stop the disease in its tracks from progressing after detection by doing a simple urine test in the doctor's office. Thank you.
Now, I think after this, before the starting of the next talk, I must congratulate and thank the IMA stalwarts for this great initiative to educate and enlighten the primary care physicians of the country, because it is a grim statistics that hardly 10% of the patients, kidney patients, get exact management in time. 90% of the patients get faltered. And I think this session will be a torch-bearing session for educating all of them. I am personally obliged to Dr. Vinay Agarwal, who has invited me at chairing this session. And touch of Dr. Vinay Agarwal is always a golden touch, who makes all the programs a great success. Dr. Vinay Agarwal, kindly give a clap of hands, please. Now with this background, I must tell you the credential of the stalwart, the speaker stalwart is going to speak on this, Dr. Rajesh. I think he's professor in the Department of Nephrology and Kidney Transplant Services. He is affiliated to Amrita Institute of Medical Sciences, Kochi, Kerala. 20 years of teaching experience in nephrology. Former executive committee member, Southern Chapter ISN, peer reviewer, Indian Journal of Nephrology, invited faculty in national and international nephrology meetings, publication in reputed nephrology journals, and organizing chairman, ISN Southern Chapter Conference 2022. With this sound credential, and particularly as a physician, we just know very, very superficially that nephrotic syndrome is just gross proteinuria more than 3.5 grams per. Nephrotic syndrome is having the hematuria, proteinuria, not in that tune, hypertension, hyperlipidemia. I think with his erudite talks, everything will be crystal clear and will be highly benefited. Dr. Rajesh, sir, start your talk, please.
So you have to open the PPT. We can see your Zoom right now. Okay. If you minimize this. Yeah. Now you have to make it full screen.
Yeah.
Then you can carry. Yeah.
Hope I'm audible.
Right, sir, you're audible.
Well, thank you very much for the kind introduction, and I'd like to thank IMA and especially Dr. Garima for inviting me to give this important lecture in the context of maybe the World Kidney Day which is coming up. So I'll probably try to be very basic in my approach. I'll just give an overview of what is glomerulus and what do you mean by glomerulonephritis. Understand the various syndromes of nephrotic, nephritic, and other glomerular syndromes, and how to evaluate a patient with these syndromes, and when are you supposed to refer the patient, especially for kidney biopsy. I'll start off with the case. It's a prototype 8-year-old boy with one week history of swelling around the eyes and legs, and he has his mother has noted that there is significant froth in the urine. Dr. Kanji has highlighted that froth and presence of proteinuria. Examination shows that patient has significant edema, blood pressure is okay, his urine albumin is 3+, his serum albumin is low, and his creatinine is normal, and he has high cholesterol. The diagnosis is fairly straightforward. It is a nephrotic syndrome. So that is the classical periorbital puffiness in the pedal edema, which is pitting in patients with nephrotic syndrome. What is a glomerulus? Glomerulus is nothing but a filtering unit in the nephron, which are basically unwinding capillary loops with basal membrane, which allows passage of protein-free filtrate down the nephron. That means the filtrate which is coming down the nephron is free of protein. What is glomerulonephritis? It is nothing but inflammation or damage of the glomerular basal membrane, resulting in altered function, which is often immune-mediated. I'm not going to the mechanisms, the complex pathways of immune-mediated dysregulation in glomerulonephritis, but suffice to remember that it's an immune-mediated process. It can present with nephrotic syndrome, it can present with a nephritic syndrome, or there can be an overlap. It can be in various combinations. Just to highlight the glomerulus, there is a capillary loops, the glomerular capillary loops there, the proximal tubule on right side, the vascular pole on the left side. We can see the afferent arteriole, we can see the efferent arteriole, we can see the parietal layer which is lining the Bowman's capsule, we can see the visceral epithelial cells outlining the GBM and the mesangial cells and endothelial cells. So this is the basic structure of the glomerulus. Going further in relation to the glomerular injury, it is very important to understand the major determinant of whether the patient presents with the glomerulonephritis will be having an active urine sediment. As Dr. Kanji said, nephritic syndrome, patient is having hematuria. It can be microhematuria or macrohematuria, or with proteinuria. Proteinuria is predominantly nephrotic syndrome. Is basically dependent upon the site of glomerular injury. specifically telling the glomerular cells which are targeted. So we know that there are three major types of resident glomerular cells: the epithelial cells, which are visceral and parietal, the endothelial cells, and the mesangial cells. You can see here that the parietal epithelium, this is the visceral epithelium, which is shown here, and the podocyte, which is extending, the foot process of the podocyte, which is extending outwards. This is the endothelial cell, and this is the mesangial cell. So in patients with inflammatory inflammation-mediated glomerulonephritis, there will be significant infiltration or proliferation of these resident cells, along with infiltration of other neutrophils and macrophages into the glomerular apparatus. So that is how a glomerulonephritis with inflammatory background develops. So a mechanism of immune injury can be inflammatory or non-inflammatory. So inflammatory means, yes, the glomerular infiltration, I said, with significant neutrophils and macrophages. They are foreign cells, plus proliferation of resident glomerular cells, which I have discussed, leading on to the RBC and RBC cast urine, which is shown below. What is the other mechanism? It is a non-inflammatory glomerulonephritis. Non-inflammatory glomerulonephritis means there is an injury to the glomerular podocyte. It is definitely immune mediated, but the associated functional changes will result in increased glomerular permeability to albumin and other proteins. So basically, it is a non-inflammatory form of glomerular disease which presents nephrotic syndrome. There is little or maybe no hematuria, and there are no RBC cast. The prototype is minimal change disease and membranous nephropathy, which classically presents with significant nephrotic range proteinuria. This is called non-proliferative form of glomerulonephritis, whereas the first, which I have discussed, the inflammatory form, is called the proliferative form of glomerulonephritis. So this is a basic approach which we need to keep in mind before we discuss further. It is very unfortunate that renal disease is present in a very confusing, and it can actually present in various forms. Look at this. You can present just like asymptomatic. Patient have just a proteinuria maybe of 150 to 300 milligrams. Patient can have an isolated microhematuria. Patient can have recurrent macrohematuria, especially in IgA nephropathy. Patient who is having recurrent patient has pharyngitis, and then patient has hematuria. That is a classical presentation of IgA nephropathy. This boy obviously had a nephrotic syndrome. The other presentation is a nephritic syndrome. Patient can have a rapidly progressive glomerulonephritis, and patient can have a chronic glomerulonephritis, which is patient has a CKD with hypertension, renal impairment, and proteinuria may be in nephrotic range, and the kidneys may be shrunk and smooth. So all these presentations is possible in any patient with CKD or any form of nephrotic or nephritic picture for that matter. So it is not very compartmentalized. A patient with nephrotic syndrome can have microhematuria or macrohematuria. A patient with nephritic syndrome can have sometimes proteinuria ranging to nephrotic range. So all these factors has to be looked into before you arrive at a diagnosis. So it can be asymptomatic, it can be recurrent macrohematuria, it can be a nephrotic syndrome, it can be a nephritic syndrome, it can be a rapidly progressive glomerulonephritis, and it can be a chronic glomerulonephritis. So this is a very important slide I thought I would like to highlight. Now, nephrotic syndrome is very simple. Patient is having massive proteinuria more than 3.5 grams in 24 hours. It's for adult. The child, it is 40 milligram per hour per meter square or 50 milligram per kilogram per day. This is very important because a child coming to you, you look at the protein and protein is more than 1 gram or maybe 1 gram. You say that there is not nephrotic. No, the child's weight has to be assessed. So 50 milligram per kilogram per day, more than 50 milligram per kilogram per day or 40 milligram per hour per meter square is nephrotic for a child. Hypoalbuminemia less than 3.5 and edema. That's the triad. And if you have a lipiduria and hypercholesterolemia also, then it is a pentad, and that's a classical nephrotic syndrome you see in a child. Coming to this case 1, this child is 8 years and there are no atypical features. That means there is no hematuria, there is no hypertension, there is no renal dysfunction, the GFR is okay. So basically this is a straightforward, simple nephrotic syndrome. So most likely you are dealing with a minimal change disease, wherein you do a kidney biopsy, there will be nothing but from effacement of foot process if you do in the electron microscopy. In light microscopy, it will be normal, immunofluorescence will be negative. So corticosteroids can be initiated without a kidney biopsy. So there is no need for kidney biopsy in this patient, especially first onset nephrotic syndrome. The patient is likely to respond to steroids, and presumptively we can treat as minimal change disease. But strategy is going to be different if it's an adult who is complaining of frothy urine, or maybe elderly lady with multiple comorbidities and significant systemic issues. So the strategy will be different in such situations. Now, I'll spend a few minutes on this slide. What are the common diseases which can present as nephrotic syndrome in adults? As I said, it can be minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy. In the middle, we can see that there are certain associations which is likely to be there with these diseases. These associations will tell you that probably this patient is having a systemic disease. Probably there is a cause for this. So it is very important to look at all these associations when you have a patient which is likely to have a disease which is depicted in the first column. So MCD is usually associated with allergy. It can be associated with Hodgkin's disease, especially in adults, and it can be associated with sometimes drugs. NSAIDs can produce minimal change disease. FSGS also has its own associations. Membranous nephropathy, it can be usually, membranous nephropathy is usually idiopathic, but can have secondary causes, which is close to 20%. It can be infections, it can be again drugs, it can be SLE with lupus nephritis, it can be a malignancy, especially the breast, lung, and GI tract. So membranous nephropathy is idiopathic usually is an 80% and 20% is secondary. But mind you, membranous nephropathy in elderly, the possibility of a secondary membranous nephropathy is more likely because the possibility of systemic disease is high. One word about the anti-PLA2R antibody. This is one thing, the anti-phospholipase A2 receptor antibody. This has come up in a big way as a marker for primary or idiopathic membranous nephropathy, to the extent that if you have an anti-PLA2R antibody positive, probably we can think of holding biopsy and diagnose membranous nephropathy in patients with a nephrotic range proteinuria with no atypical features. So this is, again, this is a non-proliferative glomerular disease, MCD, FSGS, and minimal change disease with these associations. So we'll be evaluating with the serological test in this line. What about MPGN? MPGN can present with nephrotic with a nephritic limit usually, because there is a proliferative glomerular nephritis there. So usually there's a nephritic. And the C3 glomerulopathy, which has come up in a big way recently, I'm not discussing that. So MPGN and C3 glomerulopathy usually presents with a nephrotic or nephritic presentations. And looking at the complement also, we can have a fair idea that you're probably dealing with the type of MPGN, the complement levels. Now, coming to the last part of this chart is the, again, non-proliferative glomerular disease. Again, these are systemic diseases. Amyloid, which is associated with the multiple myeloma. So we have to look at plasma-free light chains, serum protein electrophoresis, and all those evaluation in line of a plasma cell dyscrasia. Any other systemic disease like rheumatoid arthritis, inflammatory bowel disease, bronchiectasis, all these need to be looked into. And the last but very important is diabetic nephropathy. Of course, diabetic nephropathy can present with nephrotic syndrome. If there is an atypical feature, like a patient is having microhematuria, patient is having a progression of renal failure, which is not in line with the natural history of diabetic nephropathy, then probably you are justified in evaluating with the kidney biopsy. For the otherwise, diabetic nephropathy is a fairly straightforward diagnosis. You don't need a kidney biopsy for evaluation. So this is a chart which clearly depicts fairly the basics of a patient presenting with nephrotic syndrome in adult. Okay, so the evaluation we need to do in this. So I'll re-emphasize, all adults with nephrotic syndrome will need a biopsy with certain exceptions. Of course, children, generally we can give a trial of steroids, whereas in diabetic nephropathy, if it is quite evident, there is no need for biopsy. So diabetic nephropathy can be, the diabetic kidney disease is basically a clinical diagnosis, there is no need for biopsy. I'll come to diabetic nephropathy after one more case. Now, since I've shown nephrotic syndrome, now the next prototype is an acute nephritic syndrome. Again, a male presenting with an abrupt onset of, usually the nephrotic syndrome, acute nephritic syndrome usually presents with abrupt onset of edema. Usually it's a facial puffiness. Peripheral edema may not be very significant because basically it's salt and water retention, and patient can present with sudden hematuria. This boy presented with sudden hematuria with cola-colored urine. Dr. Kanchi has already shown the color of the urine, and he had pyodermal lesions 3 weeks before. He is hypertensive, he has a renal dysfunction, his creatinine is 2, his albumin is okay, urine showing 2+ protein, maybe not in nephrotic range, but RBC is 80 to 100, so he has microhematuria. So what is a glomerular syndrome he is fitting in? It is very clear it's an acute nephritis or acute nephritic syndrome, or otherwise called acute glomerular nephritis. All these can be used synonymously. So look at this urine, this is a coffee colored urine, the RBC cast. And nephritic syndrome is defined by hematuria with or without RBC cast. RBC cast may or may not be present, but if RBC cast is present, then it is pathognomonic of a glomerular proliferative pathology. Hypertension because of salt and water retention. Patient may be oliguric because patient is having a renal dysfunction also with salt and water retention. Acidemia, renal dysfunction may be there. And proteinuria is usually not in the nephrotic range, and proteinuria is also associated with that. So that is a classical acute nephritic syndrome. So we have discussed nephrotic syndrome, we have discussed acute nephritic syndrome. Now, what is the differential diagnosis in nephritic syndrome? Even though we said the prototype is post-streptococcal glomerular nephritis, often, actually, this is not very common of late. PSN or post-streptococcal glomerular nephritis is followed by a 3 or 4 weeks of an antecedent period of pharyngitis or impetigo. Again, it is an immune complex mediated disease. Immune complex gets deposits in the kidney and produces an inflammatory reaction, forming a proliferative glomerulonephritis. Evaluation in the form of ASO titer, septicemia antibody. I'm not going to the details. So post-septicemia glomerulonephritis is off late. It is over a period of time, the incidence of PSGN has come down. So going back to the other post-infection, other cause of nephritis syndrome are infective endocarditis, abscesses, shunt nephritis. All these are the issue. The background will be quite obvious because patient is infective endocarditis, patient is having a proliferative glomerulonephritis. The background will be very obvious. Whereas the last two is very important because all said and done, the commonest cause of a glomerular disease, which is presenting with a CKD, which is presenting with a microhematuria, presenting with a macrohematuria, recurrent macrohematuria, is IgA nephropathy. I emphasize IgA nephropathy is the commonest cause of a glomerular disease presenting with micro or macrohematuria. So that has to be always borne in mind. Usually the hematuria is synpharyngetic. There is no gap immediately after the respiratory infection or the gastrointestinal infection.
Dr. Rajesh, sir,
yeah,
I'll have to ask you to wind up the session soon.
Yeah, fine.
We're
Okay.
already out.
Yeah.
Thank you.
So these are the basic differential diagnosis of nephrotic syndrome. Now, a simple chart which looks at patients who are how to differentiate nephrotic person. I have already discussed all this. In nephrotic, it is basically the edema will be insidious, in nephrotic it will be abrupt, and all the other features which I have discussed. Now coming to diabetes. Probably this is a most common issue which all of us face. This patient is diabetic with history of micro and macrovascular disease, and he has a stable GFR for the last 1 year. He has retinopathy. So there is no need for biopsy to confirm. But yes, biopsy is needed only if the patient is having atypical features, like short duration of diabetes, there is no retinopathy, there is a massive proteinuria, low complement levels, and persistent microscopic hematuria, making us feel that there is something more than a diabetic kidney disease. RPGN I'm not discussing because my subsequent speaker is discussing that. I'll just rush through the causes. IgA nephropathy I've discussed. Now I'll just wind up by giving you an idea of how to follow up, how to go about in a patient with hematuria and proteinuria. So if patient is having hematuria or proteinuria or both, is the patient having a glomerular hematuria? If the patient is having a glomerular hematuria, the next question is what is the amount of proteinuria? You have to quantitate the proteinuria. If it is more than 500 milligram per day, patient is having a declining kidney function, and there is evidence of a systemic disorder, one of those is there, then probably we have to go for a nephrology consultation and kidney biopsy, because this patient is having a most likely a proliferative glomerulonephritis with the ongoing inflammation which can progress to renal dysfunction. So this patient needs a biopsy. Now, what is a differential diagnosis based on the biopsy? I'm not going to the details. Based on the immunofluorescence, that we can actually differentiate the various diseases. Now, if it's a glomerular hematuria and there is no evidence of proteinuria more than 500 milligrams, the GFR is okay, there is no evidence of systemic disorder, what do? Keep the patient on follow-up. Routine follow-up every 6 to 12 months.
Wind up, please.
Yeah.
Constraint of time, sir.
I think this is my last slide. If there is a nephrotic syndrome, obviously patient will need a biopsy. And if there is no nephrotic syndrome, then patient's subnephrotic proteinuria patient needs to be on follow-up. But if there is a reduction in GFR with a subnephrotic proteinuria, again we will need a kidney biopsy. So a high index of suspicion is needed in patients with glomerular nephritis. It can present in varied forms, nephrotic, nephritic, or mixed presentations. The crux is to identify the syndrome, assess the GFR, and presence of a systemic disease, if any, so that we can arrive at a correct diagnosis. Thank you very much.
Thank you, Dr. Rajesh. It was really a fascinating talk. And after the successful completion of the first session, I'm just giving my mic to our moderators for further execution.
Thank you, all the speakers. Now there are a few audience questions to address. So I would ask this first question to Dr. Arvind Kanchi, which is isolated borderline raised creatinine indicative of kidney disease in a healthy person?
Any change in creatinine indicates a change in kidney function, so I would definitely investigate that further. There are a few caveats to this. If you have a person in a gym with building his muscle bulk and eating a lot of protein as a result of that, then there is some sense in actually waiting and then deciding. There is also some sense in looking at a repeat creatinine after a week and watching what happens. But a raised creatinine is always something that means that there is a kidney dysfunction and you'd want to investigate it further, yes.
I would ask the next question to Dr. Rajesh Nair. Is 1 plus persistent proteinuria in an otherwise healthy adult detected on a health checkup significant? And if so, what further workup is indicated?
Okay. This is a usual question once the patient comes or a person comes for a routine checkup who is otherwise healthy. So if there is 1 plus protein, persistent proteinuria need to be evaluated. So we'll have to repeat the urine dipstick again, and we have to quantitate the proteinuria. We can look for a urine protein creatinine ratio, and we can get a 24-hour urine protein. If the 24-hour urine protein is beyond 500 milligrams, 500 milligrams to 1 gram, probably he'll have to be in a very close follow-up and probably have to think of a kidney biopsy. But if the persistent proteinuria, which is less than 500 milligrams, with no evidence of renal dysfunction, with no hypertension, with no microhematuria, with no family history of renal disease, probably that patient need to be on follow-up. Mind you, there is something called orthostatic proteinuria also, which need to be looked into in such situations, which is fairly innocuous.
Okay, thank you
Thank
so
you.
much. Thank you for solving our queries. That was the end of the first session. I am very thankful to the speakers and the chairpersons for joining us today. Dr. Mohan Rajapurkar sir, I would request you to switch on your video so that you can be a part of our inauguration proceedings. I would hand over the mic again to Dr. Kshitij.
Thank you so much. The first panelist, right? The moderators, chairperson, excellent work. We stick with the time. And now mementos need to be given. So I would request Dr. Harish Grover sir to come on dais and give mementos to Dr. Girish Tyagi, sir. Right, sir, you are next. You are next. Please just hold his hand. Next memento to be given by Dr. Harish Grover sir is to Dr. Rajiv Ranjan. I would request Dr. DRI sir to give the memento to Dr. Manisha Dashi. Next one to Dr. Lovi Gaur. Thank you, Grover sir. Thank you, Dr. DRI sir. So with this, we end the first session. Now we are on with the inauguration. I would request Lele sir to come and do the needful, sir, please.
Thank you, Dr. Kshitij and Dr. Garima. Excellent first session. So your battle has started and first round you have won. Congratulations. Let me announce that today, just now we saw that more than 1,000 doctors have online on that and some more are joining and I've been sending them to get the link immediately. Yeah, it was to begin with. So this is a very important conference. We are going to have the inauguration. I will request Dr. Garima and Dr. Kshitij to escort our national president and Dr. Vinay Agrawal sir, our past national president, and guiding this entire conference together. I'll request Dr. Garima to moderate this session. Dr. Garima, please. Yeah. She's a nephrologist. I don't have to introduce her. And you can see the performance because the entire scientific work has been handled by two of our young buddies. Over to you, Dr. Garima. Please take over.
Thank you, sir. Thank you and welcome to the official inauguration of the IMA Kidneycon. I would like to request Dr. Anil Agarwal, sir, Honorary Joint Secretary IMA, to please come on the dais for the IMA prayer. We request all of you to please.
President to add on the medal here. Please rise for the IMA prayer.
And everybody will repeat after me. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you.
Please rise for the flag salutation also. Doctor.
I would like to request Dr. A.K. Sani, sir, to please join us for the flag salutation. He is also Honorary Joint Secretary IMA. I request all of you to please raise for the flag salutation.
Please do not repeat. Dr. Israni will lead the flag salutation.
Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our fight and strength, and its course shall be our course. We pledge our allegiance to it and realize our responsibilities. As the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Thank you.
Now, I would like to request our Honorary Secretary General, Dr. Jayesh Lele, sir, to please give the welcome address. An organization is only as good as its leaders, and we can ask for no better than Jayesh Lele, sir. All this dynamism that we have shown in this conference, the scientific program, and 100% support is all thanks to him. Thank you, sir, for helping us throughout this journey. Please, the welcome address.
Thank you, Dr. Garima, for your kind words. In fact, the entire team of this kidney conference has been working for last almost 2 months. First, we were planning in the beginning in sometime in the November, December, but then we discussed with Vinay sir, and we thought that the World Kidney Day will be the best opportunity wherein we will be able to have a good program. And that is how this entire conference was planned. As you know, the World Kidney Day, we always organize, and we have been requesting all our branches and the state branches to organize the programs, because it's very important that all the public health days, especially world, always as the Indian national days, which are very considered as one of the very important. This World Kidney Day probably has a fantastic organization support on the scientific team by Dr. Garima and Kshitij, and all nephrologists across India have given their helping hand in way of talk or moderating or in the panel discussions. Unfortunately, my very close friend, Dr. Umesh Khanna, who was a chairman for this conference, could not attend because of his personal reasons. But he has been always guiding me. In fact, today he's busy. Otherwise, he would have definitely joined. This scientific conference, when we thought that we should have a maybe physical or hybrid and certain things, we had a lot of meetings. All the meetings were definitely day by day, we were inching towards the success of the conference. And ultimately today, what we see that more than 1,500 joining across India, various faculties, various nephrologists, and none other than the family physicians have been the part of this entire conference. Just now also, I am getting continuously phone calls or the message that some link is they have missed out or something is not opening. I've been guiding them. Already we have planned, I think the conference what we have arranged, it is not to boost, but my entire team and with the guidance of our none other than Chief Patron, Dr. Ketan Desai sir, Vinay sir, and our SNP sir, our president, guiding force. And I would say that since it's a World Kidney Conference, I would say that this has been definitely an international conference of that statute, without any flaw, without any mishap or without anything. And I'm sure the same will continue for another day, that is till tomorrow afternoon. All the recordings, we will be keeping it alive for the conference on another 15 days on our website. So those doctors who have not been able to attend during this time will always be able to view it at a later date. They can continuously have, not only that, we have secured that nowadays we talk about the CME points, and the Delhi Medical Council has given the 4 credit points. So that is also very important, because I'm in Maharashtra and we got so many calls from the Maharashtra that whether the credit points are available, and it is a very creditable that Dr. Kshitij have been able to get this credit points for this conference. Very important. Regarding this World Kidney Day, we just had in the afternoon regarding even the press conference, and we have requested our friends from the various press to have the knowledge inhibit this entire theme to the common people, because our ultimate goal is to reach the common people, diagnose the kidney diseases at the earliest at the family physicians level, and definitely reduce the burden of the dialysis or burden on the organ transplant and other things at a subsequent end stage renal diseases. So I'm sure this will go a long way, and I'm sure as we will request all other local branches, state branches to have similar programs across India. Our next opportunity, we are also planning to have a kind of a conference or a welfare program for the patient at large, and that we should be our subsequent theme to have that. Especially scientific conference is doctors will be attending, but our intention would be that people should arrange, people should have whatever difficulties we have, then it should be a continuous process. So I would suggest and I would request the team also to consider this proposition of arranging this kind of activity wherein the patients we will look after. They themselves must be having a lot of patients who are either on the kidney dialysis or waiting for a organ transplant, waiting for the kidney, somebody to donate. So it will be our important exercise to go ahead and have such kind of a meetings, which will be definitely what for IMA is known for. Today, IMA is become the very important and a brand in the field of medical education, medical activities, health, and especially to give you example, yesterday afternoon when we were in the office and the discussions were going on about the Ukrainian the students, medical students who have returned, and our national president, myself, our honorable Ved sir, we discussed later how to go about it. The letter was immediately sent to the Prime Minister's office. Subsequently, it was also requested for an appointment with the health minister, our honorable Mansukh Mandviya ji sir, and the response has been tremendous. Most of the doctors, most of the students and the media at large have appreciated the letter which we have written it, and they have really responded very well, I would say, because we are concerned about the medical education and medical health in India. Thank you very much for giving me the opportunity. And I request the entire team and all the delegates to continue to have good conference, good dialogue with IMA. Thank you very much.
Thank you, sir, for those kind and encouraging words. And we will try to take your mission forward. Today, we are lucky to have amongst us the august presence of our national president, Dr. Sehjanand Prasad, sir. Sir, despite his exhausting schedule, flew in today morning and made it a point to attend this very important event for us. I would like to call the national president for the presidential address, sir. Please.
Thank you, Dr. Garima. Very good conference, as well as virtual also. So, a very good afternoon to all distinguished leaders, learned faculty, all delegates, and organizer of the Kidneycon. Let me congratulate the team of organizers led by senior nephrologist from Mumbai, Dr. Umesh Khanna. Sir, young dynamic daughter of our great leader, Dr. Vinay Agarwal, Dr. Garima. Our very sincere National Joint Secretary, Dr. Kshitiz Bali, and others are working so hard to make this event a grand success. It is estimated that over 90 crores people around the world suffer from kidney disease. 1 out of every 10 adults may have kidney disease, and if felt untreated, the disease can be deadly. Kidney disease related mortality continues to increase early and projecting to the 5th leading cause of death. As of today, unfortunately, a kidney disease knowledge gap exists in the border healthcare system, and only way to address this issue is by improving awareness and early detections. World Kidney Day is a global annual event aimed at raising awareness on kidney disease, the importance of our kidney to our overall health, and to reduce the frequency and impact of kidney disease that is a shared health problem worldwide. Every year, this highlight a particular theme, that the theme of 2022 is kidney health for all. Especially it call on all of us to work to spread knowledge on kidney disease and care of the healthcare, the patients' communities. This specific program is tailored for physicians and clinicians who may come across kidney patients in their practice on how to identify, treat, and timely refer them. You will find the scientific organ particularly clinically applicable in your day-to-day practice. So, during practice, we are seeing patient who has got a puffiness of face, swelling leg, and patient is not treated. If patient is not treated for a long time, then they have to suffer from the kidney disease. Early detection is very much essential for the kidney disease patients. Those are not treated, they have to suffer from KW syndrome, which having with the hypertension and diabetes. Especially I have seen a doctor who was suffering from kidney disease. I know him, he was suffering from diabetes and hypertension both, but he is not caring. So in this conference, we have to circulate all part of the country, especially rural areas. I have seen the rural patients as not treated properly. We have to treat properly because doctors are not available. They are working. They are taking medicine like a nemoxylide, like a ibuprofen, many drugs, so which is very harmful for the kidney disease. Those patients who are taking medicine for long time, any allopathic drugs or Ayurvedic drugs, they have to suffer with the kidney disease. So, sir, this is very good conference. Very learned doctors are here. Dr. Rajiv Ranjan is a top practitioner of medicine, diabetologist in Patna. And he's always treating this nephrotic syndrome patients or kidney disease patients. And all our Dr. Tyagi, Dr. Harish Grover, Dr. D.R. Rai, and Dr. Ramesh Datta. So the building committee chairman is here, smart fellow, is a good physician, as we have heard. He is a member of API also. There's many posts we are holding in API. So, sir, our secretary generally dashing personality. I have seen he is a CME master. He is used to this type of conference, 1 or 2 in a month. Always in Bombay, he is doing CME. So credit hours is very much essential these days. And this conference is to give not less than 8 points. Here our Delhi Medical Council star is here. So there's no not problem to get this. Our handsome personality, our past Secretary General, he is very close to us and is very laborious. Dr. Pandey's boss. So very good team. Dr. Binay Agarwal has a very good team. He is working not only in Delhi, all part of the country is very much old. And whenever he has told me you have to come. Then today I have very urgent work in Patna. But boss has told her, yaar, aana hai. Some guy, beti, jab isme match kari, to then I have to come. Again, he has told you have to come on 28th this month. I guess boss hum aayenge. So these days, IMA working is very good. I should not say, but we are trying to do something within 1 or 2 months. We have met 4 or 5 times to Health Minister. He has given assurance for all pending work. We have to do BCR award function. BCR award is not going on. We have to do CPA of Clinical Establishment Act. Within 2 or 3 months, everything will be possible. And regarding doctors, we are very much worried. And our special advisor, Dr. Ved Prakash Misra, has told us, and we are working in the umbrella of Dr. Ketan Desai. He has told we have to write a letter to Prime Minister. And I have written a letter to Prime Minister. Prime Minister has been very good response. He has taken cognizance of that letter. And he has publicly, to pressmen and media, I am 100% agree to IMA people. So our Prime Minister is very humble person. He has told us that everything will be possible, everything we will do for the current people, for Corona doctors. Just now you have heard the internship has been already passed. There is no problem. Those who have passed from the they will come to India and they will do this internship and they will get 12 months internship. After that, they will get provisional registration. After provisional registration, there will be no problem of permanent registration. So government will solve this problem. We have told us if it is possible, then this medical students of this country, those are studying there, those should be established there. If it is possible, again, all expenditure should be done by the government of India. If it is not possible, then all the students should be settled in India. पहले भी ऐसा देखा गया है, पहले भी ऐसा हुआ है. Dr. Rajiv Ranjan knows everything. In Bihar, 2 medical colleges has been closed, and that students has been shifted to government medical college. So here is possible. If government will take this initiation, everything will pass. So I may same we have to do with the persuasions. We will not fight, or we will solve everything by the persuasion, sir. With the cooperations of the people, with the blessings of all the people. We have to work with the umbrella of Dr. Ketan Desai. Thank you very much, sir. Thank you, sir.
Thank you very much, National President, sir. Your commitment to the cause of rural healthcare cannot be denied. And I think we are getting close to that, because I just got word that we have had 1,678 people watching us online right now. So we hope that this conference reaches every family practitioner, every clinician across the country. Now, our next speaker needs no introduction. I have personally been witness to his long commitment to the Indian Medical Association, to the cause of the family practitioner, to the GP, to the clinician. Dr. Vinay Agarwal is a known name all across the circle. I personally know him as my father. So, this conference is born out of his brain. It is his brainchild. He thought of it, and we are just the executioners. He feels that all of us specialists should commit to the Indian Medical Association, and all of us should move together. I would request Dr. Vinay Agarwal to please talk about the context setting of the conference.
Chief guest of the function today, our leader, Dr. Ketan Desai, sir, National President, a very simple, dedicated, and grassroots worker of Indian Medical Association, Dr. Sajanand Prasad Singh, Dr. Jayesh Lele, Secretary General of Indian Medical Association, a very experienced, Dr. Harish Grover, Dr. D.R. Rai, Dr. Narendra Saini, our past Secretary Generals of Indian Medical Association, Dr. Ashwini Dalmia, the President-elect of Delhi Medical Association, Dr. Girish Tyagi, the Registrar and of Delhi Medical Council and a past President of Delhi Medical Association, Dr. Ramesh Datta, Dr. Munish Prabhakar, many of my senior colleagues in the office bearer list of this year, and many of our nephrologists and urologists of eminence who are joining us this conference, whether physically or online. I also want to recognize the services of organizers who have done a wonderful job in organizing this event, both Garima and Kshitij Bali. Friends, this is the very, very unique experience of synergy between the professional organizations and a political organization like the Indian Medical Association. Previously, we divided our roles. That professional organization will keep on doing academic role, and organization like Indian Medical Association will be responsible for medical, legal, political roles, or a unionist role in the country. Time has changed. Time has come when the strength of 4.5 lakh members of Indian Medical Association And the other 6.5 lakh members, whether they are members of professional organizations, they are members of junior doctor network, whether they are members of medical student network, that has to be work like a synergy. You'll be happy to know that while 150 persons are physically have joined this conference here, 1700 delegates are online watching all of you and getting the treat from all those eminent nephrologists and neurosurgeons from the country and their experiences in it. Why we thought of organizing this? I am just doing the duty on behalf of organizing chairman, Dr. Umesh Khanna. Unfortunately, he had a bereavement in the family, so he could not come, and I have been given this onerous duty of explaining what exactly this conference is. You all know that 10th of March is going to be the World Kidney Day. And this time the theme is Kidney Health for All. Every year in the entire country, one World Kidney Day, we choose a theme and we work on that phenomenon. Our national president has just explained you that almost 90 crore active patients of chronic renal disease are there in the world. But hundreds of crore are those patients, those individuals who have not been diagnosed as suffering from kidney diseases. Unfortunately, in this country, the exact role when a patient comes diagnosed as a kidney disease comes either to the emergency of a hospital or to a senior physician with some of the complicated symptoms. And that is the situation when you suddenly found it out that while on routine investigation, you find his urea is increased, creatinine is more, or urine has more proteins. But I'm sure what is needed, and I really applaud our national president who have said that nationally, he's pledging today that nationally he's taking out a program of routine health checkup through their program of Aao Gaon Chale to every village and every person and try to identify if some persons are suffering from lifestyle diseases or they are suffering from, so that we can identify early symptoms of a kidney disease and we can prevent a lot of them from going to dialysis or a lot of them going to transplant this thing. This conference has faculty from entire country. You just saw Dr. Rajesh Nair from Cochin. Dr. Urmila is sitting here from Karnataka. You have our experts from Delhi. Dr. Umesh Khanna is from Maharashtra. We have Dr. Balal from Manipal University. And like that, Dr. D.S. Rana, Dr. Vijay Kher, Dr. Ajay Kher has already come, he's here, and many other. And the idea of it is that why can't we synergize the political activities, and the Forum of Indian Medical Association can also be used through its 1700 branches to pass on the basic primary aim to a general practitioner or to a physician to say that we have synergized our activities and these are the things which you should do primarily as a primary physician sitting either in a village or in a kasbah or in a district or as a secondary care hospital. Very well designed program. I kudos to Dr. Garma and Dr. Kshitij Bali, who have really done, and Dr. Umesh Khanna. And under his chairmanship, this program has been really well designed. I can't imagine a person who is not in this. Whether it is Dr. Sunil Shroff, whether it is Dr. Anant Kumar, whether it is, whatsoever name you want to take, even Rajiv Sood is here, who has been a president of Urology Society of India. So like that, most of the prominent persons in the field of nephrology and urology have been put, and we are gaining their experience by way of this conference. I'm sure the efforts of our organizers will go a long way in passing the basic messages. And the messages are two: preventive health checkup, early checkup, regular checkup. And the second part is a movement for organ donation. There is a big gap between the persons needing transplant and the availability of an organ. And I'm sure if we can take this as a muhim, as this movement, that why can't we in this country make more persons to commit that their organs, if required, will be given to the needy persons. We save, by one cadaver, we save 8 lives. Not only that, kidney transplant is one of those, liver transplants are one of those 2 things which even a live person can give it to a live patient, so that both the lives can be simultaneously taken care of. I'm sure presence of all of you, eminent physicians, eminent family physicians, eminent doctors, eminent clinicians from all over the country. I'm talking about all those and thanking all those 1700 plus persons who have joined online, and also persons who are viewing us from our Facebook Live as well as on our YouTube channel. Indian Medical Association is committed to continuing medical education. I can assure you, in the time of Dr. Sahajanand Prasad Singh and the times to come, that we will continue these kind of academic activities through these forums for future also, so that there can be a synergy of professional organization and the family physicians, or primary to secondary physicians, small hospitals to small clinics, so that they can also get benefit from the primary symptoms to the actual advancements being done in those specialties. Thank you very much, Garma. Thank you very much, Sitish, for doing a wonderful job. And I'm sure on behalf of all of you, I want to thank all those who are viewing us online. Thank you very much. Thank you.
Thank you, Dr. Vinay Agarwal. Your words have always guided us and the Indian Medical Association. And coming to guidance, no good thing can begin without the blessings of Goddess Saraswati. I would like to request the dignitaries on the dais to please proceed towards lighting the lamp and get blessings for this 2-day academic endeavor. The senior dignitaries of the IMA to please join us and in seeking blessings for this endeavor. Dignitaries of the IMA to please join us. Thank you. Thank you, and may this light dispel all the darkness in all of our lives, and we move towards prosperity and joy. The chief patron of the conference today is Dr. Ketan Desai, sir. We have had his blessings for this conference. This topic's been close to his heart because him being a urologist himself, he was very encouraging from the start. And now we have a special message from him for all of you.
National President Dr. Sahajanand, Secretary General of Indian Medical Association, dignitaries, friends, invited guests, ladies and gentlemen. It is my proud privilege to address this gathering of illustrious luminaries on the day of World Kidney Day and Indian Medical Association has very rightly organized the IMA Kidneycon 2022 on this day. I, being a urologist, this subject is very close to my heart. And did you know that 1 out of every 10 adults suffer from some form of kidney disease? It is estimated that over 90 crore people around the world suffer from kidney disease. Kidney disease related deaths are rising year on year in India. 95% of early stage kidney disease are in fact not seen by specialists but by general practitioners, clinicians, and family doctors. But unfortunately, the knowledge about detecting and treating kidney disease is very limited even among healthcare professionals. This is due to lack of focus on kidney and urological issues during medical training and lack of regular CMEs initiatives on the same. This by itself is a warranted issue which merits consideration in as much as desired modalities to combat the same need to be put into place at its earlier, lest it turns out to be a malady beyond redemption. World Kidney Day is a global annual event which focuses on a particular theme every year to increase kidney health literacy. And this year the theme is Kidney Health for All, bridging the knowledge gap to improve kidney care. So the IMA Kidneycon is a perfect initiative to start to build a more informed community of doctors when it comes to kidney disease. This is bound to facilitate the issue at hand in terms of providing a radical cure for the same in a very cogent, credible, and creditable manner. However, it cannot be worked out in the form of a one-time approach or a one-time initiative of its type. It has to be through invocation of modality, which should be in the form of a standing mechanism committed to dispensation of onus of bridging the knowledge gap that exists as of now so as to give a qualitative fillip to renal care and cure. The Indian Medical Association, as the largest national organization of doctors of modern medicine, is committed to serving not only the medico-legal issues, but also the professional interests of its members and developing their expertise by various scientific and CMA activities in the domain of continuing professional update, which results in enriching the competencies of the healthcare professionals for rendering desired level of services commensurate with the problem. IMA as a voluntary organization has always shouldered the responsibility along with the government in promoting all kinds of national health programs. The IMA's commitment to the nation, which is evident with the recent corona epidemic, where 2,000 doctors laid their lives, stands as a bona fide testimony of the members of IMA having unlimited and unending commitment to the cause of rendering medical cure to needy in the worst and hostile circumstances, as well dominated by willingness to lay down their own lives without any sense of apprehension or fear of any type. I want to avail this platform to pay my respects and homage to our lost warriors and utilize the efforts of the entire IMA community, which has been rightly and richly recognized by all concerned, including the powers that be. IMA is an active partner of the World Medical Association and its global activities as well. Resultantly, the contribution invoked, thereto in an all-round manner, bears a global perspective in all its manifestations. With its commitment to medical education in mind, the IMA has organized this national conference with a focus on kidney disease, their early detection, treatment, and timely referral, which is bound to prove to be of use and relevance alike in terms of its outcome, totally commensurate with the set out objectives in a tangible and measurable manner. This would go a long way in not only strategizing on the vital issue of kidney care, but bring out a detailed blueprint of actionable action plan on this vital arena and prove to be a real savior in times to come. I want to compliment the organizing team for putting together a practical and clinically relevant scientific program for doctors, and I wish them the best towards the commitment of the desired goal in the larger interest of people, profession, and society as a whole. I feel privileged to inaugurate this laudable conference of genuine worth, substance, and purpose as well. Thank you very much, and Jai Hind.
Thank you, Dr. Ketan Desai, sir. Um, well, they say it takes a village to raise a child. They should say the same about organizing a conference. It takes a village and more. I was lucky to have a co-organizing secretary who has been holding fort for the last 3 months. The amount of effort that's gone behind the scenes to make this happen today, including dealing with late night and early morning calls and messages from me. So now I would like to call upon the real force behind this conference today, Dr. Kshitij Bali, to please give the vote of thanks. Thank you.
Okay, I come to the most difficult part. After so many good speakers, मेरे को दिया गया vote of thanks. So I'll try to do justice to it. कुछ हो गया तो sir माफ करना. So thanks to our chief patron, Dr. Ketan Desai, sir, for inaugurating the conference and for the encouraging words to the fraternity. Thanks to our national president, sir, Dr. SNP, sir, and our HSG, sir, Dr. Jayesh Lele, sir, for all the help, encouragement, support, and guidance to make Kidneycon a grand success. Lele, sir, thanks to you. I do not know how many times I must have disturbed you, called you up at odd times. I do not know how many times I sat down with you in the night to set this conference. Thank you so much, sir. Special thanks to our own Dr. Vinay Agarwal, sir, our past national president and patron, for the idea, the push, and continuous guidance and courage to conduct this mega event. I remember sir's word, ho jayega. Chinta mat kar, ho jayega. Thank you, sir, for putting trust in our team to organize such a mega conference. Right now, we have approximately 1,800 people who are watching us live. Thanks to Dr. Umesh Khanna, sir, for organizing chairman to plan and fine-tune the topics and arranging eminent speakers and moderators. Thanks to my partner in crime, where you are, Garima, right? For all the help in planning, executing, and smooth conduct of the conference. I would like to call her the little master for all the tasks she had given to everybody in the organizing team. So thanks to you. Thanks to our organizing team consisting of all moderators, speakers, and chairmen and patrons. This vote of thanks would be incomplete without thanking the IMA staff, Meena ji, Rakhi ji, Neeru ji, Monica, Gautam, Sachin, Yogesh ji, and the man of the hour, Pandey ji. Would also like to thank Dr. Kamat sir for all the advice and support rendered to us. Special thanks to our canteen staff for unrelenting 24/7 hour service in providing catering to our taste buds. Special thanks to our sponsors who are down. I would request you all to kindly visit their stalls, put downstairs in the parking area to encourage them. Finally, I would like to conclude by thanking all our doctors, you all who are there to take time to attend the mega conference, either physically or virtually. I would like to take this opportunity to invite everybody for dinner, which happens tonight at 8 o'clock in this very hall. Thank you so much. I would request everybody to stand up. We will play the national anthem. गाए सब जय गाता, जन गण मंगल दायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे. I would request Dr. Garima to come and start the next session, session 2.
आप सभी डिनर लेके जाएंगे, डिनर लेके जाइएगा.
Thank you to the dignitaries on the dais. Thank you to the dignitaries on the
डिनर
dais.
लेके आप लोग जाएंगे.
For want of time, we'll begin our next session now. Our next session is a very important issue, acute kidney injury, often ignored. I would like to call upon stage the moderators for this session, Dr. Ajay Kher, who will be joining us on the dais, and Dr. Mayuri Trivedi, who will be joining us online.
Hello. I would like to invite our chairperson, Dr. Munish Prabhakar, senior consultant and a special focus on diabetes and preventive cardiology, who's also member of the governing council of API and past president IMA of Haryana as well as IMA Gurgaon, and member of the advisory board of JAPI. Dr. Munish Prabhakar. We'll also like to invite our second chairperson, Professor Ketan Mehta, General Secretary of the ISC, and editorial board member of JAPI, as well as the Journal of Medical Nutrition and Nutraceuticals, and who's been a PI for various trials as well, and convener and chairman of the IMA standing committees, as well as National Steering Committee member, Professor Ketan Mehta. And Professor Narayan Prasad, who is the head of nephrology at SGPGI and secretary of the Indian Society of Nephrology, as well as the deputy chair of the South Asian Regional Board of the International Society of Nephrology, council member of the International Society of Nephrology, and also has held various positions in other nephrology societies like the Indian Society of Organ Transplant and the Peritoneal Dialysis Society as well, and is currently the member of the Pradhan Mantri National Dialysis Program as well. I would like to invite Dr. Urmila Anand to be on the dais, and Dr. Narayan Prasad to introduce Dr. Urmila Anand, who's going to be our first speaker.
Thank you, Dr. Ajay. Am I audible? Dr. Ajay?
Yes, sir. Yes, sir.
Yeah.
Yes, sir. Yes.
Thank you very much. Thank you, first of all, IMA and the organizing committee, Dr. Garima Mayuri and Dr. Ajay Kher, for this opportunity. It is always pleasure to be in such a great gathering, and we have just heard about 2,000 pupils are connected, and I have been told by Dr. Urmila that you have to not to speak too much, so that's why I am limiting her introduction. She is a very dynamic nephrologist, consultant nephrologist in Yashoda Group of Hospitals in Hyderabad, and she is a founder member of the Women in Nephrology, and she is also involved in internationally in many of the events of the International Society of Nephrology. To name a few, that she is a member of South Asia Regional Board of the International Society of Nephrology, and she is doing the great jobs, and she has very good in-depth knowledge of the acute kidney injury. She is going to speak on the topic that is definition of AKI, one of the very controversial topic, and what are the causes of AKI. Over to you, Dr. Urmila.
Good afternoon. At the very onset, I would like to thank IMA for giving me this opportunity to talk in this session on acute kidney injury. Acute kidney injury makes up an important part of our clinical practice, not just for nephrologists, but for physicians also. In the next 15 minutes or so, I will discuss mostly on the definitions of acute kidney injury and a critical appraisal of these definitions. Finally, in the last couple of minutes, I'll briefly go through the causes of acute kidney injury. I need the indulgence of the gathering, both offline and online, to help me because the definitions will be a little technical, but I realize that these are important for our practice, not just for nephrologists, but physicians alike. Now, acute renal failure is actually defined as a rapid fall in GFR, which manifests with an abrupt and sustained increase in serum creatinine, with associated disrupted salt and water homeostasis. So it's actually a functional definition where there is a fall in GFR. And the concept of acute kidney injury actually encompasses everything, starting from minimum renal dysfunction and minor changes to finally into dependency on dialysis. The definitions of acute kidney injury actually crystallized with the Acute Dialysis Quality Initiative meeting in 2000, where intensivists and nephrologists met together to develop guidelines for prevention and treatment of renal failure. This was a consensus process, and they looked into published evidence, and whenever evidence was not there, they sought expert opinion. They actually gave us the term acute kidney injury. The first definition of acute kidney injury actually comes as the Rifle definition, and in that they showed that they divided it into 5 criteria: risk, injury, failure, loss, and end-stage kidney. Starts with a 50% rise in creatinine or a 25% decrease in GFR, going up to 3 times the rise in creatinine and 75% decrease in GFR. Included urinary criteria where in the first 6 hours, if the urine output was less than 0.5 ml per kg per hour, it was considered at risk. This is the first definition, and they had 2 outcome definitions of loss and end-stage kidney disease. The most important concept of Rifle is that it moves beyond acute renal failure, and it gives us the concept of acute kidney injury, which creates a new paradigm. It focuses on minor changes in creatinine and allows early interventions. It also gives us the first standardized definition for uniformity in clinical research. And what was shown by Rifle is that the severe the category of Rifle, more the higher the mortality, showing that Rifle is actually an important prognostic definition. But Rifle had its own limitation. The limits that were created in RIF were arbitrary. And there was also a mismatch in serum creatinine and GFR when we used MDRD formula. A rise in 50% rise in serum creatinine actually led to 37% decline in GFR. Similarly, when the creatinine trebled, the GFR fell by 72%. And it did not look into the fact that hydration can actually alter the urine output and also can modify the volume of distribution of creatinine, giving us both urine output and serum creatinine fallacious values. They did not give the emphasis that underlying cause can have a significant importance in the clinical meaning of AKI. And also the criteria was developed for critically ill, not for outpatient glomerular diseases. The limitations also is that the urine output criteria is a limitation, but because it is very difficult to look into prospective data analysis, and the mismatch of stage, if you combine both serum creatinine and urine output, is important. And there is serum creatinine is in patients appear to be sicker compared to urine output criteria. Baseline creatinine is often not available, and GFR limitations are in the dynamic state for the diagnosis of AKI. And depending on what baseline creatinine you use, the mortality actually varied between 7 to 14% when we used Rifle criteria. That led to the development acute kidney injury network criteria, where they improved the sensitivity of AKI diagnosis, and they added an absolute increase in serum creatinine by 0.3 milligram per deciliter. The GFR criteria was removed, and all patients, irrespective of their creatinine, if they were on dialysis, was staged at AKIN 3. And patient only required one criteria, either creatinine or urine output. The time was important. The changes were to be looked into 48 hours, whereas Rifle looked at 7 days. And outcome classes of failure and end-stage kidney disease were removed. Akin excludes patients with urinary tract obstruction and causes of irreversible urine output decline. Because these things, the urine output criteria, is very difficult to detect in retrospective study. The 48-hour time frame of diagnosis of AKI is a little stupefying. Is that how is it possible for us to diagnose AKI in patients in whom we have not done alternate day creatinine? And even if the diagnosis happens over 48 hours, the staging takes over a longer period. The baseline creatinine issue still stays, and they also mentioned that the lowest in the last 48 hours. Now, if you look into the difference, Rifle had risk injury and failure. Akin became 1, 2, 3. The loss and end stage criteria were removed. The GFR criteria was removed, and the creatinine rise was 1.5 times, which is in the same stage. And there was no mention on renal replacement therapy, whereas in Akin, all patients who were on dialysis were staged into stage 3. The time frame for Rifle changes was 1 week, whereas here it has become a 48-hour change. And the diagnostic criteria of AKI will only be done when patient has undergone an adequate hydration, so the pre-renal causes are removed. Now, this is a case study where we see the difference between Rifle and Akin. A patient who has a creatinine 1 on ICU day actually goes into the Rifle criteria of risk on day 6 because he has more than 50% rise in creatinine over 7 days. But in Akin, within the last 48 hours, the creatinine has not increased more than 0.3. So still it is AKI. And this continues by day 11. He becomes Rifle stage 2, but in Akin, he still no AKI because between 9th and 11th day, there was no rise in 0.3 creatinine. So this is the issue that we have. It is only on the 17th day when the creatinine has actually trebled and the patient is in Rifle failure, has actually moved into stage 1 of Akin because between 16th and 17th day, that is within the or between 14 and 17, that is within the last 48 hours, the creatinine has increased by 0.3 milligram. So these are the issues with Akin criteria, which was addressed by the KDIGO definition, which is the commonest definition of AKI that we use, where we not only keep the absolute serum creatinine of 0.3 milligram within 48 hours, but we looked into the 1.5 times increase in serum creatinine within the last 7 days. So in KDIGO, you have, again, it's creatinine or urine output, and you have these various rises in creatinine and the various declines in urine, and KDIGO is stage 1, 2, and 3. Now, if you look back to the earlier example of Rifle and Akin, if you use the KDIGO criteria, this patient will become risk in Rifle, but also will go to KDIGO stage 1 of renal failure because his creatinine has increased by 1 to 5 times within the 7 days period. So this is the advantage of KDIGO. Now, there have been lots of critics about AKI definitions. AKI definitions, acute kidney injury definition, is actually markers of functional injury, not markers of anatomical change. And the markers of actual damage do not make a mention in the diagnosis of AKI. And the concept of baseline creatinine still stays dubious. And till what time frame we maintain the diagnosis of AKI? Now, this is the framework of AKI which we would like to use, that it is only when the GFR drops that we make a diagnosis of AKI, but we would like to detect AKI when the damage has set in, that is in the early stage, and we should like to incorporate the markers of damage in the definition of AKI, that is the biomarkers like NGAL, KIM1, and IL-18. Now, the worry of baseline creatinine. If you look into A, B, C, D, E, it is easy because either you have a baseline in the beginning or at the end, which gives you an idea of AKI and helps you stage the creatinine. What about patients who don't have a baseline and who don't reach the creatinine stages to suggest that they had AKI or not? In F, you have reached 1, so it's easy, even though if you don't have baseline. In the example F, you have reached 1, so you can say you had AKI stage 3 because the creatinine had trebled. But what about G? Is there any evidence of AKI? We don't know. There has been a rise in creatinine. There has been a drop in creatinine, but there is no 1.5 G times change. And the baseline, we are not very sure. Is G and H both CKD? And this definition will only be possible if we follow these two patients for 3 months and if the creatinine still stays elevated. What if the patient G and H has its creatinine normalized after 2 months? This is where the concept of acute kidney disease comes in. This is where the rise in creatinine, if it is for less than 7 days, it stays as AKI. But if the creatinine persistent rise stays till less than 3 months, or if it normalizes by 3 months, but it's more than 7 days, this is called a stage of AKT. And when it is more than 3 months, we get into the concept of CKT. So it's important to know the time frame of AKI, how long this AKI lasts. Briefly, in the next couple of minutes, the causes of acute kidney injury, and it is a common disease and it depends on which setting it happens, whether it's hospital or community, which part of the world, tropical, non-tropical, which ICUs it is happening, and finally, the nephrologist definition of which part of the kidney is involved. Hospital and community acquired are two different things, and the community acquired infections from India had shown, Srijit will be discussing this, is actually mostly nephrotoxics and infections. The tropical AKIs are not only infections, again Srijit will be talking, but there are lots of other things that we use, plant toxins, animals like snake bites, use of chemical, lot of suicidal intent and various other things which are responsible for acute kidney injury in our part of the world. Acute kidney injury in the ICUs is similar all over the world, mostly surgical by surgery, sepsis, underlying liver disease, trauma, rhabdomyolysis, obstructive uropathy are the commonest causes of acute kidney injury in ICU. Obstetric AKI will be discussed by Manisha, but it is important to know the causes of acute kidney injury in obstetrics actually depends on the trimester of the pregnancy. Finally, for a nephrologist, acute kidney injury is defined, causes are defined as pre-renal, intrarenal, post-renal, and based on which part of the kidney it is involved, the causes are different. So ladies and gentlemen, acute kidney injury should be defined with a single consensus definition clinically and in research system. Concept of AKI should include laboratory markers of kidney disease. Acute kidney injury is not a transient phenomenon. Causes are dependent on various factors and causes of AKI is often multifactorial. I invite you all to the International Society of Nephrology Frontiers meeting in New Delhi, September 22nd to 25. Details of this meeting is there in International Society of Nephrology website. Thank you very much for your kind attention.
Thank you very much, ma'am, for that lovely talk. And now I invite Dr. Munish Prabhakar to please introduce our next speaker, Dr. Pranav Jha.
Good afternoon. After listening to the definition and causes of acute kidney injuries, now Dr. Pranav Jha shall be talking about prerenal cases. And Dr. Pranav Jha, we can all see a very illustrious speaker. And rather than myself taking time to give all his introduction, let him give a very nice presentation of his cases, prerenal cases. Thank you very much. Dr. Pranav Jha, please start.
Thank you. And thank you, Chairperson. I have a pre-recorded talk to avoid am I audible, am I visible syndrome in Zoom. So please. Thank you, Chairpersons. And first of all, I would like to thank the organizers for giving me this opportunity to talk on this important topic of a case of pre-renal AKI. So I will start my talk with 3 case scenarios. First one is Mr. MP, who is a 28-year-old male with no previous comorbidities. And he has presented with history of profuse watery diarrhea and multiple vomiting episodes for the past 2 days. He's also complaining of reduced urine output. And on examination, his pulse is 110 per minute. His blood pressure is 100/60. His tongue is dry, chest is clear. Investigation showed a blood urea of 100, serum creatinine of 2, and the serum sodium is 144. His urine osmolality is 600 milliosmol per kg, and the urine sodium is 8 millimole per liter. His urine routine analysis is normal. The second case is of Mr. NK, who is a 55-year-old gentleman with a known case a known case of diabetes, hypertension, coronary artery disease, and he has also presented with breathlessness and reduced urine output of 5 days duration. On examination, his pulse is 72 per minute, blood pressure is 100/60, his JVP is raised, there is bilateral pedal edema and crepitations. His lab values showed urea of 65 and serum creatinine of 2.5, serum sodium of 142, potassium of 4.9, and his urine analysis is normal. Echo showed an ejection fraction of 25%. The third case is of Mrs. SL, who is a 63-year-old patient of hepatitis C-related cirrhosis with portal hypertension, and she has presented with history of worsening abdominal distension and reduced urine output of 10 days duration. On examination, her pulse is 75 per minute, blood pressure is 100/60. She has pedal edema and ascites. Investigations revealed a serum creatinine of 1.8, sodium of 128, and potassium of 3.8, with an albumin of 2.5. Her urine sodium is 5 millimole per liter, and the urine analysis is normal. Now, how are we going to manage the acute kidney injury in these three different scenarios? So as all of us know, acute kidney injury has been divided basically into three different types: pre-renal, post-renal, and intrinsic renal. The pre-renal and post-renal are the reversible forms of acute kidney injury, and if not treated at right time, it can proceed to intrinsic renal acute tubular injury. So AKI is observed in almost 9% of the hospitalized patients, and more than 50% of ICU patients get acute kidney injury. And the pre-renal disease accounts for about 1/3 of such cases. There is a very high risk of mortality, even with minimal increase of serum creatinine. And early identification can prevent the increased cost of treatment and associated morbidity and mortality that is seen in patients who have an established AKI. There is no formal definition as such for a pre-renal AKI, but an elevation of serum creatinine or a reduction of urine output that can be easily reversed with improved hydration or improved renal perfusion pressure constitutes a pre-renal AKI. So there are two characteristic things: transient and reversible. That the serum creatinine, the renal function should become normal within 24 to 72 hours. This is also synonymous with hypoperfusion induced azotemia. So as all of us know, that pre-renal and intrinsic renal has been traditionally classified as two different compartments, where pre-renal finishes, intrinsic renal starts. But in reality, it is more of a continuum. And the studies have also found that in the biopsy of a patient with pre-renal acute kidney injury, one can even see sometimes patchy changes of acute tubular injury. A pre-renal state can be because of a true volume depletion, like seen in dehydration, hemorrhage, renal, GI, or skin losses, and third space sequestration. It can also be seen with edema in patients such as those who have heart failure, cirrhosis, and nephrotic syndromes. And it can be seen in conditions where there is a bilateral renal artery stenosis or unilateral stenosis in a solitary functioning kidney. So coming to the pathophysiology of pre-renal AKI, in fact, before the pre-renal AKI sets in, there is a lot of pre-renal adjustments that the body is doing. This is being done at three levels. One is at the level of cardiac output and the renal blood flow. Second is at the level of glomerular filtration. And third is at the level of tubular reabsorption. Now, all of us know the autoregulation in kidneys consists of two different responses. One is myogenic response and other one is tubuloglomerular feedback. In the myogenic response, the reduction in arterial blood pressure leads to reduced arterial wall stretch. And this leads to closing of calcium channels in the smooth muscle cells and leading to afferent arterial vasodilatation. If you look at the tubuloglomerular feedback, whenever there is a reduction of arterial pressure, the BP is reduced. In that case, the GFR falls and the filtrate that is reaching macula densa is reduced, thereby reduction of sodium chloride delivery to that area. This is sensed by macula densa and it leads to secretion of renin by the juxtaglomerular cells, and it leads to angiotensin II formation, which ultimately leads to increased afferent arteriolar resistance. The macula densa also leads to increased the sensing of reduced sodium chloride by macula densa also leads to increased prostaglandin secretion, and this leads to reduced afferent arteriolar resistance. This ultimately leads to increased filtration fraction and improved glomerular filtration rate. There are quite a few vasoconstrictor and vasodilators acting on the renal helping in the renal autoregulation. The vasoconstrictor stimuli consist of angiotensin 2, endothelin, adenosine, thromboxane A2, and vasopressin. While if you look at the vasodilator stimuli, it is prostaglandins, bradykinins, and nitrous oxide. Now coming to the pathophysiology of hepatorenal syndrome, here the splanchnic vasodilatation leads to effective arterial hypovolemia, and there is an activation of renin, angiotensin, aldosterone system leading to renal vasoconstriction and hepatorenal syndrome, while it also leads to retention of sodium and water, thereby leading to ascites. In the third scenario, which is of cardiorenal syndrome, the main abnormality here is reduced cardiac output as well as increased renal venous pressure. These are the two important events. Apart from this, the usual neurohumoral activation and intrarenal mechanisms that we discussed also play a role, and there is also a role of cytokine and endothelial dysfunction leading to inflammation. The history is most of the time forthcoming in patients with prerenal AKI. They have a history of diarrhea, vomiting, blood loss, important drug intake like NSAIDs. Sometimes patients with cirrhosis and portal hypertension, as we discussed, or a cardiac heart failure patient, they will give history of cardiac and liver disease. Any patient who is admitted in hospital, the IPT record should be thoroughly reviewed for any episode of hypotension or radio contrast administration, etc. Physical examination will normally reveal a tachycardic patient who will be hypotensive, either a supine or if not in supine, then orthostatic hypotension can be seen. The mucous membrane will be dry, skin turgor will be lost, the extremities will be cool, and the eyes will be sunken in extreme cases. Edema and ascites can be seen in patients with heart failure and cirrhosis. So coming to the diagnosis, the gold standard of the diagnosis remains the response to fluid depletion in patients with features of volume depletion, and leads to which leads to normalization of serum creatinine within 24 to 72 hours. The response is usually assessed by urine flow restoration, improvement in kidney function, and a rise in urine output. There is no consensus as on the amount, nature, and duration of fluid which is required for this, but mostly it is a normal saline which is used. So there are quite a few urinary tests and blood tests which are used to differentiate a prerenal AKI from an intrinsic renal AKI, but they have the limitations of their own. First one is urine analysis. In patients with prerenal AKI, it is usually bland, while in intrinsic renal AKI, one can see muddy brown granular cast. The urine osmolality is on the higher side at more than 500 in patients with prerenal AKI, while it is less than 300 in patients with acute tubular injury. Looking at the specific gravity, patients have a higher specific gravity in prerenal state. The urine sodium is less than 10 because the kidneys are trying to conserve salt and water. The fractional excretion of sodium is less than 1%, while it is more than 1% in patients with intrinsic renal failure. The fractional excretion of urea is another index which is used to differentiate between prerenal and intrinsic renal AKI. And it is it is a better test whenever patient is on diuretics, and the value is less than 35% in patients having prerenal AKI. The blood urea nitrogen to serum creatinine ratio is more than 20 in prerenal AKI, while it is 10 to 15 in an intrinsic renal AKI. Now coming to the biomarkers, there are quite a few biomarkers that have been studied. The most common of them are urinary NGAL, urinary KIM1, urinary interleukin 18, L-type FABP, urinary calprotectin, and there are two G1 cell cycle arrest biomarkers, IGF BP7 and TIMP2. All these biomarkers are elevated in patients with acute tubular injury, while there is very less or no expression in patients with a prerenal state. There are quite a few urinary low molecular protein and tubular enzymes, which can sometimes differentiate, although not always, between a pre-renal and an acute tubular injury. Although there are many biomarkers, but none of them have been very successful in differentiating the two states, and history and clinical examination still remains the cornerstone in the diagnosis. So now coming to the three cases that we discussed when we started the talk. The first one is a very clear-cut case of hypovolemic pre-renal AKI. And here the treatment will be hydrating the patient with normal saline and assessing for the response after that. One should be cautious to avoid overhydration, as overloading has been shown to have adverse outcome for these patients in case of an established acute tubular injury. The second case that we discussed is a case of heart failure with acute kidney injury. And the treatment here won't be IV hydration, but IV loop diuretics and decongestion. There is a role for ARNI or ACE inhibitor or ARB in improving the outcome in such patients who have AKI associated with heart failure. And the third case is a case of cirrhosis with portal hypertension and hepatorenal syndrome, which we encounter in these patients. And the treatment here will be giving IV albumin and vasoconstrictors like terlipressin, norepinephrine, midodrine, or octreotide, depending upon the setting where the patient is. So to conclude, pre-renal AKI is a common and preventable condition, and early identification is important to prevent the progression to acute tubular injury. A detailed history and clinical examination is very important, and management will differ depending upon the type and the underlying pathophysiological mechanism. While we need to deplete them with IV fluid, we should be cautious to avoid fluid overload as it can as it can increase the mortality in such patients. Thank you for your kind attention.
Thank you very much, Dr. Jha. And I'll request Dr. Ketan Mehta to introduce our next speaker, Dr. Srijit Parmeshwaran from JIPMER.
Dr. Srijit is a nephrologist from JIPMER, and he'll be talking about infections related AKI. And over to Dr. Srijit for his talk.
Yeah. So we will go to this one of the very important topics, that is infections related AKI. And Dr. Srijit would be discussing about this most important aspect, which we see, be it in OPD practice or be it in indoor practice, infection related AKI. Over to Srijit, please.
Good afternoon, everyone. I would like to thank the IMA as well as the organizers of this CME for asking me to be part of this program. I am honored to be with you all. My topic is infection-related acute kidney injury, and over the next 20 minutes or so, what I would like to do is to go through the basic principles of the infections-related acute kidney injury. I will not be able to discuss individual infections which produce AKI, so I'll be focusing on the broad principles, the mechanisms involved, and what is essential for all of us to know about this. So how common is infection-related AKI, and how much does infections contribute to the overall AKI burden is something which we need to know. Then I'll be briefly discussing the various mechanisms underlying acute kidney injury in infections. Then something which all of us are dealing with in our day-to-day clinical practice, that is tropical infections related acute kidney injury, and why it is important to understand the role of the tropical ecosystem in causing this acute kidney injury, as well as in this pandemic time. And when we talk about infections, we can't escape COVID-19. So a couple of slides on COVID-19 related AKI as well. So this, I'm showing this just to impress upon you the burden of acute kidney injury as a whole. This is not exactly about infection-related acute kidney injury. This is the burden of acute kidney injury described as the proportion of people in hospital who develop AKI. Okay, so it's evident that the reported incidence seems to be slightly lower than what is described in the higher income countries like the USA or in Europe. But I should say that this estimate itself is higher than what we traditionally knew or was reported from India. And there are subsequent reports after this particular Lancet paper also showing reporting incidence of AKI up to 20-21%. So even if it is 7.5 or 8%, still that is a significant number of patients developing AKI. So it is evident that all over the world, AKI itself is a large, huge burden, right? So now the question is, what proportion of this is from infections? So this figure nicely depicts the contribution of various pathological conditions that can lead to AKI. So the size of the circle correlates with the contribution, right? So the drugs, these are not about individual infections, it can be not conditions, but pathological conditions or pathological processes which produce AKI. So drug related is significant number. Heart disease, either heart failure or post-cardiac surgery, shock, sepsis, thrombotic microangiopathies, glomerulonephritis. So these are all known causes for AKI, and it is evident this analysis is primarily based on countries where enough data is available. So this is predominantly representative of high-income countries, not necessarily India, but it is evident that infections, primarily in the form of sepsis, contributes to a significant chunk of AKI. Again, it's also important to understand that the incidence of AKI, the occurrence of AKI depends upon two things. One is the susceptibility of the patient. Then if you have a susceptible person exposed to something which is not to cause AKI, then the chance of AKI is more. This is important. This is an important concept to understand. I'll be coming back to it again. So look at this. This is again from a very interesting paper from Dr. Mehta, came in Lancet in 2015 to coincide with the World Kidney Day at that time also. This describes the risk factors for acute kidney injury. The basic idea is that it is possible to make some risk assessment of patients when they reach the hospital or admitted patients or in the ICU, whether they are likely to develop AKI in advance, right? So there are two things described. One is the risk factors for acute kidney injury. You can screen these patients for whether they have any of these risk factors. They may have more than one or multiple risk factors. And there are exposures. So these are factors which are known when if a patient experiences any of these, they are at high risk of developing AKI. So again, this exposure, interestingly, is categorized into two groups. Level 1 and 2 countries are high income countries. Then level 2 and 3 are low and low middle income countries. Okay. And if you note, while sepsis, circulatory shock, trauma, cardiac surgery, etc., are the most common exposures which cause AKI in wealthy countries. In countries including India, the spectrum is different. The etiological or the inciting events are different in the form of diarrhea, obstetric complications, infectious diseases, that too mostly tropical infections, not very common in high-income countries. Envenomations like snake bite, bee, wasp bite. Natural medicines, herbal preparations, which is very common in the low and middle income countries like India. So the point is circumstances in countries like ours, like inadequate sanitation, absence of clean drinking water, absence of piracy control measures, inadequate health infrastructure, along with the infections and other factors which are probably peculiar to the tropical environment are significant contributors to AKI. If we remove these, then our burden of AKI is likely to be less. All right. So also we know that there is difference when AKI occurs. High income country and low income country, there's a difference. In high income countries, AKI predominantly occur in the ICUs, are associated with multi-organ dysfunction and from sepsis. Whereas in low and middle income countries like India, this is usually in may not be always in the ICU. People may come, they may develop AKI outside, for example, after a snake bite in a primary health center or in the community, and then come to the hospital for treatment. They don't develop AKI in hospital after admission for some other reason. They're often caused by single disease, unlike multiple comorbidities and medical conditions in the developing countries, and often associated with specific disease like diarrhea, for example, cholera or malaria, leptospirosis, snake bite, right? And this also occurs, if you look at the age, they are younger and their outcome are expected to be better, but may be compromised by absence of proper healthcare facilities, right? So now let us look at what are the common causes of AKI in our country. So this paper is from JIPMER, published in Indian Journal of Nephrology. This was primarily in our medicine department. I was also part of this study. This is data on about 200 odd AKI, and we specifically looked at community-acquired AKI, defined as those people who, when they came to the emergency or when to the OPD, they already came with AKI, or they developed AKI within 24 to 48 hours of getting admitted. Those were classified as community-acquired AKI, and we categorize them into infective and non-infective etiology. So if you look at it carefully, almost half of them are infections and slightly more than half are non-infectious etiology. Right? So what are the infections in this again is community-acquired. It is not all AKI. So community-acquired AKI infections, most common seems to be UTI. This is not just simple UTI. A good number of them are acute pyelonephritis, often bilateral, pneumonia, acute gastroenteritis, sepsis, scrub typhus, cirrhosis with infection like SBP, not just cirrhosis, cellulitis, febrile illness, malaria, leptospirosis. So it is evident that this pattern is not going to be the same all through India, and it is going to be different from other countries. A significant proportion of these infections are tropical, like for example, gastroenteritis, usually infective diarrhea, scrub typhus, malaria, leptospirosis, and it is also different from other parts of India. Malaria, leptospirosis have become very uncommon in our part of the world, whereas it may be more common in other parts of the country. Non-infectious causes, again, significantly. Actually, if you look at any individual cause of AKI in this study population, the highest number was snake bite. This is again peculiar to our situation, where we cater to largely an agrarian population. The adjacent districts are all mainly farming districts. It may be different in urban centers and other states. So again, the point is the etiology is different from other parts of the country. It is definitely different from other countries which are high income countries, and a significant proportion, at least half of the community-acquired AKI seems to be attributable to some form of infection. It may be hospital-acquired or it may be community-acquired infections. What about AKI in the ICU? So this is another study done by my colleague, Dr. Priyamvada, and this again was published in the Journal of Nephrology. Again, around 200 patients, total 236, and we categorize them also into community-acquired and hospital-acquired AKI. Only those people who get admitted in the ICUs. You know that a good proportion of people with, say, scrub typhus, lepto, snake bite AKI don't get admitted in AKI in a government facility like ours because they are otherwise hemodynamically stable. So here, if you look at it, the most common causes seems to be sepsis, trauma, acute abdomen, and cardiac, right? So this is not exactly tropical causes for infections or AKI, and some similar to what I think would be seen in a high-income country. So I would also like to emphasize that point. India cannot be considered as homogeneous, right? We have features of both the features of high income population as well as the low income. So it depends upon where do you look for the cause of AKI. If you are in a government facility catering to the lower socioeconomic strata, you are likely to see a different spectrum of AKI. And if you are in a hospital which caters to wealthy sections of the society, you are going to see a different spectrum of AKI, different spectrum of infections, and that will be somewhat similar to what you will see in the wealthy countries. Okay, so this is the spectrum what we saw in the ICUs in JIPMER. So this is about adults. What about children? Is the spectrum any different? Are infection a significant contributor? This is a paper my colleague from JIPMER in pediatric nephrology, Dr. Sriram. This is a highly cited paper, in fact, published quite some time back. He looked at, he tried to catch all people in pediatric ward and ICU who developed AKI. And around 5% people in the ward developed AKI. It was 25% in the pediatric ICU. Look at this, 55% were directly attributable to infections in the form of pneumonia, diarrhea, sepsis, dengue, even scrub typhus in children. And if you look at it, glomerulonephritis is classified separately here, but a significant proportion of these GNs were infection-related glomerulonephritis. So what this means is that at least 60-65% of AKI in children in Pondicherry and adjacent parts of Tamil Nadu were attributable to infections either directly or to indirectly to infection-related glomerulonephritis. So infection again plays a significant role in AKI in children. So that is about the burden. It is an important, I think it's evident that it is a significant proportion of AKI are the result of infections, some sort of infection. So how do these infections produce AKI? There are mechanisms are too numerous. I cannot describe each and every mechanism. I will just list these mechanisms. Some of them are well known, like for example, hypoperfusion. It may be from shock, from blood loss, diarrhea, fluid loss, or it may be redistributive shock. It may be from heart failure. So hypoperfusion is well known. Venous congestion is what was not well recognized earlier, but at least for the last 15-20 years, we know that in cardiorenal syndromes, the worsening renal function or AKI is not just from hypoperfusion of the kidneys, but also from venous congestion, abolishing the perfusion gradient between renal artery and the renal vein across the glomerulus and thus reducing the GFR. So this is an important cause of AKI. Toxins can directly damage the kidney. Sepsis has multiple pathways. Not all things are still well known, but there are quite a few. Intra-abdominal hypertension or compartment syndrome following abdominal catastrophe is a well-recognized cause for AKI. It may be immunological, like in infection-related GN obstructions can produce AKI from extrarenal or even renal tubular obstructions. But there are less well-recognized also, like for example, direct invasion of the kidney, leptospirosis, mucormycosis, very unusual but well-reported, and even COVID-19 is supposed to be playing a role. Hypoxia of the kidney as well as hypoxia of other tissue can contribute to developing AKI, and something called renal compartment syndrome, which is being increasingly recognized as a cause of AKI. If you look at the pathology in infections, it's again evident. This is from a review recently published by Dr. Narayan from SGPGI. Each of them are known to produce. So basically, the pathology may be glomerular, tubular, interstitial, or vascular. So any compartment of the kidney, same infection in some people may be predominantly it may be ATN, but it can also manifest as a glomerular disease or a tubular interstitial disease. So all renal compartment can be involved, be it glomerular, tubular interstitium, or vascular compartments can be involved in infections, either directly or indirectly. And often AKI in infections are multifactorial, and that is also, I think, a very important thing to understand. When we think it is just from one reason, either drug, it may not be so. So let us talk about tropical infections and AKI. This is from a chapter we wrote some time back. I wrote along with Dr. Veganand Jha. Here we try to list out all the common causes for tropical AKI, which is specific for tropical regions, and categorize them into infections, different types, then plant and fungal toxins, animal poisons, chemical toxins, environmental toxins. So it is possible to categorize, even though this is not, you may not find all this in standard nephrology or medicine books. it is possible to identify a set of AKI in specific to tropical regions, and it is also possible to recognize certain syndromes in these tropical diseases. So broadly, it can be infections, envenomations, or poisonings, obstetrics, obstetric complications related AKI, or related to indigenous and herbal medicines, which I believe is becoming increasingly common these days. Talking about the AKI syndromes in tropics, there are certain well-recognized syndromes which I think is clinically useful when we are in the community. Recognizing patterns may help us to narrow down the diagnosis. So fever and jaundice can very well be viral hepatitis anywhere in the world, but in our place, we need to think of leptospirosis, malaria, dengue, hantavirus, scrub typhus, right? So similar to that, if somebody has biphasic fever, conjunctival suffusion, thrombocytopenia, and elevated transaminases, we need to think of leptospirosis. Continuous fever, ARDS can be from pneumonia, but we also need to think about hantavirus when we are in our country. Fever, severe body ache, thrombocytopenia, acalculous pulses is very typical finding on ultrasound. We need to think of dengue fever. Fever, maculopapular rash with a scar, scrub typhus, we need to look for a scar where it is usually found in the trunk, in the groin. Fever, splenomegaly, thrombocytopenia can be malaria. Exposure to unpasteurized milk may be from brucellosis. So there are tropical, I would say syndromic presentations, patterns, if we are able to recognize, may help us to diagnose them better. Briefly about scrub typhus, this is seems to be a very under-recognized cause for AKI. The Susugamushi triangle originally was supposed to encompass the Asia-Pacific region, but now cases are being reported even outside the Susugamushi triangle. And if you look at this study from Chandigarh, it showed that 24% of patients presenting with unexplained febrile illness or multi-organ dysfunction had scrub typhus. And this widely cited study from Vellore, my good friend Basu was the lead author in this. Among 367 patients, 51% was from scrub typhus. Everything else was less than 10%, malaria, entry fever. So scrub typhus seems to be very rampant in our place. We need to be alert. We should be suspecting this. And if you also notice, the spectrum reported from Vellore, which is 150 kilometers from here, is different from what we see in Jigmar. In this review we did some time back, we try to highlight one aspect which I think is very important for the current topic of COVID-19. We know that poor sanitation, unsafe drinking water, all these are contributing or common in our country, and this is contributing to AKI. Climate here, the warm, humid climate favor breeding of vectors, mosquitoes, and other things. Poverty is well documented. Multiple studies have shown this: great personal environmental health, less well nourished, less information, less able to help. So they are susceptible to diseases and their consequences. So the point is that in our country and other low middle income countries, it is the tropical ecosystem which seems to be driving diseases, which is evident from this slide I showed you earlier also. So when we talk about kidney health for all, this also means that we need to address socioeconomic progress, which may actually help in reducing the incidence of infection-related AKI. So briefly, before I end, a couple of slides on COVID-19 and AKI. Multiple mechanisms are there producing AKI. COVID is known to involve all compartments of the kidney, like tubular injury, vascular injury, glomerular injury, interstitial disease, and there are different pathways, including direct infection. So COVID, even though it's not a direct renal infection, AKI is well described and is a result of multiple mechanisms leading to AKI. Let us look at what happened with AKI and COVID in Jipmer. We did a prospective study. This is not a retrospective data. We started collecting prospectively from July 2020, and I'm telling you the data till August 2021 with 6 months follow-up. So we admitted around 11,000 patients, out of which 556 had some sort of kidney disease. So 5%. Out of this 556, around 250 had. So this comes to around 20% had AKI. What happened to these AKI people? 45% needed dialysis, 71 were in ICU, 57 required ventilation, and 65% died. And this is worse than ESRD. Those people who were already on dialysis who developed COVID, 32% only died. So people who developed COVID and who have AKI are going to have a very bad time. And this doesn't end with the hospitalization. They tend to have poor outcomes as shown in from this data. 30% died even after they got discharged. Only 30%, 35% got discharged. Out of them, 1/3 died over the next 6 months, and a significant proportion remained on dialysis. So to summarize, I hope I have impressed upon you that infections are an important contribution to AKI, be it high income, low income country, be it hospital acquired or community acquired. Spectrum of infection may be different, but infection is important. There are multiple pathophysiological mechanisms in AKI, and any renal compartment may be involved. AKI and COVID is associated with poor short and long term outcomes, and it seems if socioeconomic progress is achieved, a significant proportion of AKI, especially tropic AKI, can be mitigated. That's all from me today. Thank you once again for having me in this program.
Thank you very much, sir, for that lovely talk on infections and AKI. I now request Dr. Ketan Mehta to introduce our next speaker, Dr. Raja Ramchandran. Dr. Ketan Mehta, are you around?
He's not able to connect, ma'am.
Connect. Okay. So I don't think he's there. So Dr. Raja Ramchandran is an associate professor in the Department of Nephrology at PGI Chandigarh, and his professional interest, he basically does a lot of work on primary glomerular diseases, and he also is interested in pregnancy-related kidney diseases too. And today he's going to talk to us about rapidly progressive glomerulonephritis, which is one of the very common causes of acute kidney injury. Over to you, Raja.
Good evening, everybody. At the outset, I would like to thank Dr. Garima and Dr. Umesh Khanna for asking me to speak on rapidly progressive glomerulonephritis, which is also synonymously called as rapidly progressive renal failure, although they don't always mean the same. Rapidly progressive renal failure is a clinical and pathological syndrome. It is one of the three syndromes of nephrology with kidney injury, the others being acute kidney injury and chronic kidney disease. Rapidly progressive renal failure can be defined as a rapid loss of kidney function over a period of days to weeks, precisely more than 14 days to less than 12 weeks. Urine examination is crucial for the diagnosis of RPRF. In the urine examination, we would look for albuminuria, which is also commonly called as proteinuria, microscopic or macroscopic hematuria. If there are more than 100 RBCs per high power field, we consider it as macroscopic hematuria. Dysmorphic RBCs means RBC of various shapes, and RBC CAS points towards a glomerular origin of the RBCs. Histopathological examination is critical for the diagnosis of rapidly progressive renal failure, as the treatment is further decided based on histopathology. Even among the histopathology, it is the immunofluorescence that is critical, as it helps in classification and also a precise diagnosis of the etiology. In the histopathology, on the light microscopy, we would see a crescent formation in the glomeruli, which is proliferative cellular response outside the glomerular tuft and within the Bowman's capsule. That is, you will find layers of cells in the Bowman capsule. Initially, it could be the lymphocytes, neutrophils, and later on, it could be the parietal epithelial cells and the fibroblast. Why is rapidly progressive renal failure important? Rapidly progressive renal failure is important as you have a rapid loss of kidney functions and they are a potentially reversible cause of kidney injury. And if not treated, they would result in high morbidity and in turn result in high mortality rates. So, what are the secondary features that one would see in a patient with rapidly progressive renal failure? Most of the times, they are a part of the secondary syndromes. Like you should look for cough, asthma, or hemoptysis in a patient with vasculitis, abdominal pain, infection, and or pancreatitis in a patient with vasculitis or hemolytic uremic syndrome. Hematuria and oliguria could be a part and parcel of the RPRF itself. Skin rashes again could be a feature of vasculitis. It could be an IgA vasculitis or it could be an MPO vasculitis. Then you could have Raynaud's phenomenon as a part of the vasculitis like lupus or a part of systemic sclerosis. Then other features that could suggest granulomatous polyangiitis is hoarseness of voice, presence of ENT problems like tracheal ulceration, nasal crusting, blockade of the nose, nasal deformities, epistaxis, and hearing impairment. So after the symptoms that one should ask in a patient with rapidly progressive renal failure, how do you investigate a case of rapidly progressive renal failure? The investigations would be a complete blood count, especially the differential count. Eosinophilia could be a feature of medium vessel vasculitis. Serum renal function test mainly urea, creatinine, electrolytes. As previously mentioned, urine routine microscopy where you will mainly see for the albuminuria and RBCs. And urine for PCR when you suspect certain infections like tuberculosis. Chest X-ray followed by high resolution contrast tomography of the chest if required. Serum complement levels. ANA and dsDNA in a patient with lupus. ANCA titers in patients with suspected MPO or PR3 ANCA-associated vasculitis, anti-GBM antibody in a person with anti-GBM disease suspicion, serum cryoglobuline levels, rheumatoid factors, and viral markers mainly for hepatitis B, C, and HIV as they are associated with vasculitis and also they could directly cause rapidly progressive renal failure because of the deposition of the immune complex or involvement of the kidney directly. What are the ancillary investigations that one would do? In a patient with tracheal issues, you would do a bronchoscopy to look for suspected stenosis, mainly in a patient with granulomatous polyangiitis, ENT evaluation as suggested by the syndromes, as suggested by the symptoms mentioned in the previous slide, nerve conduction study in a patients with polyarteritis nodosa or those with microscopic pan and eosinophilic granulomatous polyangiitis. Echocardiography. Infective endocarditis itself could cause rapidly progressive renal failure because of the deposition of the immune complex or activation of the immune system. In a patient with polyarteritis nodosa, we would require an angiography of the involved system like the GI tract or the CNS. So how do you classify rapidly progressive glomerulonephritis? Rapidly progressive glomerulonephritis could be classified based on immunofluorescence testing in the serum and also on the kidney biopsy. So type 1 is presence of linear deposits along the glomerular capillary loop on the kidney biopsy, which is suggestive of anti-GBM disease, which involves the kidney and the lungs in the form of pulmonary hemorrhage. Type 2 is immune complex, which is seen in about 40% of the cases. It is infection related. You have immunoglobulin G, A, M, and complements on the kidney biopsy along the glomerular capillary loops. They could be infection related or autoimmune like SLE, IgA vasculitis, cryoglobulinemia. Then the third type is pauci-immune, where there is no immunofluorescence or there is pauci-immunofluorescence on the kidney biopsy, which is seen in 50% of the patients. And the common examples include granulomatous polyangiitis, microscopic polyangiitis, eosinophilic granulomatous polyangiitis, or a renal limited crescentic glomerulonephritis. Fourth is a double antibody positive, that is, you could have an anti-GBM positive and an ANCA positivity. Their prognosis is in between an anti-GBM disease and an ANCA-associated vasculitis generally. Then the fifth one is pauci-immune glomerulonephritis without ANCA positivity. This is a rare clinical condition which usually restricts presentation to the kidney alone. This is the RPGN classification. You could have other causes of RPRF like tubulointerstitial nephritis and thrombotic microangiopathy. Now I would take you through three cases where I would demonstrate, RP, RF because of glomerular, tubulointerstitial and vascular causes. The first case is an interesting case of a 23-year-old man who presented with fever of 2 months etiology, had shortness of breath, had B symptoms in the form of loss of appetite, night sweating, and there was also swelling of the lower limbs, which was there for 2 months, and progressive blurring of the vision. So, a urine examination, fundus examination, and chest X-ray followed by a CT was performed. Urine examination revealed 2+ albuminuria, 30 to 40 RBCs, 10 to 20 WBCs per high power field. The serum creatinine was 3.2 milligram per deciliter. The fundus examination, if you see, you could see various yellow color nodules on the fundus examination, and the chest X-ray and the chest CT revealed a miliary pattern. So a kidney biopsy was done. The patient did not produce any sputum. A kidney biopsy was done. The kidney biopsy revealed multiple epithelioid granuloma. Tubulointerstitium was densely infiltrated with lymphocyte and eosinophils if you see carefully. And also an AFB staining was done which revealed multiple acid-fast bacilli, a gene expert testing suggestive of Mycobacterium tuberculosis. The patient was started on antituberculous therapy and steroids. At 3 weeks, his serum creatinine dropped down to 3.5 to 0.9 milligram per deciliter. The next case is a 43-year-old gentleman who had complaints of weight loss and hypertension for 2 years, suddenly developed anuria, was evaluated, found to have anasarca and hypertension and albinuria and erythrocyturia on his urine examination, was initiated on dialysis at a local center, and then a kidney biopsy was performed. After the kidney biopsy was performed, it was suggestive of dense deposit disease, and a serological evaluation revealed low complement level. The CFH levels was low, normal complement factor B and C3 nephritic factor, and a negative anti-CFB. The genetic testing revealed mutations in the complement factor H. The patients developed a pulmonary hemorrhage during the hospital stay, received plasma exchange with steroids, caught up with healthcare associated infection, and succumbed to his illness. Post-mortem, we did a biopsy of his lung, which suggested thickened pulmonary capillary loops with C3 deposits being positive. Electron microscopy showed deposit in the capillary membrane. So this is a case of C3 glomerulopathy, which is a dense deposit disease on the light and the electron microscopy. So the first case was a case of tubercular tubulointerstitial nephritis. The second, which involved the tubulointerstitial compartment. The second case is a case of crescentic GN because of dense deposit disease. It is a glomerular. It involved predominantly the glomerular part of the nephron. The third case is an interesting case, is a case of a patient with pain abdomen. A 23-year-old male with pain abdomen and jaundice had an elevation in the AST more than the ALT. He had pancreatitis as suggested by elevated amylase and lipase. The serum creatinine was elevated. He was initiated on dialysis, and his serum LDH was positive. It was elevated 7 times the lab limit. His peripheral smear examination revealed 2.3% cystocytes. A diagnosis of hemolytic uremic syndrome was being made. He had acute pancreatitis and rapidly progressive renal failure. Along with dialysis, we initiated him of plasma exchange. Prior to plasma exchange, we tested him for anti-CFH, which was positive, and anything more than 100 is high positivity. This patient had a titer of 113 angstrom units per ml. Post plasma exchange, it settled down to 45 reference unit per ml, and the patient was started on rituximab and methylprednisolone along with plasma exchange, and the serum creatinine at the last follow-up is about 0.9 milligram per deciliter. The patient continues to be on rituximab and steroid maintenance. So the first case is a tubercular tubulointerstitial nephritis involving the tubulointerstitial part. Second one is the glomerular part, a C3 glomerulopathy with crescentic gene. The third one is vascular in the form of hemolytic uremic syndrome affecting the vascular along with the glomerular part of the nephron. Coming to the last slide, treatment of rapidly progressive renal failure. In the past, there used to be a blanket therapy in the form of one size fits all. Crescentic GN were all treated with IV cyclophosphamide and steroids. Currently, it is more of an etiology-based treatment. So, the learning lesson is RPRF is commonly due to glomerular disease, but can also be because of tubulointerstitial nephritis and vascular disease. Kidney biopsy is the key for diagnosing, especially the immunofluorescence microscopy. The treatment is guided both by morphology and pathogenesis. There is no one-size-fits-all approach. Rapidly progressive renal failure is reversible, or I would say potentially reversible if diagnosed early and treated appropriately. Thank you for the patient hearing.
Thank you very much, Raja. We now move on to the next lecture, which is going to be taken by Dr. Zahir Virani from Bombay. And Dr. Zahir Virani is going to cover drug-induced AKI. And he is a consultant nephrologist and a transplant physician at multiple corporate hospitals in Bombay. And most importantly, he's one of the, the person in need these days. He's one of the task force members of the Maharashtra COVID task force. Over to you, Zahir.
Good evening. Thank you for this opportunity to present drug-induced acute kidney injury. My name is Dr. Zahir Amin Virani. I'm a consultant nephrologist and transplant physician from Mumbai. So we will start with the case. Mrs. SM, a 63-year-old female, known case of hypertension, coronary artery disease, ischemic heart disease, who underwent a CABG and AVR done in 2008 and had hyperthyroidism, came with complaints of sudden onset breathlessness, left arm heaviness, and profuse sweating. She was conscious oriented. Her blood pressure was 200 by 100 mm of Hg. She had a heart rate of 140 beats per minute. She had bilateral basal crepitations with a respiratory rate of 42 per minute and an oxygen saturation on room air of 88%. She was started on non-invasive ventilation. The APG showed respiratory and metabolic acidosis. She had oliguria with a poor response to diuretics. The ECG showed an atrial fibrillation and with a fast ventricular rate. Was advised cardioversion, but the relatives were not willing. The TROP-I was positive. The 2D echo showed moderate aortic regurgitation with a paravalvular leak with an ejection fraction of 30%. She was in cardiogenic shock. She was intubated, sedated, and started on vasopressors. Blood transfusions were given as her hemoglobin was low. She was extubated the next day and started on non-invasive ventilation. Her chest X-ray showed bilateral haziness with a blood culture growing Staphylococcus hominis. This is her discharge summary. She was treated with gentamicin 40 milligrams thrice a day, vancomycin 750 milligrams alternate day, furosemide 40 milligrams QID. She was started on Vimada, which is valsartan and sacubitril, Oxra, which is dapagliflozin, Eptus, which is eplerenone, and Zytanix, which is metolazone. So as you can see in this slide, she was on an aminoglycoside, vancomycin, a loop diuretic, an ARB, an SGLT2 inhibitor. Eplerenone is basically a spironolactone-like drug, and Zytonex, which is metalazone, is a thiazide-like diuretic. This is her discharge summary. So now we will go into the phenotypes of therapeutic drug-induced acute kidney injury. You require a knowledge of whether the drug itself can cause the acute kidney injury or not. Majority of the drugs can cause something known as an allergic interstitial nephritis, but there are common drugs like your NSAIDs or your aminoglycosides or vancomycin, which are known to cause acute kidney injury in quite a few patients, and especially in the elderly and patients with chronic kidney disease. What is the mechanism of injury? It could be because it is causing a damage to the glomerulus, could be because it is causing damage to the tubules, the interstitium, or it could be a vascular problem where you could have renal vasoconstriction. The time course. Certain drugs cause acute kidney injury after 3 to 5 days. Certain drugs cause them immediately. But if a drug was given 3 months in the past and has not been in chronic use, then that is unlikely to be the cause of the acute kidney injury. An assessment of competing risk factors. This means that if a patient is on an aminoglycoside and vancomycin and then gets contrast, it is a multifactorial injury to the kidney, and all 3 drugs are known to cause acute kidney injury. Now, the injury could be at the tubular level, the glomerular level, the interstitial level, or at a level which is in the tubules where they get blocked because of nephrolithiasis. So if it is a tubular injury, it could be cytopathic or toxic. This is due to mitochondrial damage. And this is commonly seen with aminoglycosides, toxins like contrast or vancomycin. Interstitial would be inflammatory, which is basically a hypersensitivity reaction to proton pump inhibitors and penicillin. Glomerular could be nephritic, nephrotic, or a thrombotic microangiopathy. Nephritic syndrome is the presence of RBCs in the urine, hypertension, and plus minus acute kidney injury. Nephrotic syndrome is the presence of nephrotic range proteinuria in the urine with hypercholesterolemia and hyperalbuminemia. As you can see here, the drugs which are known to cause this are bisphosphonates, calcineurin inhibitors, and hydralazine. Also, NSAIDs are known to cause nephrotic syndrome. Crystal induced is basically the intracellular deposition or the intratubular obstruction. It could be osmotic, obstructive, or epithelial cell toxicity, and it could be due to your heart therapy, which is indinavir or sulfa or orlistat, which used to be used for loss of weight. There are certain drugs which cause rhabdomyolysis, which commonly used ones are statins, which are your rosuvastatin and atorvastatin, your fenofibrates, which are fibric acid derivatives, your SSRIs, your tricyclic antidepressants. So the drug-induced rhabdomyolysis is due to dehydration, due to the occlusion of the tubules because of tubular class, due to myoglobulin toxicity, which causes free radical injury to the tubules, oxidant injury, or vasoconstriction. Now, the most commonly used drug over the counter and in all over the world maybe would be an NSAID. Now, NSAIDs cause different types of acute kidney injury. They could be hemodynamically mediated acute kidney injury. It could be electrolyte and acid-based disorders. It could be an acute interstitial nephritis. It could be nephrotic syndrome, or it could be papillary necrosis. The new COX-2 inhibitors or the selective COX-2 inhibitors like eterocoxib, piroxicam, when they came in, they were sort of told to the general public and us doctors that they do not have the same traditional nephrotoxic side effects of NSAIDs, but these two cause acute kidney injury, edema, and electrolyte disorders. The acute kidney injury of NSAIDs is basically asymptomatic. It occurs within 3 to 7 days of therapy. The urine analysis is actually negative for hematuria and proteinuria. Chronic NSAID use is defined as use of NSAIDs almost every day for 30 days or longer. The recovery of acute kidney injury secondary to NSAIDs depends on whether there are confounding factors like an obstructive nephropathy in the form of a renal stone, or whether there was a concomitant use of aminoglycosides, vancomycin, or whether the patient is in sepsis. If it is a truly hemodynamically mediated NSAID use, then the recovery normally occurs within 3 days. Failure to recover or progression of NSAID-induced acute kidney injury beyond 7 days, one should do a biopsy. Or if the urine analysis shows atypical pictures like nephrotic range proteinuria, dysmorphic RBCs, or RBC cast, then one should do a kidney biopsy. Contrast-associated and contrast-induced acute kidney injury, there is a mild increase in serum creatinine within 24 to 48 hours, and it typically decreases after 7 days of exposure. It is non-oliguric. If it is oliguric, then one should look for other causes, or it indicates a severe acute kidney injury, or there was already a severe chronic kidney disease at baseline. The urinary sediment usually shows muddy brown granular and epithelial cell cast and free renal tubular epithelial cells. Basically, it shows the features of acute tubular necrosis. Absence of urinary findings obviously does not exclude a diagnosis of contrast-associated acute kidney injury. The rise of serum creatinine is, like I mentioned, within the first 24 to 48 hours, and one should rule out other causes of acute kidney injury if there is a slowly progressing acute kidney injury, or there is a oliguria, or there is anuria. So what is the differential diagnosis? One is renal arthroemboli, the other is ischemic ATN, third is acute interstitial nephritis, and one should make sure that these patients are not over-diuresed or on ACE and ARB. One question which is asked to us all, nephrologists, radiologists, and even family physicians is, a patient with chronic kidney disease, is gadolinium safe? As you can see, the newer gadoliniums, which are the ACR 2 and 3 types, are basically pretty much safe in acute kidney injury and even in chronic kidney disease. The risk of nephrogenic systemic fibrosis is very low for a standard dose of group 2, the gadolinium, which is point number 7 here, even if the GFR is less than 30. That's point number 7 here. One should make sure that whenever you do this, this is explained to the patient. But if it is indicated and if it is going to be therapy changing or life changing, then one can use gadolinium even if the GFR is less than 30. So fenofibrate associated nephrotoxicity is often not recognized. It could be pre-renal from fenofibrate effects on the skeletal muscles, or it could be on the renal hemodynamics via the defects in the vasodilatory prostaglandin production. Or like most drug-induced acute kidney injuries, it is reversible. And if fenofibrate-induced drug injury occurs, and if you have to absolutely use a fibric acid derivative, then you can use gemfibrozil. Aminoglycoside nephrotoxicity, the rise in the serum creatinine occurs after 5 to 7 days of therapy. It is non-oliguric due to the loss of the concentrating ability in the distal tubular due to distal tubular damage. The urine sediment usually shows mild proteinuria, hyaline, and granular cast. Other electrolyte abnormalities are also known with the aminoglycoside nephrotoxicity, like hypomagnesemia, hypokalemia, hypocalcemia, and hypophosphatemia. It can also cause a proximal tubular damage, therefore leading to a Fanconi-like syndrome with glycosuria, aminoaciduria, phosphaturia, and uricosuriia. The hypomagnesemia can lead to secondary hypokalemia and hypocalcemia. The course is basically normally, if it is isolated aminoglycoside nephrotoxicity, one recovers within 21 days of cessation of therapy because the proximal tubules tend to regenerate. The recovery also depends on whether you use concomitant medicines like furosemide, NSAIDs, and ACE inhibitors. The type of aminoglycoside also matters, with gentamicin being the most having the greatest nephrotoxic potential, followed by tobramycin, amikacin, and netilimycin. So in aminoglycoside nephrotoxicity, the once daily dosing programs are much safer, both in form of nephrotoxicity also. It also gives you the advantage of the concentration dependent bactericidal activity and post antibiotic effect of aminoglycosides. ACE-ARB is another very commonly used drug of choice for diabetic nephropathy with significant proteinuria. One should check the renal function 3 to 5 days after the ACE-ARB has started. The termination of ACE-ARB should only be considered if the creatinine has increased by more than 30% of the baseline. And one should also look at the potassium levels in these cases. So if there is refractory hyperkalemia, or if the GFR or has decreased by more than 30% of the serum creatinine has increased by more than 30%, then one has to look at it as an alternative. One has to also make sure that the patient is not volume depleted or on high dose diuretics or another nephrotoxic agent has not been used, and also rule out renal artery stenosis. Vancomycin is also known to cause acute kidney injury, and it is because of acute tubular injury and necrosis and acute interstitial nephritis. So one has to make sure that whenever one is using vancomycin, one also monitors the serum creatinine levels. Now, trimethoprim sulfamethoxazole is a very commonly used drug available as Septran. The trimethoprim inhibits the proximal tubular secretion of creatinine and results in elevation of the measured serum creatinine. But this is not a true drop in the GFR. Also, trimethoprim is known to cause hyperkalemia, and this is due to it inhibits the epithelial sodium channels at the distal convoluted tubule, which actually provides the driving force for potassium secretion. AKI can also occur due to the sulfa component, and in this case, it could be allergic interstitial nephritis. It could be a crystal nephropathy, where in the urine microscopy, you will see bifringent needle-shaped crystals, or this crystal nephropathy occurs in acidic urine and in low flow states. Warfarin-related nephropathy, one of the most commonly used oral anticoagulants in our time, basically occurs normally in patients with chronic kidney disease and a persistent INR of more than 4. It is due to excessive anticoagulation and hematuria seen. A definitive diagnosis is made on the basis of a renal biopsy. Vitamin C came into vogue because of our COVID pandemic, and it was used by multiple specialities, including physicians, family physicians, intensivists, and it gave rise to a large amount of patients who developed something known as an oxalate nephropathy, which is basically the tubular crystalline deposits of calcium oxalate, which led to acute and chronic tubular injury, interstitial fibrosis, and in certain cases, even progressive renal insufficiency. So vitamin C is not as harmless as it seems to be. Finally, the magic drug, the drug which everybody is using nowadays, SGLT2 inhibitors, it induces a modest decline in the GFR of 3 to 5 ml per minute per 1.73 meter square. And this is due to the proximal tubular natriuresis effect on the tubular glomerular feedback. It is a reversible intra-renal hemodynamic effect because of the afferent vasoconstriction. It is a very safe drug, and it is now, multiple studies have shown that it does not predispose to acute kidney injury, and it can be started in patients who have an eGFR more than 30 ml per minute per 1.73 meter square. Last but not the least is mannitol, one of the favorite drugs of our neurosurgeons and neurologists. In moderate doses, it causes volume depletion and hypernatremia, but in high doses, it basically increases the plasma osmolarity, causes a shift of fluid, water and potassium out of the cells, causing extracellular fluid volume expansion, can cause hyponatremia and dilutional metabolic acidosis and hyperkalemia. Thank you for your patient hearing.
Thank you for that talk. And our last speaker for this session is going to be Professor Manisha Saha. She's a professor and head of Osmania Medical College, Hyderabad. She's also editor-in-chief of the Indian Journal of Transplantation and deputy chair of the CME Committee for the International Society of Nephrology. She's also held multiple positions in nephrology and transplant societies in India, including Indian Society of Organ Transplant, Indian Society of Nephrology, as well as International Society of Nephrology. And her talk is going to be on obstetric AKI. Over to you, Dr. Manisha Saha.
Yeah, just a second. Yeah, share the screen.
You're able to do it now?
No, just a minute, just a minute.
Okay.
Just a minute, bear with me. You just put it on the...
Yeah, you see the share screen button on the bottom of the
Yeah, I'm
screen?
seeing that. So just a second.
Okay.
I think it will, yeah, there was some internet problem. Yeah. Yeah, sorry for that. I think I can share now. Yeah. You can see it now?
Yes, ma'am, it's visible, yes.
Okay. So at the outset, thank you for giving me this opportunity to talk to you about pregnancy-related acute kidney injury. We all know motherhood completes womanhood, and pregnancy-related AKI is one of the biggest barriers to motherhood. Now here, many of the physicians would be thinking, in a conference of IMA, what's the role of physician in management of PRACI, the pregnancy-related AKI? So I would like to say that pregnant females are under follow-up with physicians, GPs, healthcare workers, OBGYNs, practically everyone. And many PHC CSCs are manned by physicians. So I feel all of us should know very well about pregnancy-related AKI. It's one of the leading causes of AKI in developing countries. It's increasing in developed world as well. It's associated with significant fetal-maternal morbidity and mortality. And it has significant long-term effects, not only short-term effects, long-term effects, not only in the mother, but also in the baby as well. How do we define AKI in pregnancy? Is it any different from what talks we've heard? No, it's nothing different. It's again, the creatinine criteria and urine output criteria by KDIGO. And simply said, more than 0.3 milligram per DL rise in creatinine on a follow-up urine output. That's what is presently most accepted. And we talk about the severity of AKI. This also is not much different. Again, the stages of AKI remain the same in pregnancy, though there are some lacunae, but as of now, this is the accepted definition. So now, as a physician, you may encounter a pregnant lady who comes to you in first trimester. And her creatinine at this point of time is, say, for example, 1. So will you be happy with this report of 1 creatinine? Remember, in pregnancy, the creatinine normal values are lower, and 1 creatinine may not be normal, because generally in a pregnant lady, the creatinine values are around 0.4, 0.5. So this female will need some investigation. So that's the first clinical pearl. Creatinine values are lower in pregnancy. Check for previous records or repeat. Is pregnancy AKI common that we are discussing it? Yes, it's common. In 2000, almost 30% of all AKI was pregnancy AKI. Happily, in India, it's come down. It's around 5% of all AKI now. In the developed world, however, the pregnancy AKI, which was around 0.1% in 2000, has gone up 3 times. It's 0.3% now. So in developing world, though it's increasing, developed world, though it still remains low, it's gradually showing a rise. And why is this happening? In developing world, it's come down because of the legalization of abortions. So most of the pregnancy AKI was septic AKI, abortion-related AKI, that has come down. And also because of improved quality of care. Whereas in the developed world, why it's going up? Quite logical, because the age of reproduction has gone up. There are more assisted deliveries. And many of the females have comorbidities at the time of conception. They may be diabetics, hypertensives, and maybe because of increased surveillance. And this picture somehow will come in India as well, where the reproduction is getting delayed in our country as well. So you can see, as compared to the developed world, in the developing countries, we have 10 times as high obstetric AKI as a cause of acute kidney injury. What is the cause of acute kidney injury? We have heard of acute kidney injury causes throughout the talk, wonderful talks. Is it anyhow different in pregnancy? So in pregnancy, you can have pre-renal AKI, you can have renal AKI and post-renal, which Dr. Urmila has discussed. Most of the causes are the same, but I would like to focus on some pregnancy-specific causes. And the ones in the red curly brackets are the pregnancy-specific causes, where you can have preeclampsia, you can have thrombotic microangiopathies, acute fatty liver of pregnancy, and renal cortical necrosis. So there are some unique causes which are unique to pregnancy. But remember, at the same time, any other cause of AKI can occur in a pregnant woman as well. And coming to the pregnancy-specific causes, which I talked about, some of them can occur in early pregnancy, for example, septic abortions and hyperemesis gravidarum, and some can occur peripartum. For example, preeclampsia, one of the most important causes. You also have thrombotic microangiopathies, TTP-HUS, you can have acute fatty liver of pregnancy, puerperal sepsis, and antepartum and postpartum hemorrhage. So just remember these causes, because these are the important causes. The peripartum ones are the ones which we commonly encounter. So now we have a case which comes to a physician in early pregnancy with a history of abortion few days ago, and she has come with AKI. So obviously there is no major differential diagnosis here. It's probably related to the septic abortion. Nowadays it's not common because of legalization of abortion. So generally these types of AKI used to have a bad prognosis. They were generally because of Clostridium organisms, and the lady presented with fever, sepsis, hypotension, so on and so forth, and treatment was antibiotics and hysterectomy. So any pregnant lady coming to you early trimester, first trimester with a history of abortion and AKI, keep this in mind. The important differential in first trimester is hyperemesis gravidarum, which occurs due to excessive vomiting, but it is not very common in our country. Now let us come to the main AKI under discussion in pregnancy, of which all of us are terrified of. You have a 28-year-old female. She comes to you at 33 weeks of gestation. She is detected to have high blood pressure. Urine output has decreased. Hemoglobin is 8. Platelet count is low. Creatinine 3.5. You can see 3+ protein, and her liver enzymes are all up and down. So this is the picture generally we get. Peripartum lady. Some of them come antepartum. Some can come after delivery as well. And this is the scenario where you need to find out what is the cause. In most of the cases, the cause is obvious. This is a clinical history of preeclampsia most of the times. And preeclampsia associated with seizures, you have eclampsia, and you can have AKI in these situations. There are other differentials as well, about which I'll be talking about. But let us first know about this preeclampsia, because all of us as physicians or OBGYNs or nephrologists or GPs will be encountering this entity. So generally it occurs in more than 20 weeks after gestation. And we recognize it by 140/90 blood pressure and above taken on 2 occasions. Usually we see it in priming. It can occur mostly antepartum or even postpartum. And traditionally we used to say that proteinuria should be there, either equal to or more than 300 milligram per day. So diagnosis is easy. Any lady coming in the latter half of pregnancy with proteinuria and hypertension, we called it preeclampsia. But now the concepts are changing, that you can have preeclampsia without proteinuria. So a lady coming to you with hypertension, but with any other organ dysfunction, CNS dysfunction, pulmonary edema, vision abnormalities, abdominal pain, you can still think of preeclampsia. So even without proteinuria, any organ dysfunction, platelet count low, hematological dysfunction, hepatic dysfunction, enzymes elevated, or renal dysfunction. So any of these are defining criteria for preeclampsia, even in the absence of proteinuria. So this is important to know. So don't always look for proteinuria. Try to find out evidence, signs, or symptoms of organ dysfunction if the lady comes to you with hypertension, which may be a common scenario. Now we talk about HELP syndrome. HELP syndrome is something like preeclampsia, and it is somewhat severe form of preeclampsia, to put it simply, where you have hemolysis defined by criteria, you have elevated liver enzymes, and you have low platelets. And again, the HELP syndrome has more people coming with AKI. So it's important to use this term, look for this constellation of findings, and look for renal failure in these patients. The treatment is we generally stabilize the patient, and the HELP syndrome and preeclampsia, they improve after delivery most of the times. So this is the most important causes of brachy. We know the etiology lies with a defective placentation, and this defective placentation leads to increase in the pro-angiogenic factors and decrease in the other elements. And this causes vasoconstriction, it causes liver damage, hepatitis, can cause kidney damage. Simply put, the placenta seems to be the culprit. You have high anti-angiogenic factors, which we all know now, SFLT, endoglin, fibronectin, and you have low pro-angiogenic factors, PIGF and VEGF. So why we should little bit know about these? Because now they may become commercially available as early biomarkers of preeclampsia. So these are the new markers, which I already said, SFLT, PIGF, endoglin, fibronectin, etc. The important thing is, in some of the guidelines for definition of preeclampsia, they have included this as a part of the definition. So you may have high blood pressure, you may be in a confusion with the other differentials. You can use these biomarkers for diagnosis as well. So this is an important point. So fine, you have diagnosed preeclampsia. What is your role as a physician? So the 4 Ds. You look for drugs to control the BP, you look at diet and fluid, you plan whether you have to refer the patient for delivery, and dialysis, whether it's required for that pregnant lady. So regarding diet, salt restriction, yes, but moderate, not severe salt restriction. Rest, exercise and work as for healthy pregnant women. Except in severe preeclampsia, there is no need for a bed rest. Aspirin, calcium are given for proteinuric patients for prophylaxis. Drugs, what you should use are labetalol, methyl-dopa. You can use calcium channel blockers. These are the main drugs which are used. ACE and ARBs are not to be used, which we are all very well aware. So as a physician, you have diagnosed preeclampsia. You have started the lady on these antihypertensive medications. What do you do? Some ladies may come with nephrotic proteinuria. That's the most often asked question. So all nephrotic proteinuria may not need admission. The commonest cause of nephrotic proteinuria in pregnancy is preeclampsia itself. And we did not use steroids for treatment. And as far as possible, we avoid diuretics. The patients may not need admission if they are stable. We monitor the fetal and maternal status. When do we hospitalize? So if the blood pressure is not getting controlled, if platelet count is low, liver functions are more than 2 times enzymes upper limit of normal, creatinine is high, immediate eclampsia, imminent eclampsia, pulmonary edema, these are some of the indications of admission. Otherwise, a preeclamptic woman you can manage in your OP. If these indications are present, you refer to the gynecologist or you admit the patient. Suppose the pregnant lady comes with a creatinine of 5. What do you do? Is dialysis possible in pregnancy? Yes, dialysis is possible if severe azotemia, if creatinine is more than 5, urea more than 100, if dyselectrolytemia, metabolic acidosis, encephalopathy or pericarditis. Remember that Dialysis should be done gradually. Daily dialysis is better. Gradual removal of ultrafiltration should not remove too much of fluid suddenly. Fluid shifts should be minimal. Peritoneal dialysis is not recommended generally in the third trimester. Hemodialysis is the way to go if the lady needs dialysis. What about timing of delivery? If the preeclamptic lady is more than 37 weeks, go for delivery. Do not wait. If less than 34 weeks, expectant treatment is better as far as possible, but monitor the fetus and the mother. And between 34 to 37 weeks, again, it may be an expectant treatment. You may wait or may plan for delivery depending on the fetal and maternal status. So what are the indications when you go for an urgent delivery, irrespective of the period of gestation? These are some conditions where BP is not controlled more than 160/110, fetal abnormalities on CTG, diastolic reversal on Doppler, any evidence of organ dysfunction, worsening CNS symptoms, or abruptio and fetal distress. So whatever be the duration of gestation, you have to terminate for the sake of mother. If the woman has completed 37 weeks, there is no point in delaying. Too much delay is counterproductive. Go ahead and terminate. So don't continue preeclamptic pregnancy beyond 37 weeks. So these are your duties as a physician. So you have recognized preeclampsia, you have guided the patient, controlled her blood pressure, managed her diet, you have sought nephrologist opinion if the creatinine was high, and you have referred for hospitalization when she needed immediate delivery or if she had imminent eclampsia features. So this you've done. Any other things you should remember? Remember, most of the peripartum AKI is preeclampsia, most of it. And generally it's labeled as preeclampsia. But there are some important differential diagnoses which a physician should also be aware. Suppose this preeclampsia lady, exactly same, she comes with severe anemia, hypertension, she has a low complement, and schistocytes are there on smear. What would you suspect? Sometimes you may do a biopsy as well. So this classical picture where severe anemia, hypertension, and hemolysis, you should think of hemolytic uremic syndrome. And it's presumed that it's because of genetic abnormalities of complement. And here you should pick it up because here delivery is not the option. Many of the times it occurs postpartum. Very rarely it may be seen antepartum, but most of it is postpartum. So here, what's the treatment? Unless you give specific treatment, she's not going to improve. She's going to CKD. Specific treatment is eculizumab. So pick this up. Whenever you have a doubt, non-recovery of AKI, severe anemia, hypertension, refer to the nephrologist. Other important condition, another clinical scenario, low platelets, persistently low platelets. So here, keep in mind TTP, thrombotic thrombocytopenic purpura. It's quite rare. It occurs in third trimester, just presents like peripartum preeclampsia. Here, deficiency of ADAM-TS13 is the clinching diagnostic marker. And here also specific therapy, plasmapheresis is required. So this also you need to pick up. Third clinical scenario, exactly the patient looks like a preeclampsia, but here the jaundice is very severe. Enzymes are relatively okay, but jaundice is very severe, low blood sugars, low fibrinogen. And what do you think here? Acute fatty liver of pregnancy. So fortunately, these HUS, TTP, and AFLP are not that common. Preeclampsia is the most common, but we should be able to identify them because the treatment is different. Then another case scenario, similar presentation with peripartum AKI, postpartum AKI, with significant blood loss. And here APH or PPH would be under differentials. Another patient, peripartum AKI, but with fever, retained products, sick looking. And what would be the diagnosis? Here, puerperal sepsis causing AKI. And you have another clinical scenario, similar, you think it's preeclampsia, but here you have a lot of protein in urine along with RBC casts. So you think of some glomerular disease, and if you test serology and if it's positive, it might be for all we know lupus nephritis, or it may be a vasculitis or a glomerular disease, which Dr. Raja was presenting. And here the specific treatment would be steroids. So these may come in the guise of a peripartum AKI. You may think it's preeclampsia, but there are clinical clues which will direct us to the correct diagnosis. Another important thing, rarely we can have obstruction as a cause of pregnancy AKI. We all know the gravid uterus puts pressure and you have dilatation, physiological dilatation of the system. Most of the times nothing is required. Sometimes there may be stones causing hydronephrosis and acute renal shutdown, and stenting may be required. So this also is important to pick up the physiological obstruction as compared to a pathological obstruction in pregnancy. So ladies and gentlemen, these are important causes of AKI. Now, when do we do biopsy in AKI? We don't do biopsy in AKI generally in pregnancy unless biopsy is going to change your management. And this generally occurs in rapidly progressive renal failure in pregnancy, where specific diagnosis may be needed for treatment. If done, it's generally done up to the second trimester, not in third trimester. Postpartum AKI, when do you do a biopsy? If there is no recovery after 2 to 4 weeks, you may plan a biopsy. So role of biopsy is there in case you suspect some glomerular disease, which might be picked up on biopsy. And what would a biopsy show? Mostly glomerulonephritis, ATN, AIN, thrombotic microangiopathy, or cortical necrosis. So these are different types of histological lesions on biopsy. Mostly patients have endotheliosis if they have preeclampsia. ATN may be there. The other ones are less common. The most dreaded is cortical necrosis. As the term itself indicates, the whole cortex gets necrosed, as you can see in this. So this condition does not recover. And later on, there may be calcification of the cortex on CT. This is a bad etiology because it's devastating. Young mother, apparently healthy before pregnancy, now ends with a baby, if the baby is born at all, and a lifetime of dialysis. So cortical necrosis is a dreaded cause of AKI in pregnancy. Now, how does brachy impact outcomes? Maternal outcomes are bad, mortality is high, abruptio, DIC, longer hospitalization, more rates of cesarean, hemorrhage, all these go up. Fetal loss, 30% fetal loss, preterm baby, low birth weight, and stillbirths. So bad outcomes. And what happens to the kidney in short term? Short term, 40 to 75% recover happily, but 10% go for chronic dialysis in India. And if it's HELP syndrome, around 20% can go for chronic dialysis. So poor outcomes are associated with HELP syndrome, with cortical necrosis, septic AKI, and thrombotic microangiopathy. And what happens long term? Long term, the mothers with brachy have more risk of cardiovascular disease. They have more risk of neurological disease as well. And hence these mothers need a long-term follow-up. What happens to the baby? The small for date babies are at risk for cardiovascular disease and metabolic syndrome later in life, as well as there is increased risk for CKD because of low referron numbers because of preterm birth. So brachy affects mother and children, not only immediate outcomes, late outcomes as well. Thus, collaboration is important. And that's why this session of brachy is important. Whatever field of medicine we are working, our aim is to care for our patients. We should all work together and provide best services wherever we are, whether it's a PHC or a tertiary care hospital. A teamwork makes dreams work. And I feel a brachy registry is important to follow these patients for long-term outcomes. So remember, I conclude saying that brachy exists in developed countries as well. It's coming down in developing countries. The treatment generally depends on the etiology. Preeclampsia is turning out to be the major cause, even in developed and developing countries as well. And the 4 Ds are important, as I highlighted. Most important thing is we should also learn to identify the preeclampsia-like diseases whenever we encounter brachy, because there is a disease-specific therapy for each of these diseases. And long-term follow-up, as I said, is very important. So it's high time we follow up these patients with brachy because they cause a significant morbidity later on and are an important cause of CKD. So I again end my presentation and invite you to this ISN Frontiers meeting, which is happily happening in our country on infections and kidneys in September. So thank you, ladies and gentlemen, for a very patient hearing. Thank you.
Thank you, Dr. Manisha, for that excellent talk. And we'll open the whole session for questions to the audience here, as well as we have questions in the Zoom chat, which we'll take after any questions that are there in the audience. We do have a mic here, so if anyone has any questions, please feel free to come forward and ask your question. Our panelists are already here. I'll start with one of the questions from the Zoom chat, and I'll address it to Dr. Urmila, who's here next to me. The question is fluid resuscitation the main thing in management of AKI? And how important is managing or maintaining a positive balance for patients with AKI?
I think the question also addresses partly by Pranav on his talk when he discussed pre-renal AKI, where he said resuscitation or maintaining an adequate volume is important in prevention and reversing the pre-renal component of AKI. But it's important that we realize that aggressive hydration or maintaining a extra fluid resuscitation or volume is actually deleterious. And if you, over the next 48 hours, if you resuscitate an excess of fluid, which is more than 10% of your body weight, that is, you are 6 liters positive in a 60 kg individual, it can actually worsen AKI. And we have a thesis by our student which showed that more excess the fluid, more the biomarkers which are increased after 48 hours, the common AKI biomarkers. So we need to maintain a very fine balance between resuscitating fluid, just doing it right, and not overdoing it.
I'll put the next question up to Dr. Pranav Jha. What are the important differentials that should be considered while making the diagnosis of pre-renal kidney failure or kidney injury?
So I think the most important thing whenever you're looking at the case of acute kidney injury is to rule out post-renal thing, obstructive thing. So the differential will be, you should rule out obstructive thing and then think of the various things which can lead to a pre-renal disease. As we discussed earlier, most of the time the history will be forthcoming. You'll have history of diarrhea, vomiting and all. So, but an important thing to realize here is, as Madam already told, is that many of these patients are, when they present, we are not sure that they are into pre-renal state or a state of intrinsic renal failure because of acute tubular injury. So that's why it becomes very important that the hydration should be short boluses and not the traditional 1 to 2 liters of fluid that we used to do earlier. Because if these patients are in acute tubular injury phase, they might land up in fluid overload and leading to a worse outcomes. So yes, all the three etiologies need to be ruled out whenever you're looking at the case of pre-renal acute kidney injury.
Next question is to Dr. Srijit. What are ways or things that we can do to limit or reverse sepsis-induced AKI?
Yeah, so there are not very specific pharmacological measures, if that is what somebody was asking, are not there. What we can do is to start systematically from the beginning, in the sense, risk stratify people based on their risk factors and their exposure factors, which can be systematically done in, say, in an ICU setting, systematically for all patients. So this may help us in identifying those individuals who are at higher risk of AKI, and we can identify, proactively look for things like nephrotoxic agents, and this can be done specifically for those people who are identified to be at higher risk, and our minimize contrast use, avoid or minimize nephrotoxic drug use, optimize their hydration status, don't push them too much, resulting in overhydration, and don't allow them to go into hypovolemic status. So beyond doing those things, if there is an identifiable source of infection, you treat that, you give appropriate antibiotics. Instead of doing all these things are what is going to help in preventing and minimizing the severity of AKI. There are no specific pharmacological agents which are shown to be useful in these things.
Right. Thank you, sir. My next question is going to be to Dr. Zahir Virani. There have been a lot of doubts with the same question, saying that how does PPI kind of, how do you give PPI, or do you think PPI causes AKI, and do all classes of PPI? So what's your opinion about PPIs and AKI?
So any drug can cause allergic interstitial nephritis. There are studies which have shown that chronic PPI use may be associated with chronic kidney disease. Any drug which is not indicated should be avoided. And in the middle, there was a lot of talk that any pantoprazole or rabiprazole or omeprazole should be substituted with ranitidine. So unless there's a hard indication, one should avoid PPIs, and it is known to cause allergic interstitial nephritis.
Thank you. Dr. Manisha Sain, ma'am, there's a question which says that what are the main factors which make accurate diagnosis of AKI more difficult in women who are pregnant?
So as I already highlighted, there are no standard definitions, and we use the KDIGO definition as of now. In pregnancy, the creatinine values are lower. Then the urine output in pregnancy may not be low only because of the renal involvement. Sometimes because of preeclampsia without renal involvement, the urine output may be lower. So even the creatinine criteria is not reliable, urine output criteria is not reliable. In addition, the GFR formulae which we use, none of them work in pregnancy. So if you want to measure the creatinine clearance, you have to do a standard 24 hours creatinine clearance, which also is fraught with certain difficulties. So because of the physiological changes in pregnancy, because of a lower creatinine level, sometimes it may be difficult to diagnose renal failure in pregnancy. So I was trying to show in that slide, if a lady comes with a creatinine of 1, don't presume it's normal. 1 is high for pregnancy. So go back, check her previous records and repeat. So that would be my message.
Right.
Thank you, ma'am. And I think with that, we'll close the session and we'll move on to the next session, which is on hypertension. And I let Dr. Garima take forward.
Before we close this session, I'd like to thank all the chairpersons, panelists, speakers. And as a token of our appreciation, we would like to call upon Dr. Puneet Dhawan, sir, to please give present our moderator and the speakers present here with a memento. First, I'd like Dr. Puneet Dhawan, sir, to please present a memento to Dr. Urmila Anand, who was the speaker for today. Now I'd like Dr. Puneet Dhawan to please present a memento to Dr. Ajay Kher for the marvelous conduction of the session by himself and Dr. Mayuri. Thank you. Now we go on to the next panel. Our next panel has generated a lot of interest amongst everybody. This is a panel on hypertension. And our two moderators will be joining us online, Dr. Amit Langote and Dr. Sanjeev Nair. I think we can pin them onto the screen. Also, I'd like to request Dr. Manisha Dasi to please join us on the dais while the session is going on. Amit and Sanjeev, I think you may start the session.
Thank you, Garima. Good evening, everyone who has joined us online, as well as those who are physically present at the venue. This next session is a topic that is of increasing importance to all of us in our practices, as well as to the lay public, because of the increasing prevalence of hypertension. And we've tried to focus on topics that are relevant to how we diagnose and treat hypertension, as well as diagnostic challenges. To take this session forward, let me first invite to the dais Dr. Naresh Chawla. Sir is a senior consultant in general medicine as well as a famous medico-social activist, and is an alumni of Maulana Azad Medical College, Delhi, where he did both his undergrad and postgraduate medicine. Can I invite sir to the stage, Dr. Naresh Chawla?
It is also my privilege to welcome Dr. Sudarshan Ballal to chair the session. He's a very well-known personality, and he's a chairman of Manipal Hospitals. He's also chairman of Stempeutics Research Private Limited at Bangalore. He has won many awards and gold medals during his career and has a distinction of being appointed as a professor of medicine with St. Louis University School of Medicine and an adjunct professor of medicine at Manipal University. He was conferred the fellowship of the Royal College of Physicians, London, for contribution to medicine, and been recently nominated as the member in Board of Management in Manipal Academy of Higher Education. He also has set up the first postgraduate training center in nephrology in Karnataka, and also performed the first cadaver kidney transplantation in Karnataka. I welcome you, sir, to the session.
Thank you.
Also chairing the session online will be Dr. Divya Monga, who is an alumni of KMC Manipal, also my alma mater, so a special welcome to her. She's completed her nephrology and hypertension fellowship from Hofstra, North Shore, Long Island, Jewish Hospital in New York, and thereafter worked as an associate professor in the Mississippi Medical Center in Mississippi, again, the USA. Her interests span onconephrology, glomerulonephritis, and kidney replacement therapies, and she served as a medical director for the dialysis units at the University of Mississippi. And she's also much published and has run a number of clinical trials. Welcome, Dr. Divya Monga.
Thank you.
I will now ask Dr. Naresh sir to introduce and welcome our first speaker, Dr. Vaibhav Keskar, and take this talk forward from there.
Hello. Good evening, dear friends. First of all, I thank the organizers to give me the chance to be chairing this session that underscores, number one thing, that kidney disease, although being dealt by such eminent nephrologists, many cases are first seen by the GP, the so-called medicine specialist or physician. So they have to be properly prepared how to initiate and put away with refer the patient properly. That's extremely important. So coming to the first talk of this session is defining hypertension, making sense of the guidelines for clinical practice. As we all say that hypertension, diabetes, dyslipidemia, and thyroid diseases, these four are practically the big dangers or so-called such diseases which are not detected till one is tested. So the first topic is defining hypertension, making sense of the guidelines for clinical practice, and the speaker is Dr. Vaibhav Keskar. So straight, without wasting any more time, over to Dr. Vaibhav Keskar speaking on hypertension.
Good evening, everyone. Am I audible?
Yes, sir, you're audible.
Yes, thank you for having me here today. In next 10 minutes, I have a difficult task to discuss various guidelines and to see if we can make sense of these guidelines. Let us take a minute to think about normality. How do we define a biological variable as normal? Normal is something which the majority of population has, or we can define normal as something which is associated with a favorable health outcome. So let us come to the first. So this is how we define short stature. In children, if we want to label someone as short, we make sure that we have data of about 100 children, and shortest 5 are labeled as short. This is called as normal distribution, and the majority of population has something called as normal variable. Can we define hypertension like this? We do define hypertension in children in this way, so that the highest 5% of the children are labeled to have hypertension. But when it comes to adults, we must define hypertension based on its association with cardiovascular disease. Take this example. The figure A is the distribution of systolic and diastolic blood pressure. For example, in our grandparents, they were physically active. They had typical Indian diet. They had low salt diet, and their mean could be around 110 of systolic and 60 to 70 of diastolic. Come 100 years later, our generation, we are more obese, we are more Western, we are eating more salt, and our blood pressure could be around, the mean could be around 130, or in some cases 140. And this was seen in epidemiologic studies. What happens if we define blood pressure based on population A's records? Majority of us will be defined as hypertensive. So this is going by epidemiologic data. But from an epidemiologic perspective, there's no obvious blood pressure level that defines hypertension. And there is a continuous and incremental risk of cardiovascular disease, stroke, and renal diseases. This is a figure taken from a meta-analysis published in 2002. And they had data from thousands of patients, and they studied the risk of cardiovascular disease against various levels of blood pressures. And as we can see in this graphs, the blood pressure, as blood pressure increase, the risk of cardiovascular diseases increase. So in next few slides, we'll define hypertension based on the target BP achieved in several trials. So as early as in 1967, we knew that diastolic blood pressure of 91 was better than diastolic blood pressure of 190 based on VA cooperative study, one of the first studies of antihypertensive medicines and blood pressure targets. There were fewer deaths, fewer complications like retinopathy, CHF, high creatinine, strokes in lower blood pressure group. In next few decades, we also knew this is a graph from a publication in NEJM. This study examined thousands of patients from a cohort where blood pressure was checked, and about 20 years down the line, they checked the risk of end-stage renal disease. We can see here is risk of kidney disease, end-stage kidney disease gets worse and worse as systolic as well as diastolic blood pressure increases. So the lowest risk is probably at 120 to 129 or below 120. So in next decade, in 2002, a meta-analysis was published where they had data about almost 1 million people. And this was a meta-analysis of cohort studies. And this also showed that coronary heart disease and stroke risk worsens as there is every 10 or 20 millimeter of mercury rise in blood pressure. And the lowest risk is at around 115 to 120. These are the observational studies. Let us come to the trials. In last century, there were several trials that tested lower systolic blood pressures, and they found that the lower systolic blood pressure was associated with better cardiovascular risk profile. And then come to SPRINT trial that was published in 2015. This is one of the largest trials of in hypertension, and they tested intensive control of blood pressure, that is less than 120, versus standard group that was below 140. They found that the primary outcome, which was cardiovascular diseases, it was improved by 25% in intensive group. So we can see even the secondary endpoints were better in the intensive treatment group. So here 120 is better than 140. But at what cost? So there could be more complications. There were more hypotensive episodes, more episodes of syncope, more hyperkalemias because of probably more use of or higher doses of ACE and ARBs. And there was higher incidence of acute kidney injury in this cohort. So there is a trade-off. The beneficial effects are almost 29% reduction in major adverse cardiovascular events, 33% reduction in cardiovascular mortality, 37% reduction in heart failure. But at the same time, we are using more medicines. We are using more medicines that may have potential side effects. And there could be more episodes of hypotension, syncope, and other adverse events. So this is really a trade-off. To achieve, which is something normal, we have to have certain unintended effects also. Looking at this data in 2017, ACC-AHA came up with a guideline that generated a lot of discussion because they changed the definition of hypertension. Previously, it was considered more than 140. The new guidelines defined hypertension as more than 130 or the diastolic of 80. I'll come to this slide again in a minute. Over the next few years, several guidelines came up that defined hypertension. The European guidelines published in 2018 defined it as more than 140/90, and so they chose to stick to the previous definitions. But when it comes to targets, more or less all of them rooted for 130/80. Let us think about it. These guidelines differ in definition of blood pressure, but all of them probably ask us to achieve a level below 130 when it comes to the target blood pressure. That means lower is the better. It's just that different guidelines analyze the same data based on the clinical scenario. In addition to pure numbers and absolute risk, do other risk factors play a role? I think yes. The evolution of definition of hypertension is probably related to the risk, cardiovascular risk also. The benefits of BP lowering in the clinical trials seem to be greatest among those who have highest risk of cardiovascular risk. For example, elderly, people with CKD, people who have high Framingham risk score, or those who have highest baseline blood pressure level. So more, in addition to these factors, we also keep in mind that more aggressive systolic BP lowering can be associated with higher risk of events. So we have to individualize BP treatment. Does that mean we individualize definition of hypertension? Probably yes. What happens in diabetes? So according to Accord trial, there was not much of difference between systolic blood pressure of less than 120 versus systolic blood pressure of 140. So American Diabetes Association still roots for the definition of hypertension as 140/90. They do mention that if someone has high CV risk, achieving blood pressure target 130/80 may be appropriate if it can safely be attained. That means, again, we are individualizing the definition. And all of this discussion is true only if we measure blood pressure in right way. If you are not measuring it right, the discussion about a cutoff or definition or targets is worthless. We have a full talk on this, but it is very important to measure blood pressure in right way. Again, I come to this slide, and I agree with ACC-AHA, which defines normal blood pressure as less than 120, which is supported by several cohort studies as well as data from a randomized controlled trial, and hypertension to be defined as 130/80 or more. So take-home message from last few slides would be, there's definite evidence that lower may be better, but there is a trade-off. So we have to treat each patient individually, and we have to apply guidelines by considering the clinical conditions that these guidelines detail, that tell us. And of course, when it comes to prescribing more medicines, shared decision-making is the way to go. We have to talk to the patient about the goals and the number of tablets needed, and of course, the lifestyle management needed to achieve that goal. Thank you. Thanks a lot.
So I think that's a great talk, Webo. As decided, we will be taking the questions at the end, and I hope you stay back to answer some of the questions. May I now ask Dr. Sudarshan Ballar sir to introduce Dr. B. Karthikeyan, who is the next speaker. Sir, your mic is on mute, sir.
Good evening. I'm greatly honored to be here at IMA Kidneycon 2022. And it gives me great pleasure to be chairing this very important session on hypertension. My thanks to the organizers, Dr. Garima and Dr. Umesh Khanna, for giving me this opportunity. Without further ado, I will go on to the speaker, Dr. B. Karthikeyan, who's Associate Professor, Department of Nephrology, Savitha Medical College, Chennai. He's done his DM Nephrology from SGPGI, MD General Medicine for JIPMER, Puducherry, trained in some of the best institutes in the country. He's a member of the Indian Society of Nephrology, International Society of Nephrology, has had many publications, including and also been awarded the Chandrasekhar Gold Medal at JIPMER. And his areas of interest are intradialytic hypertension, dialysis recovery time in MHD patients, and interventional nephrology and renal transplantation. Over to you, Dr. Karthikeyan.
Yes, thanks. Thank you for the introduction, sir, and I thank the organizers for giving me the opportunity to talk on this topic. Without further delay, I'll be starting with the topic. The topic given to me is optimal blood pressure measurement. So I'll be covering the office blood pressure, automated office blood pressure, ambulatory blood pressure, and home blood pressure monitoring. So why optimal blood pressure is needed? So as Dr. Vaibhav said, first we have to diagnose hypertension, and for that blood pressure measurement should be optimal. And the optimal blood pressure is usually a direct measurement, which requires an intra-arterial assessment, which is not routinely practical in our setup. So we probably mostly depend on the office blood pressures. And other than office blood pressures, we have ambulatory blood pressure as well as home blood pressure monitoring. And there is always a difference in blood pressure, which is measured in the office and out of office. And recently, more automated devices and semi-automated devices, which uses oscillatory method, has come up. So as I said, BP measurement can be office as well as out of office. And the office can be, office blood pressure is measured by traditional oscillatory method, or it can be oscillometric automated method. And the out of office blood pressure is ambulatory blood pressure or home blood pressure monitoring. And during BP measurement, there may be errors. It can be due to patient related or device related, or it can be procedure related. So patient related can be sometimes full bladder, recent food intake, or movement during the measurement. And the device, if it is not calibrated or not validated, then it also can lead to BP measurement error. And the procedure related can be miscuffing and either texting or talking to the during the procedures. All can lead to error in BP measurement. So the key component is training the person to measure the BP accurately. For that, we have to assess the physical and cognitive competencies to measure an oscillatory BP measurement. And we have to assess the knowledge of the observers regarding their techniques and understanding the BP variability. And they should also use the validated devices, and they have to measure BP in quiet location and correct position of the person. And they have to ensure that patient person should not talk or move during the measurement. And they need training and retraining every 6 to 1 year. It has to be considered for training in BP measurement. So coming to the selecting cuff sizes. So we have to mainly measure the mid-arm circumference, like between the midpoint of the acromion, we have to take the midpoint of the acromion and olecranon, and we have to measure the arm circumference, and the BP cuff length should be at least 75 to 100% and the bladder width should be around 37 to 50%. So the cuff sizes should be appropriate for measuring the correct blood pressure. Whenever you are applying the cuff, it should not be on the cloths, it should be on the bare skin, and the shirt sleeves should not be rolled up because it may cause a tourniquet effect. And most of the times the frequent error can be because of miscupping. So we should be very cautious, we have to take precaution in this while measuring applying the cuff. And the next is about the cuff sizes, and usually the normal adult will require 16 into 30 dimension of bladder dimension of cuff sizes, and the various cuff sizes are given here according to the arm circumference. And body position is, which is also very, very important, because in supine position, both systolic and diastolic blood pressures may be higher. It is almost 3 to 10 in systolic blood pressure, as well as in diastolic blood pressure, it may be 1 to 5 millimeter higher than in sitting position. And when measuring in supine position, with the cuffed arm should be supported with a pillow behind it, so that it is at the level of the heart to get the correct blood pressure measurement. So in sitting position, the patient has to be relaxed, and the patient back should be supported. The legs should not be crossed, and it should be touching the floor, and the hand has to be relaxed, and the arm cuff should be placed near to the heart, like at the level of the heart. And regarding the cuff placement and the stethoscope placement, we have to palpate the brachial artery in the antecubital fossa, and the place, the center of the cuff, the bladder length. Like most of the times they will give you a mark, so it should be placed over the brachial artery, and the lower part of the cuff should be 2 to 3 centimeters above the cubital fossa. And after that, we have to assess the tightness of the cuff, and then cuff should be inflated above 30 millimeter after the radial pulse disappears, and the cuff deflation should be at least 2 millimeter of mercury per second. So the auscultatory technique, most of us we know, like the sequence of sounds, and we use various various types of sphygmomanometers are there. One is mercury, we normally use, which has simple design, and it is not subject to substantial variation. And most of the times we'll see aneroid manometers, where calibration has to be done every 2 weeks. And nowadays hybrid sphygmomanometers have come, which replaces the mercury column with the electronic pressure gauge. And the next is the oscillometric devices, because the oscillometric devices are most commonly used now over the past decade, and it is based on the amplitude of oscillations, which is recorded in the lateral wall of the upper arm. It estimates BP whenever the cuff is deflated. So it measures both and systolic as well as diastolic blood pressure based on the maximal oscillation amplitude. So usually we have to use only independently validated devices, because different devices even from the same manufacturer is not interchangeable. So we have to make sure that only validated devices are used for measuring blood pressure. So coming to the automated office blood pressure, so it has the capability to record multiple blood pressure readings with even single activation. So this can be either attended, means whenever the healthcare provider or staff nurse is nearby at the time when we are measuring. Unattended, when healthcare provider is not there with the patient, where we can measure the blood pressure in the quiet room, where most of the times the guidelines recommends unattended automated office blood pressure, because unattended office blood pressure, automated office blood pressure is very close to awake ambulatory blood pressure, and it has very strong association with cardiovascular risk factors as well as carotid intimal artery thickness. This is one of the study which has combined, which has compared conventional versus automated measurement in office. This is Cambo trial, where the primary outcome was the difference between systolic blood pressure in the first office visit and the mean awake blood pressure in the ambulatory blood pressure monitoring. We can see the difference, like the difference is less with the automated office blood pressure than that of the auscultatory method. So the correlation was very significant with that of ambulatory blood pressure in automated office blood pressure monitoring. So there is always a limitation with the routine auscultatory method, because we have to rely on the observer skills, and there is always white coat effect. which can lead to we can go for unattended automated office blood pressure, because there is minimal increase in staff effort and time, and the Canadian guidelines also recommend unattended automated office blood pressure. So how many times we have to measure during a single visit? The hypertension clinical practice guideline says that at least 2 times in a single visit. And usually the first, one of the study mentioned that usually the first BP measurement is mostly higher, because here we can see that almost 35% of the people with the systolic blood pressure who has more than 140 to 150 had less than 140/90 when the average measurements are measured. And what about the interim difference? Like usually there will be interim difference, and the BP should be measured in both arms in first visit. The arm with higher BP should be used for the subsequent visit. So if the difference is more than 10 millimeter, then we have to suspect coarctation as well as any upper extremity arterial obstruction. If there is any large inter-arm difference, then it is associated with the increased risk of cardiovascular diseases. How about the frequency of visit? The US Preventive Services Task Force says that annual BP screening for adults with the increased risk, those who have no increased risk, BP should be measured every 3 to 5 years for adults aged 18 to 39 years. And if the patient is having increased BP during visit, at least 2 reading per visit has to be done with a follow-up visit within 1 month. After initiating antihypertensive drugs, monthly visit has to be followed it up, and after achieving hypertension goal, then every 3 to 6 months we have to follow up the patient. This is already mentioned about the stages of the hypertension. How about the reproducibility? Like routine office blood pressure, there is substantial variability. We can't have a good reproducibility, but in research studies, what they are using is standardized office blood pressure, where we can find like good reproducibility. But automated office blood pressure has better short-term reproducibility. Coming to ambulatory blood pressure monitoring, it is non-invasive, fully automated, oscillometric method, and it has very strong association with cardiovascular outcomes. And we can have multiple BP measurements over 24 hours. And the other important advantage is we can able to identify the blood pressure patterns like white coat hypertension, masked hypertension, and nocturnal hypertension with ambulatory blood pressure monitoring. So the medical staff has to be trained because they should have adequate knowledge about the BP measures that can be obtained with the ambulatory blood pressure, and they should be trained in these specialized equipments and devices, and they should prepare the patients for ambulatory blood pressure, and they should know how to teach the patient about the device for recording, and they have to be trained for fitting the device as well as cuff and tubing, and they also have to be trained for downloading the software data and analyze it. So about the frequency of readings, like every 15 to 30 minutes when the patient is awake, and every 30 minutes when during sleep over 24 hours. So totally around 48 to 96 total readings will be there. And reading less than 15 minutes should be avoided because it will be more disruptive for the patient. And the cuff has to be applied in the non-dominant arm because it may interfere with the routine activity. So regarding the patient preparation, the ambulatory blood pressure may disturb sleep. We have to instruct them, and we have to avoid showering, and we have to instruct them to avoid showering and swimming. And they can follow their routine usual daily activities, and they should be taught about the refitting of the cuff if it miscuffs. And we have during sleep they have to place the device on the bed or beneath a pillow, and they have to have a diary to document the sleep and awakening times, and the time of antihypertensive medications, as well as the time of meals and any occurrence of symptoms. And they have to also know about how to turn off the device if that is malfunctioning. So how do you know it is a complete ABPM? There is no standard criteria as such, but there is more than 80% of planned readings with at least 1 reading per hour is essential. And most of the guidelines mention the same, and Canadian guidelines and the European Society of Cardiology guideline also mentions almost 70% of planned readings to be valid. How to identify day and night time? Most of the times it can be of 3 types. It can be self-reported, or actigraphy. We can use wrist actigraph device or ABPM with actigraph, or it can be fixed night time, midnight to 6 a.m. or 10 a.m. to 8 p.m. So there is higher agreement with the self-reported and actigraphy than that of the fixed timings. So in clinical practice, self-report is the most pragmatic approach to identify the day and night time. So in analyzing readings, the average of all readings should be calculated. So mean daytime blood pressure, mean nighttime blood pressure, mean 24 hours blood pressure, and we have to see whether any nocturnal dipping is there or not. Coming to the BP phenotypes, it can be white coat hypertension. Whenever there is in office, the blood pressure is in the hypertension range, but out of office, the patient has normal blood pressure. What is white coat effect is the patient who is already taking antihypertensive medications with the office blood pressure, high office blood pressure, but out of office blood pressure is normal. What is masked hypertension? Masked hypertension is office blood pressure is in the normal range, but out of office blood pressure is in the hypertension range. What is masked effect is the patients who are already taking antihypertensive medications with hypertensive BP levels in out of office, but they are normotensive in the office. So when hypertension is present in office as well as in out of office, then it is sustained hypertension. If it is present only in out of office, then it is masked hypertension. If it is present only in office, then it is white coat hypertension. So if there is any white coat hypertension, you have to go for ambulatory blood pressure monitoring or high blood pressure monitoring. If BP is less than 130/80, then white coat hypertension is confirmed. So you have to monitor annually. If it is BP is high, then we have to diagnose as hypertension and we have to initiate antihypertensive therapy. White coat hypertension, most of the studies mention there is no increased CV risk. But annual follow-up is necessary because these patients may go for sustained hypertension later on. Masked hypertension is more common in chronic kidney disease patients, diabetes, and obstructive sleep apnea patients, and it has high increased risk of cardiovascular events. So whenever you are suspecting masked hypertension, we have to measure ambulatory blood pressure or home blood pressure. If it is more than 130/80, then masked hypertension is confirmed. Then we have to initiate antihypertensive therapy. If it is not, then advise lifestyle modification and annually measure the ambulatory blood pressure and home blood pressure monitoring. So same here. And the nocturnal hypertension. So some patients may have higher blood pressure during sleep, which is like they are reverse dippers, and they have increased cardiovascular risk. So more common in diabetes and chronic kidney disease patients, and we have to use ambulatory blood pressure monitoring to detect the nocturnal hypertension. So how to see whether it is dipping or non-dipping? So we have to measure like the degree of BP dipping by 1 minus mean asleep BP divided by mean awake BP. So if the decline is more than 20%, then it is extreme dipping. So if it is less between 10 to 20% decline, then it is dipping. And if it is less than 10%, then it is non-dipping. And if the sleep BP blood pressure is more than awake blood pressure, then it is reverse dipping. So reverse dipping and non-dippers are having higher cardiovascular risk. And another important thing is morning BP search, because most of our patients may have cardiac events, pulmonary edema at the early morning. That is rapid rise in BP when the people awake. So this is also has higher risk of cardiovascular events. So this is measured by the difference between the average BP during the 2 hours after awakening, between the 2 hours before awakening. So if it is high, then there is increased risk of morning BP surge, and they have increased risk of cardiovascular events. And the awake blood pressure, sleep blood pressure, and 24-hour mean blood pressure has high reproducibility. And the non-dipping isolated nighttime hypertension, isolated daytime hypertension has poor reproducibility. So about the indications of ambulatory blood pressure, so as we know, like white coat hypertension, masked hypertension, white coat effect, masked uncontrolled hypertension, and to assess the presence of nocturnal hypertension, and to assess the evaluation for postural, postprandial, drug-induced hypotension, and autonomic dysfunction. All these are indications for ambulatory blood pressure. Home blood pressure monitoring. So this is the blood pressure measured at home, and it is well tolerated than ABPM, and it is more widely available and lower cost than ABPM. But patient recall may be a concern, but some of the devices have built-in memory, which will be helpful in evaluating the home BP monitoring. And there are various devices, validated devices available, and we have to use only the validated devices. And patient training is important because they have to select the proper device, and they have to measure BP on their own, and they have to bring their record to the healthcare visits, and we have to educate the patient that BP readings may vary greatly. So they have to use the device. Better is to use a device that is automatically storing all the readings. And the best practices are should not take any food or drink before 30 minutes, have an empty bladder, do not talk or text, and we have to at least ask them to rest quietly in a seated position for at least 5 minutes. And the same thing what we are measuring in the office, like sit back with the relaxed and floor should not, the feet should be in the floor, leg should not be crossed, and all these things has to be followed. And the frequency of reading, we have to take at least 2 readings at least 1 minute apart in the morning as well as in the evening. And the referred monitoring period is usually 7 days, 28 readings. You can take consecutive days, which is ideal, or non-consecutive days is also valid. So the minimum period is 3 days. If you are excluding the first day of readings, at least 4 days, and the preferred period is 8 days. So the reproducibility with the home blood pressure monitoring is very high. You can see that test retest correlation, which is approaching up to 0.84. And the indication is again the white coat hypertension, masked hypertension, assessing white coat and masked effect. And use of home blood pressure monitoring is associated with the improvement in blood pressure control because of other adherence strategies, because it can be followed up to the healthcare provider and they can instruct it. The difference is mainly the ABPM have 24 hours measurement, but home blood pressure has only every day we can measure, and home blood pressure only during the awake period, and it can measure BP only at rest, and a person can aware of the readings. Ambulatory blood pressure, they are not aware of the readings, and it measures BP during sleep and awake periods, and it measures BP when person does his routine activity also. So which one is better? I say like most of the guidelines recommend ABPM because it can detect nocturnal hypertension. Most studies support ambulatory blood pressure. If ambulatory blood pressure is not available because of reimbursement, cost, and all these things, we can go for home blood pressure monitoring. The disadvantages does not detect the nocturnal hypertension. So the challenges is ambulatory blood pressure is not widely available. Reimbursement may be issue, and it is not well tolerated by many patients. And but in home blood pressure, it is well tolerated, but most of the devices are not validated accurately, and some devices do not have automatically record. So this is a corresponding office blood pressure with the home blood pressure as well as ambulatory blood pressure monitoring. So on summarizing, hypertension of course is one of the prevalent risk factor. For diagnosing hypertension, accurate blood pressure and optimal blood pressure measurement is required, which will also guide to initiate antihypertensive drugs as well as titrate the drugs. Use of oscillometry devices in office setting will reduce the human error, and recommendation is unattended automated office blood pressure. And in out of office blood pressure monitoring, ambulatory blood pressure is the recommended one, but if it is not available, home blood pressure monitoring is used, but use only validated, routinely calibrated BP measurement devices. And but not the least is adequate training of staff for BP measurement. Thank you.
Thank you, Karthik, for that exhaustive talk. I request you to stay back for the panel discussion at the end of this session.
Yeah, thank you.
Meanwhile, you can look at the questions in the chat box. There are quite a few that you can answer there as well. Okay. Can I request Dr. Mongia to please introduce the next topic and speaker?
Thank you so much for this honor here. I'm going to introduce our next speaker, Dr. Aniket Hase. He's a consultant nephrologist and a transplant physician at the Jupiter Hospital in Thane, Maharashtra. He was nominated. He was awarded the Best Outgoing Medicine Resident and Service Excellence Award in 2009, 2010, and he has many publications in national and international journals. And he's contributed to book chapters in the field of medicine and nephrology. So we welcome Dr. Hase, and we'll start. Thank you.
Good evening. At outset, I must thank the organizers for giving me this opportunity. My topic is new hypertension, how to evaluate secondary hypertension. So we have seen accurate diagnosis is important and how to confirm the diagnosis of hypertension. Now I'm going to concentrate on how to evaluate newly diagnosed hypertension, why they need evaluation, what is the basic workup that should be done, and when to extend the basic workup to rule out secondary hypertension from the clues we get from history, examination, and basic workup. I would like to start with the case. This was a 30-year-old male referred for increased creatinine and severe anemia. On detailed history, we got to know that he was diagnosed with hypertension 4 years back at the age of 26 years. He was started on amlodipine and telmisartan by primary care physician. However, he took the medication intermittently when he had a headache or he felt that his BP was high. He never followed up with his doctor, never was evaluated, nor he measured his BP. 1 week back, he had fever, cough, nausea, vomiting, generalized weakness, and his BP was recorded 200 by 120. Investigations revealed anemia with hemoglobin of 8, proteinuria, hyaline broad-axis cast, azotemia with blood nitrogen of 108, creatinine of 12, hyperkalemia, metabolic acidosis, and USG revealed bilateral small kidneys with loss of CMD. So the point to be noted here is that he was diagnosed hypertensive at the age of 26, and within 4 years, he progressed to end-stage kidney disease. This is one of the most common reflux seen in our nephrology OPD and ER. Perhaps if he would have been evaluated and his BP would have been controlled 4 years back, he wouldn't have rapidly progressed to this end-stage kidney disease. Hence, there is a definite knowledge gap which needs to be bridged for better kidney care. High blood pressure is a silent killer. Why so? Because we have seen they can directly present as renal failure, they can directly present as heart failure, myocardial infarction, can lead to accelerated atherosclerosis and coronary artery heart disease, peripheral vascular disease. It can give rise to catastrophic brain hemorrhage, dementia, hypertensive encephalopathy, and can even lead to blindness. And there is a definite benefit of lowering blood pressure, which can be seen from this study. There was a definitive reduction in incidence of stroke by 40%, myocardial infarction by 25%, heart failure by 50%, and progression of CKD by 40%. And this is an Indian study done in urban population of Chennai. It showed the prevalence of hypertension was 22%. But point to be noted is more than half of those patients didn't know they had hypertension. And out of those, only 50% were treated. And of the treated ones, 60% had uncontrolled blood pressure. This again suggests that our ultimate objective should be to improve the healthcare literacy at all levels, from patient to the caregivers. So hypertension can be primary or secondary. Primary hypertension, also known as essential hypertension, where the exact etiology is not known, and account for 90 to 95%. Now lately being defect being recognized in the kidney. While secondary hypertension, which is identified a cause and which accounts for 5 to 10%. However, hypertension in children, 85% will have a secondary cause. These secondary causes include renal parenchymal hypertension, which includes glomerular disease, interstitial disease, or polycystic kidney disease, renal vascular disease, wherein atherosclerotic renal artery, especially in the elderly, while fibromuscular dysplasia and arteritis in young patients, endocrine causes like primary hyperaldosteronism, pheochromocytoma, thyroid disorders, coarctation of others, the coarctation of aorta, and definitely drug as a cause of secondary hypertension needs to be kept in mind. These are potentially curable causes. However, if we see from this study, these are rare and hence we cannot investigate all the patients per se. We need a high index of suspicion and high pretest probability to investigate these and thus make the evaluation cost effective. The age at onset of hypertension may give a clue for possible cause for secondary hypertension and help to select a screening or a confirmatory test. For example, in pediatric and adolescent age group, most commonly renal parenchymal hypertension, coarctation of aorta, Cushing syndrome, obesity or overweight. In elderly, atherosclerotic renal artery, renal parenchymal hypertension, thyroid disorders. While in middle-aged, young adults, renal parenchymal renovascular hypertension, or primary hyperaldosteronism, obstructive sleep apnea are the common causes. Who should be evaluated? All newly diagnosed hypertensives should be evaluated. And the goal of evaluation is to detect the target organ damage, to identify comorbidities and risk factors, and to rule out or find the etiology of secondary hypertension. So how they should be evaluated? They should be evaluated with detailed physical examination, and basic workup, which we will be discussing, and extended workup as indicated by the clues from history, examination, and basic workup. So basic workup in all newly diagnosed hypertensive may give us a clue to secondary hypertension. So complete hemogram, urine analysis, creatinine, electrolyte, sodium, potassium, and bicarbonate. CBC may reveal anemia. Urine analysis may show proteinuria. Creatinine may be high, which may indicate towards renal failure. Potassium may be low. Hypokalemia with metabolic alkalosis may point towards primary hyperaldosteronism. Uric acid lipid profile, blood glucose, fasting postprandial, HbA1c, ECG, and retina evaluation. These are mainly detected to targeted to detect target organ damage and comorbidities. So there are certain clues like onset of hypertension less than 30 years or more than 55 years. Pre-pubertal onset or pediatric onset of hypertension. Resistant hypertension. Resistant hypertension is hypertension requiring 3 antihypertensives, one of which is diuretics. All 3 in optimal doses are given, and yet the BP is above the target range. Patient presenting with severe hypertension of BP more than 180 is as an hypertensive emergency at the first diagnosis. A sudden increase in BP with previously stable hypertensive patient, non-dippers or reverse dippers, end organ damage at the time of presentation. These may give us clue for secondary hypertension. In all patients with hypertension, we must take a detailed history, do a detailed examination, get the basic lab workup done, which we have already discussed. And from this, if we find any clues, suspect secondary cause, accordingly screen and refer for confirmatory test and treatment. So let us see some of these clues. So patient may have edema, puffiness of face, nocturia, hematuria, recurrent UTI, recurrent renal calculi, or children may give history of enuresis, growth retardation, diabetic patients. Examinations may give clue on like palpable kidneys, ADPKD. Basic lab workup may give clue like increased creatinine, proteinuria, severe anemia, RBCs in the urine, RBC cast. So this may give us a clue and point towards renal parenchymal hypertension. So ultrasound KUB can be done and refer to a nephrologist for the further investigation and confirmation of possible etiology of this renal parenchymal hypertension, which can be glomerular, interstitial, or polycystic kidney disease. Onset of hypertension less than 30 or more than 50, unexplained rise in creatinine, especially after starting ACE or ARBs, resistant hypertension requiring more than 3 or more drugs, recurrent flash pulmonary edema, abdominal brewing, not a very sensitive sign, but these may hint towards renovascular hypertension. The screening test with renal Doppler and referral to nephrologist, and further evaluation with isotopenogram, CT, MRI, or a conventional gold standard angiography and intervention as required. Amongst the renovascular hypertension, if the patient is young, 40 years, especially Indians, absent or unequal pulses, radial subclavian buoy, and constitutional symptom may hint towards aortoarthritis. CT aortogram is an investigation of choice and appropriately referred to a nephrologist or cardiologist. Young hypertensive with headache, epistaxis, delayed pulses in the lower limb, significant difference of pulse with upper limb and lower limb, BP difference of more than 20 or 10 millimeters of mercury between the upper and lower limbs, interscapular ejection systolic murmur, may point towards coarctation of aorta. Screening with color Doppler echocardiography, CT aortogram, and appropriate referral to a cardiologist or a cardiovascular surgeon may be considered. The patient may present with non-specific symptoms like fatigue, cramp, muscle weakness. Basic evaluation may reveal hypokalemia, metabolic alkalosis, or hypokalemia unmasked after diuretics. To suspect primary hyperaldosteronism. This has been an under-recognized cause of secondary hypertension, endocrine cause. The screening test with aldosterone, PRA ratio, and confirmatory test by CT, MRI, adrenal gland sampling. So primary hyperaldosteronism may be because of an incidentaloма detected adrenal tumor, which can be surgically removed, and it is a potential cure of our hypertension, or bilateral adrenal hyperplasia, which can be treated with medical therapy like spironolactone. So primary hyperaldosteronism has been under-recognized cause, and the spironolactone has been an underutilized drug in our antihypertensive armamentarium. So I won't get into the details as this is our next talk. The patient presenting with paroxysmal hypertension, headache, palpitation, and perspiration, 90% are likely to have pheochromocytoma. However, it should be remembered that in pheochromocytoma, there can be sustained hypertension too. And also patient may present with the complications like hypercalcemia, lactic acidosis, acute abdomen, myocarditis, cardiac arrhythmias, pulmonary edema, or end organ damage like stroke, heart failure. 24-hour urinary beta-nephrin, plasma beta-nephrins are the screening test of the choice, and then appropriately referred to the endocrinologist, CT, MRI, and NIVG scan to localize the tumor, and subsequent surgical removal may be considered. Excessive weight gain, proximal muscle weakness, acne, easy bruisability, hyperpigmentation, moon faces, buffalo hump, striae mark on the abdomen, truncal obesity, and basic workup showing hypokalemia, hyperglycemia, metabolic alkalosis may give a clue towards Cushing syndrome. Dexamethasone suppression test is a screening test, and further CT, MRI, ACT is referred to endocrinologist to determine the primary, secondary cause and treatment accordingly. This is one of emerging causes. Obese patient with excessive daytime sleepiness, history of snoring, resistant hypertension, large neck, obstructive sleep apnea may be the cause. Appropriate referral to the pulmonologist, and sleep studies, that's polysomnography, and then subsequently requirement of BiPAP, CPAP accordingly can help cure the hypertension or get it under control. Drugs have to be kept in mind. So most common drugs which can induce hypertension are the non-steroidal anti-inflammatory drugs, glucocorticosteroids, oral contraceptive pills, nasal decongestants, psychiatric drugs. So secondary hypertension. So to conclude, secondary hypertension constitutes 5 to 10% of total hypertension. It is a definite identifiable cause. History, physical examination, basic workup may give clue towards it. Basic workup has to be done for all newly diagnosed hypertensions to detect target organ damage and find any clue towards secondary hypertension. Suspect secondary hypertension in all newly diagnosed hypertension, resistant or difficult to control hypertension, previously controlled but now uncontrolled hypertension, and aldosterone excess and obstructive sleep apnea are the common under-recognized causes of secondary hypertension. Thank you.
That was an excellent coverage of secondary hypertension etiologies and the workup, Aniket. And lastly, I'll request for the Dr. Sudarshan Ballal sir to introduce our last speaker of this day and the panel today.
Thank you. I have a great pleasure in introducing Dr. Rajiva Lochana Parthasarathy, consultant, Madras Medical Mission, Chennai, ERA EDTA fellow, and AST accredited multi-organ transplant fellow from Canada, and has multiple publications at the national and international level. And her research interests include peritoneal dialysis, transplant immunology, glomerular diseases, personalized genetics in diabetic kidney disease. Over to you, Dr. Rajiva Lochana, to talk about hyperaldosteronism.
Thank you, sir, for that very kind introduction. At the outset, I would like to thank the organizers, Dr. Umesh Khanna as well as Dr. Garima, for giving me this opportunity to present to this very august gathering. My topic, which has gained more and more importance in the last decade, is hyperaldosteronism and the utilization of spironolactone. I have no disclosures except probably I overuse MRAs. Why this talk at all? Most common endocrine cause of hypertension is primary hyperaldosteronism. It's severely underdiagnosed. The screening rate using conventional methods may not be too sensitive, and there are varying definitions and interpretations of the same. What are the dogmas that we have been living with in terms of primary hyperaldosteronism? We always feel it's an all or a none diagnosis. It's severe hypertension and hypokalemia have to be present for us to diagnose primary hyperaldosteronism. Our minds were much simpler a decade ago when we thought only unilateral adenoma or bilateral hyperplasia were the commonest causes of hyperaldosteronism. And all we had to do was a unilateral adrenalectomy or a lifelong mineraloreceptor antagonist therapy in order to kind of relieve us of this disease. I want to kind of shun these dogmas and broaden our views about PHA, and we'll be discussing the following points, which is the prevalence of PHA and the definitions of PHA, the basic pathophysiology, how do we diagnose, especially at the general physician level, should MRAs be actually used more frequently at all, and what are the practical approaches and innovations that we have. Primary hyperaldosteronism or primary aldosteronism is basically an inappropriately elevated aldosterone in the setting of a low plasma renin. It's a 20% prevalence among resistant hypertension and around 6% in uncomplicated hypertension. It has implications in the fact that it has a very high cardiovascular morbidity and mortality. What is the role of aldosterone in physiology? Sodium is the main driver of plasma osmolarity, and the total body sodium is the main driver of the plasma volume. And our kidney filters almost 180 liters of plasma per day. And aldosterone plays a key role in the sodium reabsorption from the distal collecting in the DCT as well as in the collecting duct. The salty fact is that the 1500 milligram, which is the recommended ACC 2017 guideline sodium diet, a normal healthy person filters almost 99.9% of the sodium. Coming to the molecular mechanisms, aldosterone is actually lipophilic, and the mineralocorticoid receptor antagonists are present in almost so many organs from the kidney, heart, and brain, which again kind of emphasizes the fact that we need to diagnose PA quite early. It's been extensively studied in the kidney, where it increases the amiloride-sensitive ENaC channels on the apical surfaces, increases the sodium reabsorption, and in exchange excretes potassium. Simply put, it also excretes the hydrogen ions via the hydrogen ATPase channel. It also has non-genomic actions through GPER receptors. Now, aldosterone, the main regulator is the renin-angiotensin-aldosterone system, and renin and angiotensin are the main regulators of aldosterone. Traditionally, aldosterone is to save us from dehydration. It is basically to prevent us from getting volume depleted. But in the society we live in, where we consume a large salt diet, we are trying to go against physiology, where all we are trying to do is actually suppress the aldosterone production from the zona glomerulosa. So even a small amount of aldosterone is detrimental to us. Similarly, plasma potassium, where high potassium stimulates aldosterone production and low potassium suppresses the aldosterone production. Now, what are the causes of hyperaldosteronism? Our understanding of the causes has undergone a sea change with the application of genomics as well as genetic studies in nephrology. Commonest causes being adenomas or adrenal producing adenomas. Bilateral adrenal hyperplasia is quite an elusive concept. And now we know that we can have bilateral adenomas, unilateral hyperplasia, or micronodules and microscopic aldosterone producing cell clusters which can be present, which can actually produce more and more aldosterone. And coming to those familial causes, which are not that rare, commonest being familial hyperaldosteronism type 1 or glucocorticoid remediable hyperaldosteronism. Though relatively not too bad, it still causes quite a bit of hemorrhagic strokes and can be easily treated with a simple dose of glucocorticoids. Familial hyperaldosteronism type 2 behaves almost like the primary hyperaldosteronism. Severe forms like KCNJ5 mutations, people with seizures and neurological disorders associated with familial hyperaldosteronism syndromes exist. So it's very important to know that we are no more confined to saying that it is only two things. There can be multiple things producing hyperaldosteronism. Coming to the screening criteria, resistant hypertension defined by the US guidelines as a BP more than 130/80 with 3 or more drugs at optimal dosages, which includes a diuretic. Any spontaneous or diuretic induced hypokalemia, hypertension with an incidentally noted adrenal tumor, any family history of primary hyperaldosteronism, family history of premature stroke in patients less than 40 years, and hypertension and obstructive sleep apnea are all screening criteria for primary aldosteronism. Now, what are the screening tests that we have in our armamentarium to diagnose this? And this probably is extremely important at the general physician level. So, aldosterone-renin ratio, which we were traditionally thought is an actual good tool, but it has a high number of false positives and negatives. So the way to approach this whole thing is to actually see the plasma renin. So the plasma renin has to be extremely suppressed for us to initially diagnose hyperaldosteronism itself. So two things we can do is the plasma renin activity, which basically depends upon the conversion of angiotensinogen to angiotensin 1. It can be expressed as a rate. Then we have the direct renin concentration, which is used more frequently nowadays, which is a renin mass, which is basically expressed in MU per liter and is more reproducible by the laboratories. Now, which one do we use? So this is this small table basically shows what are the low and the higher thresholds for us to diagnose with PRA as well as the direct renin concentration. A lower threshold will make us diagnose more false positive primary hyperaldosteronism, whereas we may have high threshold diagnosis will lead to more of false negatives. So to make it really simple, so whenever somebody meets the screening criteria which I discussed, it's good to do a plasma renin activity or a direct renin concentration as is available in your particular lab. So the PRA should be really low, that is suppressed, that is less than 1 nanogram per ml per hour, or the direct renin concentration should be less than 10 picogram per ml. Simultaneously, the aldosterone measured should be more than 10. We should remember that many of the times we were taught that ARR more than 20 means that it is primary hyperaldosteronism. We should remember when we do this ratio, if the PRA is reported really low, then obviously our numerator goes up consequently, though the aldosterone levels may still be lower. So it's important to note that first, the renin activity or the direct renin concentration should be low. Simultaneously, the aldosterone should be high, and easily we can suspect primary aldosteronism. What are some of the useful tips? Blood samples for these tests should be collected simultaneously in the morning after at least 2 hours of ambulation. Correct the serum potassium. That's so important because the low potassium, as we know, can suppress the aldosterone production. Generally, there is no need to discontinue medications. The renin activity will anyways be suppressed generally. And if still the tests are inconclusive and the clinical suspicion is extremely high, then discontinue the offending antihypertensives for at least 2 weeks and then recheck. There are so many sources of error in primary aldosteronism screening, and this is important for us to understand when we interpret the results. Hyperkalemia, calculating the ratio itself, which I mentioned. So we should be careful, especially when the renin values are really low, because the numerator automatically goes up. If the patient is on direct renin inhibitors, it lowers the plasma renin activity. OCPs lowers the direct renin concentration. So a drug history is of extreme importance. The false negatives again are hypokalemia, use of concomitant MRAs, ACE inhibitors or ARBs, diuretics or salt restriction, and pregnancy. Now coming to the confirmatory tests, once we have actually suspected and have had a screening test which is fairly positive, it is wise to refer to the endocrinologist or a hypertension specialist, where the most common tests done are an oral salt loading test over 3 days, after which the aldosterone levels are measured, or an IV saline challenge over 2 hours, after which the aldosterone levels are measured. The concept of this test being that you load with salt, aldosterone should actually reduce, but in this case, when there is an autonomous production of aldosterone, it will actually increase. There are other tests like fludrocortisone suppression test and captopril challenge test, which are quite difficult and challenging to perform. All patients where we have established the diagnosis of primary hyperaldosteronism and adrenal imaging is a must. And the test of choice for the primary aldosteronism subtyping is adrenal vein sampling and just not an imaging. Therefore, this needs a very expert center and a high level of expertise to perform these tests. And of course, if there is a high level of suspicion for the genetic components of PA, then it is better to perform this. Now, why in a medical conference am I talking about the surgical management? Well, if there are aldosterone producing adenomas, the best way to go about it is an laparoscopic adrenalectomy, and we have data to support this. We know that in comparison to just medical therapy alone versus an adrenalectomy, patients in the medical therapy group had higher risk of CKD, decreased GFR, and incident albuminuria. Medical management, the mainstay still remains spironolactone. It has a slow onset of action when compared to the other vasodilators. So how do we start this drug actually? Start at small doses, 12.5 to 25 milligram once a day. Test the blood pressure, creatinine, electrolytes in 4 to 8 weeks. Especially in patients with some amount of renal dysfunction, it's important to watch out for hyperkalemia. Increase by 25 to 50 milligram if tolerated, and indicated till 100 milligram, which can be given in once a day or twice a day doses. There are studies which have shown up to 400 milligram of spironolactone being used. Now, if the BP is low or continues to remain high, use the other drugs to titrate. This particular trial is extremely interesting. This is the Pathway 2 trial, which was published in the Lancet in 2015, where they compared spironolactone as an add-on drug when compared to placebo, bisoprolol, or doxazocin. And in this study, actually, the hyperaldosteronism group was excluded. In spite of that, aldosterone, the spironolactone performed extremely well and was a very good add-on drug as shown in this graph. So which again says that maybe we are missing out the subclinical hyperaldosteronism in our population. Of course, all drugs have side effects. In males, we can have gynecomastia and sexual dysfunction, which is very dose dependent. It takes weeks or months to develop, and it's around 30% at 100 milligram per day of aldosterone. And hyperkalemia is definitely one of the side effects of spironolactone. In women, they can have menstrual abnormalities, breast tenderness. It's very important to advise these patients to practice family planning when they are on aldactone, because it can be teratogenic to the male fetus. And of course, both the genders can have hyperkalemia. Now, what are the MRA alternatives that we have? Since it actually acts on the ENaC channel, we can use amiloride and triamtrene, and that's exactly what Pathway 2 trial did. And it had similar effects to spironolactone in the Pathway 2 trial, but we have no definite data on the clinical outcomes with these drugs. Coming to eplerenone. So whenever somebody does not tolerate spironolactone, we can use eplerenone. It's generally a twice daily dose. The simple conversion is like 50 milligram of spironolactone once a day is equivalent to 50 milligram twice a day of eplerenone. They say we can go up to 400 milligram per day, which is rarely done. It's quite an expensive drug. What are the clinical consequences of primary aldosteronism? And this is exactly why we need to diagnose it. It has a very high cardiovascular mortality, even in normotensive individuals. LVH, diastolic dysfunction, myocardial fibrosis, stroke, non-fatal MI, atrial fibrillation, metabolic syndrome, which also includes OSA, is highly described in patients with primary hyperaldosteronism. This is definitely a golden era in hyperaldosteronism. We know that there are many somatic mutations which occur in the ion channels. It's not always neoplastic. It doesn't always have to be an adenoma or a carcinoma. Morphologically, normal glands are always possible. We have gone beyond the current textbook definitions of hyperaldosteronism.
Madam Speaker, kindly wind up very late.
The resistant, moderate, and even non-hypertensives can present with this. The take-home messages are: have a low threshold to diagnose PHA. Screening tests have to be used sensibly. Refer to a higher center for confirmatory tests and diagnosis. Surgery if indicated and possible, and medical therapy with spironolactone or eplerenone. Thank you.
Thank you very much, Dr. Rajiv Alochana, for a brilliant expose on hyperaldosteronism. We have had a great session on various aspects of hypertension. And before I move on to the other chairpersons and the panelists, I have just one question. We have discussed hypertension in detail, which is probably the most common non-communicable disease. And unfortunately, a silent disease, silent killer. Most people don't know they have hypertension, and very few people who know it have good control of hypertension. So the onus is on us to make sure that we detect hypertension, create awareness about hypertension, and treat hypertension aggressively. My question to the speakers is, any one of the speakers is, we have talked a lot about adult hypertension. What I have noticed, and maybe some of you also have noticed, is in the pediatric practice, even adolescents who go through the pediatricians don't have their blood pressure checked. I see a lot of patients who later on come to us for various other diseases. But in general, there is no check on the blood pressure. There may be a check on the height, weight, so on and so forth. So would you want to have any comments on this?
Maybe Vaibhav can take this question because he's also a pediatrician by background and a nephrologist.
Am I audible?
Yeah.
Yes, Vaibhav, go on.
So this is a personal experience. Before COVID pandemic, we had a community outreach program in Mumbai, Thane, and Pune. So we screened about 2,500 kids in 8th and 9th standard for presence of hypertension. To our surprise, almost 7% of them had hypertension. And when we went back in 3 weeks' time and asked their permission, asked their parents and teachers' permission to check it again, hardly anyone was ready. So there was so many misconceptions. They went back to their GP and GP told, yeah, 110, 120 is normal for you. So to stress the point that the pediatric hypertension is underdiagnosed, there is a huge problem. 7% is a huge number. And we must screen these children, especially with newer, younger generation going with high salt diet. They are sedentary, they are obese. Screen time is very high, long. The incidence of hypertension is rising. There is no doubt about it. So I agree with you, sir.
Thank you. Over to the moderators, please.
Dr. Monga, do you have any comments, questions to take on before we go to audience questions?
Thank you so much for this brilliant series of talks. I think this is very pertinent to what's going on in the world with hypertension being and so prevalent and underdiagnosed. I feel I'm not sure about how available is, my question is ambulatory blood pressure monitoring in India, and how much do you practically and clinically do it? For us here, sometimes it's just difficult to get reimbursed or approved. So how often are people using in India? I would like to know that.
Yeah, that was also an audience question. So Karthik, go ahead.
Yeah. Here in India, like if we come across with any resistant hypertension or especially like if the patient is having uncontrolled hypertension with more than 4 drugs, then we used to, especially for our CKD patients, chronic kidney disease patients, like if they are uncontrolled, then we used to use ambulatory blood pressure. It is, I think, it is freely available in India, and most of the times we can get it. So in our hospital also we can we're using it very frequently. So I think like in US there is a lot of reimbursement issues which has been mentioned in many of the articles, which is not the problem here in India, I think.
It's quite cheap as well, and I guess even less than $25-30 we can get it done, and there are a lot of companies and hospitals offering them, so that's not an issue at all here.
Personally, I feel end of the day, pill burden, the amount of medications these patients are taking, and then, I don't want to say compliance, but also, if I have to take 10 medications a day, I don't know how much, we will take. So I think we have to have that empathy and insight towards our patients and try to, and that's where I think MRAs and all these medications come in picture, because they do target the mechanism. But thank you so much.
Okay, there were a lot of audience questions, and what I'm going to try and do is sort of combine the questions and give you a gist. So Aniket, for your talk, the overall gist of the questions was, A, how do you individualize for end organ damage, and do you treat? And B, do you treat patients at stage 1 hypertension, and if so, with what, and what should you look for?
So first of all, am I audible?
Yeah, go ahead.
So first of all newly diagnosed hypertensives need to be treated, need to be evaluated with history physical examination to detect the target organ damage and to find any clues for secondary hypertension. And the basic workup which all at the general practitioner level should be done is, as I mentioned in the slide, like CBC, urine analysis, creatinine, electrolytes, to find the clue for secondary hypertension, and also like blood sugar, lipid profile, ECG, to detect the target organ damage. And the drugs which are commonly used are ACE inhibitors, calcium channel blockers, diuretics, spironolactone, and beta blockers usually with any cardiac history, and clonidine usually later on.
Thanks. Karthik, there were some questions about how the home monitoring of blood pressure happens, and what is the frequency of that measurement that you should do?
So home blood pressure monitoring, usually the frequency should be at least morning 2 times with a 1 minute gap in each, and evening. So morning will be like before taking antihypertensive medications, and evening before going to bed. So totally 4 readings in a day, which has to be taken, and we have to take it for at least 7 days, which is ideal. Or if not for 7 days, at least for minimum 3 days, which is required. We can take for either consecutive days, or even non-consecutive is also provides valid data. So that is the thing. Like home BP, like again, the protocol should be followed. Like patient has to be properly seated, and they should not be in full bladder, and they should not take food or drink 30 minutes before that, and the arm position should be correct, and all these protocols which is followed in office blood pressure has to be followed when they are taking home blood pressure.
I think there was also a question to the same. What happens?
I have a question, if you permit me, Mr.
Before, and the impact of food on the blood pressure. So do you want to just?
So yeah, like intake of food can affect the blood pressure, because taking meals can divert your blood flow to the digestive tract, and this may affect the blood pressure. Because of that, there may be constriction of the vessels for compensation. So this may affect the blood pressure. So food intake should not be there at least 30 to 1 hour, 30 minutes to 1 hour before that.
Yeah, we should also add that if you're eating chips and burgers and having a high salt diet, then sometimes it can
and
actually
again
go up
yeah,
also, assuming that. Now,
yeah.
Vaibhav, I want you to take this question. The question is basically asking about whether isolated systolic or isolated diastolic hypertension is the important one. And which one, I mean, basically, does it affect the organs, the major, and increase the cardiovascular risk?
So I would say both the values are important. Historically, when we started, it was about diastolic blood pressure. As I showed, the initial trials were targeting diastolic blood pressure. But over the years, we knew that systolic blood pressure is as important. And recent trials like SPRINT show us the importance of systolic blood pressure. So both the values are important. At times, there are clinical scenarios where the diastolic blood pressure is very low with isolated systolic hypertension. At that time, the moment you start hammering down your systolic blood pressure, your diastolic blood pressure goes below 50, which is not acceptable. At that time, again, we have to think about the overall clinical scenario and manage the blood pressures accordingly. In young patients, we do see diastolic hypertension where systolics are not much of a problem, but diastolic hypertension is there. Like the guidelines say, and in our clinical experience also, we should strive to control the diastolic blood pressure, ideally below 80.
Yeah, so what essentially Dr. Vaibhav is saying is that in young age, you have diastolic hypertensions, and elderly, you have systolic hypertensions. And when you have a wide gap in between the systolic and diastolic, then you have to worry about not dropping the diastolic too low to compromise your coronary blood flow. Also, sometimes that could be a hint towards possibility of an aortic regurgitation, and maybe an auscultation can pick up an aortic regurg where a diastolics will be very low. Karthikeyan, there's a question about how do you weed out white coat hypertension and masked hypertension in your clinic? How do you suspect? Because they're asking, how do you know that the BP that you've taken is a right blood pressure and it is not a masked hypertension or a true white coat hypertension?
So, like most of the times, white coat hypertension, most of the times when we see in office blood pressure, it is usually always high. Usually when a patient comes to the clinic, when I used to check the blood pressure, it was like 180, 90. Then I'll ask whether you have taken antihypertensives today. Then they will tell, I checked just now at home that it was only 140, 90. Here only it has increased. So this is the conditions like where you have to suspect white coat hypertension or white coat effect, and we can detect it by doing home blood pressure monitoring or ambulatory blood pressure monitoring.
So we'll take the last question. Dr. Naresh Chawla has one question, please.
Since the focus today is mostly of nephrologists only, because we're talking of hypertension. Hello, as far as I know, that any physician or general practitioner or a family medicine specialist will always record blood pressure of his own, and he will never trust the automated, the so-called oscillometric method. Dr. Karthikeyan in his talk clearly said that to avoid the human error factor, we should be trusting more of the automated method. So what are your comments? I was already, if the 70% of the doctors all across India who are physicians, general practitioners, they always like to record their BP. Previously, the sphygmomanometer, the mercury manometer, the best, sent the aneroid, and now they're digital. And we still do not trust the so-called oscillometric or automated BP apparatus. Your comments, please.
So for even for my patients, like most of the times, I'll record the blood pressure again with the auscultatory method to confirm it. But what are most of the studies mention that unattended automated office blood pressure is recommended. So mostly like the ambulatory, because when if any staffs or healthcare providers is nearby, then again the issue of white coat effect, white coat hypertension, all these things will come. So maybe the unattended automatic office blood pressure. That's why most of the guidelines mention that unattended office blood pressure is recommended in most of the guidelines, and that may be like the reason.
I don't want to close this session before we take a few 2-3 questions from Rajiva, because a lot of questions have come on primary hyperaldo. If you see the chat box, just a quick 2-3 important basic physiology questions. Rajiva, can you tell us why is the renin low in primary aldosteronism? Why do we get metabolic alkalosis? And do we see hypernatremia? After these 3 questions, maybe you can answer the questions in the chat box, because there are very specific questions for you directed there.
So the first question being, why is renin low?
Yeah.
So basically, the renin and angiotensin systems basically regulate aldosterone. So what happens is, whenever there is dehydration, or there is a volume loss, or there is decreased perfusion to the kidney secretes renin, and which basically then converts angiotensinogen to angiotensin 1, which is then converted into angiotensin 2 from the enzyme present in the lung, which then acts on the zona glomerulosa in the adrenal cortex to produce aldosterone. So as a basic feedback mechanism, whenever there is high aldosterone, the renin should also be high. The renin should be low.
Okay. And why? What about metabolic alkalosis? And do we see hypernatremia also in these patients?
So as I mentioned, aldosterone has an effect on the H plus K plus ATPase channel in the distal and collecting ducts, where it causes loss of H plus ions, which is one of the causes of metabolic alkalosis in hyperaldosteronism. The sodium generally is not too high. They generally have a high normal sodium in hyperaldosteronism.
Okay, Rajiva, would you be kind enough to answer the questions in the chat box for the lack of time right now, because there are quite interesting questions there.
Sure,
and Sanjeev, if you could conclude the session, please.
I think we've done a great job with the last few questions. Thank you to all our chairpersons and speakers for making this such a successful panel. The audience interaction with the talks is an indication of how engaged our audience were and how useful your talks were. Thank you so much for attending.
Thank you so much. I would like to compliment it that even at around about 7:20 in the evening, we still have around about 2,000 people who are online watching us.
Wow.
So that explains to what content, what we are doing, right? So I would like to thank all the moderator chairpersons for this session. So this is the last session for today. So we start early in the morning by 9 o'clock. So I hope everybody is here back again. I would like to request Dr. R.N. Tandon sir to come on dais and give a memento to Dr. Naresh Chavla sir. In the meantime, there's a small announcement that dinner is already laid for those people who want to have dinner at the canteen on the 2nd floor. Under 10-15 minutes, we would be starting the banquet here. So anybody who's really hungry, wants to go back home early, can have dinner at the canteen. It's already laid down there on the 2nd floor. Otherwise, join us for drinks here. I would like to thank Dr. Manisha Dashi, especially to bear with us and be a chairperson on the dais. Thank you so much, ma'am.
Thanks to all of you. For all those who want to socialize and stay back for some time, we will welcome it. But for those who are in a hurry or are tired, they can go on the 2nd floor. The dinner is ready. Thank you.
We can have the lights on, please, so everybody can just ready for the banquet, right? Thank you so much, and we hope to see you back again at 9 in the morning. We have important surgical aspects which we will be covering: stones, UTIs, and transplant. So let's see you back again tomorrow morning. Thank you so much. Enjoy your dinner.